Hello. Hello. We are very sorry that we could not come on air exactly at 8:30 as we promised because there were some technical glitches. Anyway, so we are back on air, and to start with, a very good morning, and I would like to introduce someone who actually needs no introduction. He is sitting to my right, Dr. Shumanto De, our surgeon, and the most important person right now. So we have a small felicitation, and then he will start the surgery. A few words from Dr. De.
Thank you so much for the honor. I'm pretty excited. This is the first time I'll be demonstrating in a medical college, and we'll be starting with inguinal hernia. I'll be doing a laparoscopic TAPP procedure. So laparoscopic surgery, after laparoscopic cholecystectomy and appendectomy, which comes is laparoscopic hernioplasty. So this is the learning for our junior colleagues, the junior surgeons, is utmost important because the next coming few years, I think laparoscopic inguinal hernia repair or laparoscopic incisional hernia repair will be the standard of care, and this is very beneficial as for the patients also. So hope I will be giving some insights and can share some important tips and tricks with my fellow colleagues and junior surgeons so that they can start doing their own hernia practices and they can implement those techniques in their practices. Thank you so much.
So now, a few words about the patient. I will request Dr. Aparna, our senior resident, to please go through the details of the patient, the history, and the findings. Now the camera, I will request them to move over into the OT after we have talked about the patient, and surgeon will proceed to wash up.
A 22-year-old gentleman presenting with swelling in the right groin for the past 12 years, which was gradually increasing in size. The swelling is not associated with any pain and reduces completely on lying down and increases on coughing and straining. The patient is a student by occupation and has history of smoking. The patient does not have any comorbidities. The patient does not have any lower urinary tract infection symptoms. On examination, there is a 3 into 7 centimeter oblong inguinal swelling with expansile cuff impulse, which reduces completely on lying down. The diagnosis, uncomplicated right inguinal hernia, PL2. We plan on doing a trans-abdominal preperitoneal inguinal mesh hernioplasty.
So the camera moves on into the OT, and there the surgeon will be talking about the details of the procedure from the OT itself. ক্যামেরাটাকে শিফট করে দাও।
Check, check. Check, check, check.
ডিসিশন করছেন সেটা সবসময় শুনে নিচ্ছি। এবার ওটাকে অফ অন হয়ে আছে এখন, ওটাকে ক্লিক করলে পরে অফ হয়ে গেল।
আরে এখানে ক্যামেরাম্যান কই? দেখো
মাইক্রোশিল্ড দিবি, এটা গালিপড একটা মাইক্রোশিল্ড। হ্যাঁ হ্যাঁ হ্যাঁ, এখানে একটা পেতে দাও। ইয়া, থ্যাংক ইউ। কোথায় ফেলবো? Okay, okay. So good morning, everyone. So I'll be starting with a case with a 22-year-old male patient who presented with right inguinal swelling for last few years. And after initial evaluation, we have planned to do a laparoscopic right TAPP procedure for right inguinal hernia. So according to the EHS classification, it is USG report, it is supposed to be L2, but going inside we can see and decide and confirm our findings. So this patient is having no comorbidities and BMI will be around 22, and patient was catheterized, Foley's catheterized, and now he is being intubated. And so we proceed along with this procedure. We will be discussing the rest of the details. At present, patient is absolutely supine in position with right up is abducted and left limb is tucked by the side. Microshield. At a gauge piece, at a microshield. Microshield. That is microshield. Hand rub, hand rub, hand rub. Table নামিয়ে দাও, full down. So after induction, I will be requesting our anesthetist to turn the head towards the right and move the boils to the right side so that I can stand on the head inside and operate. Laga, 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 laga. শীত হলেই হতো, এটা তো হবে না। লাগা লাগা, মুছতে হবে, আগে মুছতে হবে। ভেজার মধ্যে লাগাবি? হ্যাঁ, এস রিট্রাক্টর লাগবে না, এটা ট্যাপ তো, ট্যাপে লাগবে না, টেপে লাগবে। আমি একটা রিট্রাক্টর এনেছি, পরের কেসে খুলে নেবো। ভিরিস নেওয়া আছে তো, ভিরিস টিরিস নেওয়া আছে, কাজ করে না। চলো লাগা 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 লাগা। সো এটা ভেতরে আছে তো, ওকে। একটু পেশেন্টটাকে উপরের দিকে টানতে হবে, একটু মাথায় মাথায় করে দিতে হবে, উপরের দিকে টেনে মাথায় মাথায় করে দাও। টানো টানো টানো, পুরো মাথায় মাথায়। হ্যাঁ হয়েছে, মাথায় মাথায় হয়েছে, আর একটু যাবে, আর একটু টানো, ব্যাস। না বেশি চলে এলো, আবার ঝুলে পড়েছে, ওদিক দিয়ে টানো, আর একটু ঝুলে পড়েছে। কাঁচি দে, কাঁচি 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 কাঁচি। হুম, ওটা সরবে তো, সরিয়ে দাও একটু, সরাও ডান দিকে সরাও। রেডি, স্টার্ট করি? কিচ্ছু করতে হবে। So I am starting with the case. So after general anesthesia, patient is absolutely in supine position and with left arm tucked by the side, right arm is abducted. And I will be, initially I will be standing on the left side of the patient while creating the pneumoperitoneum and putting the ports. Then I will be shifting towards the head end side. And then this is the first I will be creating pneumoperitoneum with Viris needle. So I am giving a small nick with a stab knife, just 2.5 centimeter, 1 inch above the umbilicus, Viris needle. I'll just ask you to focus here. এটাকে সরিয়ে নাও, তাহলে দেখতে হবে। So this is the head end side and this is the foot end side. So I have given a small nick over here, just 1 inch above the umbilicus. Viris, sir, Viris needle, Viris, 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 Viris. Sir, হ্যাঁ আমি দেখছি 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 কি বলছে ভিরিস ভিরিস নিডিল নেই নাকি স্যার স্যার do you have viris needle? They don't have viris needle. Ah, sir. ট্যাপ করবো তো মানে পুরো ভেতরে ঢুকে যাব ভিরিস পাবো না বললো আনতে গেছে হ্যাঁ হ্যাঁ আমার ইনস্ট্রুমেন্ট আছে আমার বললো আমি ভিরিসও নিয়ে আসতাম না আমি নিয়ে আসতাম মানে কিন্তু আমি যাই না আরে না না 30 ইয়েটা কাটিং লাগবে না আমার শুধু কোয়াক লাগলেই হবে হ্যাঁ হ্যাঁ 45 থাক দেখি বুঝে নিই তারপর সেই বুঝে চেঞ্জ করবে না কেউ কি আনছে ভিরিস
হ্যালো
ঠিক আছে আসছে So by the time I get a viris needle, I just introduce with me. So I have the privilege of having two good assistants with me. So Dr. Krishnendu is the senior resident here in NRS Medical College in Surgery Department, and Dr. Ornov is there in third year postgraduate students. On the anesthesia side, our Madam Dr. Orchana is there. Then who else is there? Dr. Navonita Roy, senior resident anesthetist. First year PGD, Dr. Anuprabha Basu, and who else is there? And I have my good friend with me, which is a good confidence, will give good confidence with me, Dr. Sudeep Das. We have done our MS post-graduation together at National Medical College. So it's like a mini reunion for us.
সুমন্ত
Sir.
গুড মর্নিং শোনা যাচ্ছে
হ্যাঁ শোনা যাচ্ছে বলুন
গুড your voice is very clearly audible.
Okay.
It's nice to be back to my half alma mater because I did my MS here from 1991 to 93.
Okay.
But we used to have our OT in Fraser Ward, ground floor.
Right.
এখন তো দেখছি নতুন বাড়ি একটু স্লো চল we'll just felicitate Sarfraz and then you can start.
Okay, sir. ক্যামেরা কভার আছে তো
Shumanto, the case you are going to operate is a right-sided inguinal hernia. Shumanto?
Sir, right-sided indirect inguinal hernia according to the clinical finding and USG report.
And you plan to do a TAPP?
TAPP repair, yes.
Okay. I mean, just before you start, needed to know what do you do about a bilateral inguinal hernia?
So usually for bilateral inguinal hernia, I do a TEP procedure.
Okay.
Bilateral lab, bilateral TEP procedure.
Okay.
30 degree.
And if the hernia are really large,
Yes.
would you consider doing a bilateral TAPP or an E-TEP?
Bilateral, considering if it is an indirect hernia, if it is an indirect large indirect hernia, then I would go for a TAPP repair. If it is large direct hernia, then I think hernia sac reduction will not be much difficult. So I will be doing a TEP repair only. So E-TEP usually I don't do for inguinal hernia repairs. For incisional hernia or different kinds of ventral hernia, I do E-TEP.
Okay.
But for inguinal hernias, I usually do TAPE or TAPP procedure.
Okay.
Camera ready कर फटाफट ready कर लगा light source लगी थी.
No, Sumanto,
हाँ yes sir.
the point I wanted to highlight was if you are tackling a large direct or an indirect hernia, particularly bilateral, you might actually be constrained with the space when you are doing a classical tape. In that case, I've got no problem with bilateral tap, but would you think E-TEP gives you a better space and a better view?
I don't think so, sir, because for bilateral tap, I usually use the triangulation technique, umbilical port and both pararectal position ports. So that gives me enough space to accommodate a good enough size mesh.
Okay, okay.
একটা গজ পিস একটা গজ পিস খোল খুলে বাদ বিরিজ পাওয়া গেছে থ্যাংক ইউ হ্যাঁ চল এখান দিয়ে বার কর বেঁধে দে একটাই ঠিক আছে না আমি করে দিচ্ছি ঠিক আছে সো উইল স্টার্ট বিরিজটা দে লাগবে না ধরতে হবে না গ্যাস 14 3-14 থাক আপাতত 14 করে দাও লাগাও স্টার্ট
Okay, Shumanto,
Yes,
now
sir.
you have got your very, so you can start.
Yeah, so I am starting with the pneumoperitoneum. I have kept a Viris needle inside, and then I am starting with pneumoperitoneum. I have kept the preset pressure at 14.
Okay.
And the preset flow is 3 liter per minute. And gradually it is, we can see the distension of the abdomen. So gradually it's the continuous flow of the gas and gradual increase in actual pressure will confirm that it is inside the peritoneal cavity only. So we'll be starting.
Shumanto, considering the fact this is mostly for the PGTs, we'll really stick to the very basics of all the procedures.
Sure.
So that they can learn. Do you have a catheter in or not?
Yeah, catheter is already there. The police catheter is already there.
Okay. Shumanto,
Sir.
we'll just switch your audio off for a couple of minutes.
Sure.
We have Dr. Sarfraz Zalil Beg here,
Sure.
who is a very dear friend of mine, and he's also one of the operating faculties.
Sharp.
So we'll just felicitate him here and then come back to you.
Yes. Flow rate 20 করে দাও
Hello. Now we have Dr. Sarfraz Jalil Beg with us. So he will soon be operating on the in the OT2, and he's going to start off with an incisional hernia. So before that, a small felicitation to Dr. Beg on behalf of the organizing committee.
So দেখতে পাচ্ছি এটা একটা right indirect hernia. You can see it's a right indirect defect. Okay.
Okay, we'll get back
Okay.
to the operating area again. Thank you, Sarfraz, for being here.
Head down, please. Head down.
Okay, Shumanto, we are back with you. Can you hear us?
Yes, sir.
Okay.
So I have inserted the 10 millimeter trocar, and after going inside, right after putting the camera, you have to need to see the right beneath the port, whether during insertion of the first trocar there is any inadvertent injury to the omentum or stomach or nothing. So there is apparently no trauma to the any other structure. Then after that, you can head down. Bas that. Okay, fine. Right side up a bit. Right side up. So after going inside, you can see the initial finding. So this is the right groin. This is the left groin. You can see the left groin is absolutely normal. But while coming onto the right groin, you can see right groin. You can see there is a defect around 2 centimeter size defect on the right groin. And if you see the inferior epigastric vessel, this is the inferior inferior epigastric vessel, and it is on the lateral aspect of the inferior epigastric vessel. So it's an indirect defect. And considering the other anatomy, you can see the vast difference here. The bluish structure is the external iliac vein. By the side, it's external iliac artery. And in front of external iliac artery, this is the gonadal vessels. Okay, so this is the lateral linguinal groin space, and this is the medial. The bladder is already empty because of catheterization. So then after seeing all the findings, then I'll put the working ports.
Okay.
So this is the,
very good morning. Hello.
yes.
Hi, very good morning, Ramanuj here. It was a
Hey,
good,
yes, sir.
Right. Very good morning, good entry into and a safe entry.
Sec-
Shumanta, to begin with, as there are many residents, can you show the midline or the median ligament? Because that is
So
the
this is the
line-
midline.
Right.
So you can see the both the medial umbilical ligament,
Mhm.
and in between there will be median umbilical fold. So the median umbilical fold in this case is not very prominent, but this is the this.
Mhm.
And if you follow this is the dome of the bladder. So this is the dome of the bladder, you can see, and it is completely empty. So this is the midline, and then these are the left and right medial umbilical fold, and then the inferior epigastric vessel you can see. So actually the inferior epigastric arteries forms the lateral umbilical fold.
Right.
So I'll be starting with the port placement. So my first right hand working port will be at the level of the umbilicus in a pararectal position. So it will be a 5 millimeter port. 5 millimeter.
Shumanto,
Sir,
what is the position of the patient?
just দেখা নিচে কর ক্যামেরাটা নিচে কর.
Shumanto,
Yes, I'll be,
position of patient?
yeah, position is right pararectal position at the level of the umbilicus.
No, position of the patient.
Position of the patient is absolutely supine,
Okay.
with left arm tucked by the side, right arm is abducted 90 degree, and then the head end 30 degree head down with
Okay.
little
Yeah.
bit right up, because
That-
I'll be
yeah,
operating on the
that-
right
that's,
side.
That's the part I wanted to know. Head down and right up when you are
Yes.
operating on the right side.
Yes. And
And
then
head
the
down and
next,
left
if you
up.
see the external camera position, then I'll be putting the left hand working port a bit down, that is 4 centimeter lateral and down to the level of the umbilicus, so that I can maintain a triangulation of ports. I'll be standing on the left shoulder. So I'll be maintaining a left hand triangulation towards the area of surgery. So this will be my left hand working port, more towards the midline compared to right port.
Shumanta, what is the usual pressure that you have in the
I
pneumoperitoneum?
keep the pneumo pressure at 14
Right.
and flow rate will be 20.
No, because you see, this is a new space that you are making. So there are concerns about more of carbon dioxide getting absorbed. Right, so that's a good.
So now I'm changing the gas inlet left hand working port. এটা খুলছে না রে বোঝো আরে এটা খুলছে না তো
Hello. Yeah, Sumanto, this is Professor Utpalde here.
Yes sir.
I have seen some surgeons, they put the ports right just parallel to the midline, both the ports. So what do you recommend?
Sir,
Do you
can you
feel
just
that-
can you just a bit louder? I cannot hear you properly, sir.
Hello?
Yes sir. Tell
Yeah.
me.
I've seen some surgeons put the ports parallel to the midline on the same side. What do you have to say
Okay,
about
so
that?
they usually do the camera on camera person will be on the other side, and the right and left hand working port will be on the other side. So that is basically I am not used to this kind of lot of surgeons usually do with this approach. Okay, but usually I find it very difficult for me because I usually am trained with this triangulation technique.
I think, I agree with you, Shumanto. This is the standard technique of a TAPP. You need to have a good triangulation. The only thing is, the 5 millimeter ports are not fixed. Okay, once you have the view with the 10 millimeter telescope, you decide on the location of the 5 millimeter ports. And be careful because you are under vision. So be careful when you put the 5 millimeter ports, because if you are too medial, then sometimes you can cause inadvertent injury to the inferior gastric artery.
Yeah, so that was what I was wanting to ask you, because you see, entry into the lateral border of the rectus sometimes can be a bit tricky, because we have had patients in whom the epigastric artery has been injured. That produces a bad hematoma. Okay, Shumanto, well, the ports are in. How do you select your patients for a TAPP versus TAPE?
So when the ports are in, you have to do TAPP only because
No. You are doing TAPP only, but before selecting the patients for a TAPP versus a TAPE, any particular recommendations for junior people to begin with?
এটাও করছে না নাকি? না, ঠিক আছে। So usually my preference is to do TEP repair, and for there are certain indications for TAPP repair. In case it's a large hernia or a complete left hand ইয়ে দে আমার ইনস্ট্রুমেন্ট গুলো কোথায়? These are not my instruments. So for complete hernia, reducible hernia, the obstructional hernia where I'm planning to do for this to do TAPP procedure. Otherwise, bilateral direct hernia or unilateral direct, unilateral, small unilateral indirect hernia, I do TEP repair. At a hook, hook. আচ্ছা ওই ডায়াথামি ফ্লুট প্লেটটা আমার ডান পায়ে দাও
OT2.
এখানে
Okay, can you have the audio from the OT2? I think Shumanto will just keep you in the frame, but we'll keep your audio muted for a minute. Dr. Sarfaraz Beg will start the OT on the other side. Yes, Dr. Beg, please. Very good morning. Can I have the audio from the OT2, please? OT2, audio, please. On the other side, ladies and gentlemen, we are starting with an ventral hernia laparoscopic repair. Dr. Sarfaraz Beg is going to start with that. Okay. Dr. Sarfaraz Beg, are we audible?
Yeah, you are audible.
Very good morning.
Good morning, Ramanul. Good morning, Sandeep.
Okay.
So,
Right.
Let me just give you a brief idea about this patient. Middle-aged female, no comorbidities. She has got a right iliac fossa hernia. We would say M5L3 as per EHS classification. And this is a diameter of about 6 centimeters on clinical exam.
We don't have a view of the abdomen, so can the
Okay,
cameraman
can somebody
focus
give
on
a view? We will give you the laparoscopic picture. Is this okay?
Yeah, now we
Focus
have
karo.
more or less a better view. Yes.
So I marked the abdomen so that you can see this. Okay?
Okay. Can you again repeat the site of the hernia?
Yeah, so let me show you once more.
Yeah.
Now, this is the xiphoid. Yeah, it's okay, just stay there. This is the pubis.
Okay.
This is the umbilicus.
Right.
This is the left side, right side.
Right.
This is the hernia on the right end of the Fannin steel incision after a gynecologic surgery. It is 6 centimeters. It is encroaching beyond the linea, therefore it is L3, but primarily M5. What do you mean by M5? Within 3 centimeters from the symphysis pubis. So M5 and L3.
Okay.
MW2 because it is more than 4 centimeters. Okay?
Yeah.
That is the classification.
Now, what was the pre-operative CT like?
The
Was there
CT
any
corroborates with the clinical finding. It is a M3, it is a M5 L3 W2.
Okay.
It corroborates with it with us.
Right. So because by the time we are getting the ports ready,
Yes.
do you have the CT in view? Because by the time then our audience will
So
also like,
yes, what I will do is I'll ask Udevda
Right.
that you have the CT scan, then you can put it in the view box, and in the view box you can all see the CT scan and have an idea.
Okay.
And meanwhile, what I'm going to do, I am going to give you a brief idea about what we are going to do, because for many of you this may be a surgery that you are seeing for the first time. Therefore, I would like to just give a brief up in about 3 minutes what we are going to do. I'm going to make a port in the left subcostal, then one in the right subcostal, a 10 millimeter ports on 2 sides, and I am going to build both these spaces with a balloon which you will create with finger gloves. How will we reach there? We'll use retractors, artery forceps, diathermy to make an incision, cut the anterectus sheath, split the rectus muscle, medial to the linea seminaris. I've already marked the linea seminaris. Linea seminaris is never ever be less than 7 centimeters, so at least 7 centimeters. It would be 8, 9, 10, 11, 12, whatever, but it will never be less than 7. So we will make an incision here, keeping that in mind not to injure linea seminaris. Once we enter the retrorectus space, we will see a shiny posterior rectus sheath, and we will keep these retractors in those spaces and put in a balloon and create a space here. Similar thing on the right side.
So that means, Dr. Beg, you are basically trying to do an E-TEP
Correct.
in which we are entering a space not below the umbilicus, but above the umbilicus, and then we encroach a space below the umbilicus in
Correct.
the preperitoneal plane.
Correct.
Right.
So just one thing, Ramanuj, for the sake of understanding, whenever we say E-TEP, it is very confusing. The
Right.
world is having a problem with that nomenclature, although that is the original description. Endoscopic reef stopper. This is what we are planning to do.
Right, that is probably a better terminology,
Yeah.
because in this confusing world about terminologies in AWR, right, this
Yes.
is a much better terminology.
Yeah.
An endoscopic this. But tell
So-
me one important thing, that if the peritoneum, because as there is a scar in the abdomen,
Yeah,
while making this preperitoneal plane,
yeah.
don't you find any peritoneal or any scar adhesions with the peritoneum being attached being a problem for creating the space?
You are absolutely right. So let me just say that whether you go intraperitoneal or extraperitoneal, even in endoscopic reef stopper, you get intraperitoneal at some point of time. Adhesions encountering and the technical strategy would be similar. It wouldn't be different in the two cases. However, an extraperitoneal repair helps in a few ways. A, no fixation or minimal fixation, relatively painless. More robust repair because it is in between 2 layers, so more mesh incorporation. I can do this intraperitoneally. I can go into the abdomen first, and then just like what Shumanta is showing a TAPP approach, we can also tackle this hernia similarly. But this will not convey the message to the audience that there are many ways of doing the same surgery, and there are certain advantages of each, whether you do TEP or TAPP for groin. There are some plus and minus. Similarly here, there are some plus and there are some minus. I would say this is a more difficult procedure. A TAPP, a TAPE, all are a simpler procedure to do these kind of hernias. I am showing an E-TEP because I think the house needs to get acquainted with these endoscopic repairs of ventral hernia, which are coming up in a bigger and bigger manner. So if you look at in the last 7-8 years, in the report by Cockerling, they have shown that in Europe and USA, the number of extraperitoneal repairs endoscopically have increased. Of course, in open it has increased, but in the endoscopic world also, it has increased. So let us see this.
Right.
Yeah, absolutely agreed, Sarfraz. I mean, certainly one thing, one message to the postgraduates. I mean, if the hernia defect is more than 5 centimeters in size, you certainly don't do an IPOM plus.
Yeah.
Okay, that's the take-home message, because this is a 6 centimeter defect, as you said. I mean, the other option would have been a TAPP plus, but obviously E-TEP RS is certainly a better option if you are able to do it.
True. And whenever we look at any hernia close to any bony structure, extraperitoneal repair is better, because you cannot possibly do a IPOM close to a bone. For example,
Absolutely.
subxiphoid, subcostal,
Yeah.
close to the anterocephalic spine, close
Absolutely.
to the pubic
Absolutely.
bone. So,
And the other thing trainees need to keep in mind is the cost involved in a dual mesh and the tackers. Okay, so in our country, which is economically quite compromised, I mean, using 30,000 rupees dual mesh and a 25,000, 30,000 rupees stacker, every patient may not be able to afford it. So you need to know the techniques where you use a conventional polypropylene mesh and use the minimum number of tackers, or don't use tackers at all, you depend on sutures.
थोड़ा deep लगेगा, retractor. See?
Okay, by that time, Dr. Beg, you are dissecting the planes. Okay, so we'll go back to Sumanto, and then just we'll keep your audio muted. Okay, can you have the audio from OT1?
Hello.
Sumanto, we are back.
Right. Am I audible?
Yeah, you are audible, and you have
Right.
very beautifully created a flap, the peritoneal flap.
Right. I'm just creating the flap. So I have
Maje we are getting an ICG picture.
right. So what I'm starting,
Yeah.
I've started the incision line.
Sumanto,
that is-
can you just show us with apposition of the peritoneum that where did you start and how long do you plan to raise the
right.
flap?
So this is the upper border of the defect. Considering the upper border of the
we
defect
have that ICC
coming
picture with us.
proximally at least 3 to 4 centimeter proximal, I have given an incision starting from anterior superior iliac spine, to the median.
Right, can the camera operator go a little back so that we can have a better view? Yeah. This is
medial
better.
umbilical fold. So this will be a inverted J-shaped incision.
Right.
So then just the peritoneum, but you have to lift the posterior layer of the fascia transversalis along with the peritoneum so that it becomes a thin, thick flap.
Okay.
Otherwise, just the peritoneum will make the peritoneum during the process of dissection, and it will be very difficult to manage. So you can see the inferior epigastric vessel.
Right.
Inferior epigastric vessel should always lie
So
along with the
can the camera operator zoom in a bit, please? Because this is a very critical thing that you are showing. Because for the beginner, so I think that Dr. Sumanto has made a very important statement that the posterior layer of the fascia transversalis comes with the peritoneal flap. So Sumanto very well demonstrated.
Right. So I'm just creating the space lateral to the inferior epigastric vessel. My idea is I have created a little space on the lateral groin area. You can see. Yeah. So this is the lateral groin space that I have created a bit. This psoas muscle will be here. So this will be the proposed area of psoas muscle, and there will be a fascia covering it. You can see, you can appreciate there is a fascia covering the psoas muscle. This is dulux fat or dulux fascia. So
Right.
this fascia is actually covering all the nerves, lateral groin nerves like femoral nerve, lateral femoral cutaneous nerve. These nerves are usually covered by this fascia.
Right.
So this should not be disturbed, and this you have to differentiate between the fat, between the preperitoneal. This is the preperitoneal fat, and this is the dulux fat and fascia. So you have to differentiate between the two and go in between these two planes. So you can see I am just pushing it with my hook and just following the loose areolar tissue plane towards the defect and aste.
Right. Very beautiful demonstration, Sumanto.
Again come here, laterally. অত কাছে just.
Shumanto, just a point, because now that it's a primary hernia, in a case of a recurrence on this side, say particularly an
So
open
you can see,
repair,
just want to demonstrate one important structure. You come here, come close. You can see the nerve over there.
right?
So these are all lateral femoral cutaneous nerve, femoral nerve. These are all nerve fibers will be going over the psoas muscle.
Absolutely.
So use of cautery over there should be very cautiously used, because inadvertent injury to the nerve can cause post-operative pain.
Right, you are technically in the triangle of pain.
Yes, triangle of pain. You can see one more nerve here.
Absolutely. That is probably
So
the lateral
there is a
femoral
clear
cutaneous.
layer of a fascia which is covering this fat. This should not be exposed.
Yeah, I think the first one you showed was the femoral branch of genitofemoral nerve.
Branch of genitofemoral
And
nerve.
the second one you showed was the lateral cutaneous nerve of the thigh.
Right.
And it's better not to see them actually.
Yeah, it is
come
better
medial.
not to see these nerves.
Because usually it is not seen, because
Yeah.
this guy is a lean, thin guy.
Absolutely.
So this lateral fat is less, so that you can see only the fascial layer which is covering the nerve. Otherwise, there will be Dulux fat. This fat will be lying over here and
Right.
covering all the structures.
Shumanto, I'll just take a minute to thank our anesthesiology colleagues, without whom we obviously cannot do this surgical workshop. So on behalf of the organizing committee at NRS Medical College and the chapter of West Bengal chapter of Association of Surgeons of India, I would like to thank the senior anesthetists, Dr. Dipankar Mukherjee,
Amar Maryland.
Dr. Archana Roy, Dr. Mrityunjoy Misro, assisted by another
Maryland.
fantastic
Amar-
team comprising of Dr. Nobonita Roy, Dr. Mohima Prasad De,
Amar Maryland টা খুলেছো?
Dr. Oruprabho
Maryland.
Basu, Dr. Obhinav Barma, Dr. Modhumita Ghosh, Dr. Obhipsha Sarkar, Dr. Shreyoshi
এটা না, এটা-
Mukherjee, Dr. Shaunik Choudhury, Dr. Orunangshu Pal, Dr. Saurabh Naga.
Maryland
Thanks you
তলায় আছে।
once again, friends and colleagues, for your
পাঁচটা।
fantastic support to this surgical workshop.
So, Shumanto, very well
Oh, এখানে আছে,
demonstrated.
এখানে আছে, এখানে আছে।
Shumanto, now, as you are saying,
Right.
medially, how long do you plan to carry the incision? On a
So
medial
medially
side?
up to the medial umbilical fold. So I have given, this is the right medial umbilical fold. You can see I have given the incision till here.
Okay.
Okay, then I will be, hi kache.
So that means the message is that you need not cross the midline.
Usually
You need to
not
stay
required.
on one side.
Usually it is not required, right?
So, what is your instrument that you usually prefer in this dissection?
So initially you have seen that I was dissecting with the hook.
Yeah.
Once I have created enough space over there, then I have changed my instrument to Maryland forceps. And now I'll be pushing the inferior epigastric up, and we'll try to create some space over there.
Right.
Medially.
Now, regarding energy sources, Shumanto, we have seen some surgeons use an ultrasonic dissectors. Your take on that in this place?
So ultrasonic dissector usually ultrasonic dissector usually in hernia, inguinal hernia repair is not required until it's a complicated hernia, obstructed hernia, where you need the better energy device for hemostasis. Otherwise, if you follow this loose areolar tissue plane, it will be a usually you will encounter this kind of small blood vessels which can be easily controlled by monopolar energy.
So, no, so that's, I think, a very important thing, because in resource limited setups,
Yes.
using with a monopolar can really work wonders if you follow the safety principles. Right. Shumanto, again, on this technical note, with a dissecting with a scissors with monopolar, what is your take on that? Laparoscopic scissors with a monopolar?
I'm used to dissect with Maryland forceps.
Right.
So I'm doing that only. সরে একটু আমার ইনস্ট্রুমেন্টের দিকে সরা, তাহলে ইনস্ট্রুমেন্ট ক্ল্যাশ করবে না। হ্যাঁ। So you can
Beautiful dissection, Shumanto. Brilliant dissection.
see, right. So you can see I'm gradually trying to create the space of red. So you can see the loose areolar tissue plane clearly, and these are this is the plane actually you need to follow. You need not to go into the fat, need not to go into the muscle layer. Just follow the loose areolar tissue plane. There will be comparatively this will be a bloodless plane of dissection, and you may encounter small blood vessels which can be easily cauterized. So this is the right rectus, underneath of the right rectus muscle you can see, and gradually I am just pushing this medial umbilical fold, peritoneal flap, to create some medial space. And my next target will be to identify the I'll just, my next target will be my next target will be to see and identify the pubic tubercle, the bony area, and suddenly in this area you will see a whitey structure which you will encounter, which is
The
known as
lighthouse.
the lighthouse sign, yes.
Right. Shumanto, in recurrent hernias, as you are planning a laparoscopic repair, okay, so do you find any problems in creating this space?
See, if the recurrent hernia recurrence is after open repair, usually this plane is not violated. So this will be technically easier. If the recurrence is after laparoscopic repair, then this plane will be already violated. It's better to go ahead with the open repair.
Right. I
So
think
you can
you
see
have
the
the
bony,
lighthouse.
you can see the bony area. This is the lighthouse sign. This is actually pubic arch. So this is one landmark that I have achieved, and then I will proceed further to enlarge this space of Regius. So this is the area of urinary bladder, and this is the pubic bone. This is the anterior rectus, posterior surface of the right rectus muscle. So I will try to enlarge the space over there.
Right.
So that I can create the space of Regius. পিছনে এখানে দেখা
Shumanto, how inferiorly do you dissect once you have found the symphysis?
Guideline says you have to go 2 centimeter below the pubic bone.
Right.
So that should be followed to place an adequate size of mesh, because all the পিছনে সরে একটু ডান দিকে ডাউন করে দে, ডান দিকে ডাউন পুরো ডাউন, right. So the idea is to create that much of space so that so either you can place good enough size mesh to cover all the potential hernia sites, actually to cover the myopectineal orifice as a whole. So you can see the right rectus muscle, and now this is the midline. I have crossed the midline. This is the undersurface of the left rectus muscle.
Absolutely.
So I have crossed the midline a bit, and then once I have created good amount of space here, again I will come towards the area of hernial area. একটু বাদিকে দেখা, বাদিক, left, right. Bas, okay. So these are the, you can see with my left hand instrument, I am just depressing the flap, pulling it down, and just trying to identify what are the structures that is actually holding. You can see these are the some fibers.
Right. Shumanto, while you continue your brilliant dissection, we go to the other side. We will keep you in the view.
Sure.
Okay, thank you.
Sure.
Audio to the OT2, please.
Sarfraz, can you hear us?
Hello, OT2, Dr. Sarfaraz Bey, can you hear us? Hi. That means, right. Okay. Right. Yes, we can. Right.
I will build this page with a code. I'm waiting for a rhythm to come so that I can take one more code inside, and I will because your hook, I will create this entire space.
So that means you are using a finger gloves as a balloon, and then you are creating the space.
Sorry?
You are using a finger gloves or a gloves as a balloon, I hope.
Yeah. We use the glove, 8-number gloves as a balloon. So I know this will not be easy. As you understand, I think both of you are, experienced people to realize this is not an easy surgery to understand, but it is something that everybody has to be sensitized to.
No,
And
absolutely,
we
because
decided that at least one case let us do groin. And the other incisional hernia, instead of IPOM, which is something everybody would probably be aware of, let us do something which is a little new and something which is coming up.
No, I think, you see, Reeves Topa has now technically come up a full circle now.
Yeah.
It was started around in 1950s. It was criticized because people felt that the dissection was very cumbersome because of the access that people had in creating the preperitoneal space, particularly the lateral extent. Because we were trained in doing an open Reeves Topa. That was really technical. Particularly, I had a lot of seromas and midline dehiscences. Now with this endoscopic Reeves Topa, definitely the initial part of gaining access is difficult. But once you are in the preperitoneal plane, like you have, I think that it's just a time about patience and continuing with your principles, right?
True. A lot about patience.
Lot of patience in that. Okay, I think we'll again go back to the other side, OT.
Yeah.
Sarfaraza,
Give me some time to create
Right.
well,
We'll keep you in the
so
half
that
of the screen.
I can show you well.
Right. Okay, the audio to the OT one.
नहीं, जो कर रहे हैं ना, you
करो,
have to
head down
know
करो, करो, बस
this
बस बस,
is your-
press করে দেখতে হবে, এ দেখ, তুই আয়, অনিন্দ, so তুই এইখানে একটুখানি, এ দেখ, ওদিকে তাকা, এখানে একটু press করবি, so the sac will come inside a bit, okay? So the air, amount of air which I am putting inside, it is pushing the sac outside, ঠিক আছে?
Okay, Shumanto, brilliant dissection.
Thank you, sir.
We were all discussing the thickness of the peritoneal flap, and this is what experience is. You have an ideal thickness of the peritoneal flap. Now I think you are into the hernial sac or the pseudo sac?
Yes, I am just trying to reduce the hernial sac now because I have created medial space, the space of radius. You can see this is the midline, this is the symphysis pubis. I have crossed to the opposite side.
Right.
And on the lateral aspect, I have already dissected. So I will now target the sac. And before that, we can divide this small loose areolar tissue strands so that.
Sumanto, just a technical query, because the epigastric artery is always the danger that lurks in for the surgeon.
Yes.
So what are your tips in avoiding particularly the branches to the vas and those cumbersome cremasteric branches from the epigastric artery?
So from the beginning only, after going inside only, you have to see where the sac is, where the inferior epigastric artery is lying. And then you have to be very cautious while raising the flap so that inadvertent energy application can can injure the this thing, inferior epigastric vessel, and there will be bleeding which can be very difficult to control.
No, particularly you are in the triangle of doom, and that area is
yes
very dangerous now.
পেছনে সরে হ্যাঁ হ্যাঁ সরে একটু পেছনে সোজা কর ক্যামেরাটা সোজা হ্যাঁ এসো এদিকে এসো এইভাবে দেখাবি এইদিকে আর এইভাবে দেখাবি ঠিক আছে এইভাবে রাখ সোজা এই হ্যাঁ দেখা সরে পেছনে কেবিল আপ কর কেবিল আপ হ্যাঁ So I'm just sticking by the
right. I think
sac.
by the time you
trying
go on
to separate
dissecting
the
the
cord
pseudo sac.
structures.
Right. So we go to the audio with an OT2. Okay, OT2 please. Dr. Beg, we are back with you.
Yeah. So the reason why I did not want to do this was, can you see this rent here?
Right. I think you are in the peritoneal cavity.
Yeah. So I converted this immediately. This was a retrorectus space we were creating.
Right.
And very close to that, we made a hole, I think. So that was the hole. It made intraperitoneal. So I decided, this is very common with doing an E-TEP repairs, And once we see, एक वो दो ना, सलीम, हबीब, हमको एक मैरीलैंड चाहिए, हुक चाहिए, इधर आ जाओ ना. Then what we did was we converted this immediately. We have made 2 pararectal ports, and this is the, one second, Mita. And this is the addition of the midline. Let me just take you through. That is the hernia at M3, M5L3. Okay?
Okay.
We will measure whether it is 6 centimeters or not later. That is the bladder balloon.
Can you show us the symphysis by a finger pressure?
Yeah, that will be the symphysis, below which is the bladder balloon, Foley's balloon. This is the midline. We must make sure that we understand this is the midline.
Right.
This ligament is the midline. Can you give me a Maryland in this hand? घुसा देंगे please? अगर नहीं घुस रहा तो शायद वो बाहर निकल आया आपका. एक second. Give it to me. Give it to me. This has come out. एक लोग थ्रो कर दो बेटा. इसको अंदर घुसा कर रखना पड़ेगा. When you are inserting anything, make sure that you are not pulling it. ये इसका नहीं है trocar. This trocar doesn't belong to this camera.
Okay. Now, Dr. Beg, so what is the change in the plan that we have now?
So the plan is to do a TARM. We'll still do extraperitoneal repair. So when we have a bailout option,
Right.
the bailout option of any E-TEP is a TARM. If we
Right.
didn't have this, we would have continued with the space creation this side, that side, crossed over and shown you. Now what I will do is I'll do a TARM. So I've got 2 pararectal ports. Let me show you this from outside. इसको बाहर करो. Savlando. Now can you see this? So I am going to give you an external picture because I want people to realize. छोड़ दो ना, पीछे हटाना ना. So that is the xiphoid again, xiphoid. I have made a camera port between the xiphoid and the umbilicus. 1 pararectal port, another pararectal port.
Okay. Which side is the hernia? I think
The hernia is here,
on this side.
phalansteal right side.
So that means you are standing on the head end of the patient.
I am standing on the head end of the patient. There's a Ryle's tube, there's a Foley's catheter. The patient is having a head down position.
Right.
And we have a pressure of 15 millimeters of mercury. And we are entering into this abdomen. You
Absolutely.
can see this adhesion at the top. We'll take it down. Hold this please, Rishabh. Idhar aaiye. Nahin, idhar aaiye.
Now, while taking down adhesions, like these omental adhesions, how do you safely take them down? Because this is a problem that every surgeon has to face.
So when you're doing an intraperitoneal surgery, the first thing to identify, udhar dekhiye aap. The first thing to identify is whether you're dealing with bowel. Here you can see that you're not dealing with bowel. So you can use your energy source. Whenever you see bowel, use a scissor. Try to stay in the interface. What do you mean by interface? That is the peritoneum. And whenever you tease the structures, you will see an interface. If you find that there is a bowel and you still think that you may...
Can the camera person please zoom in a bit, please?
Come in a little bit.
Brilliant.
So this is a beautiful vision system by Carl Stoes. And it's 4K. So I hope you are getting a good picture. Now you can see why we had a problem. Can you see that the retrorectus is deficient here? Ramanuj, can you see this? Hello?
Hello, hi.
Yeah, can you see this is
Yeah,
a
we
deficient
can,
area?
we can.
So if the retrorectus is deficient because of your previous surgery, then you cannot do an E-TEP. That's a relative contraindication of doing an E-TEP. But sometimes you will get away, many times you will not. You have to be prepared for switching over your surgery. Just like in groin hernia, when you're doing a TEP and you have a hole, then what do?
Definitely.
Yeah.
You should always have a plan B.
You have a plan B. So here you are. In case this was bowel, we will keep the posterior rectus sheath with the bowel rather than the bowel with the posterior rectus sheath.
Absolutely. This is what I tell my residents. So these golden words will always stay.
Yeah.
The
So that
posterior
is
rectus
brought
sheath.
down the momentum only. Now you can see there is bowel here. Right, there's a sigmoid there.
Can you zoom in a bit, please?
Yeah, can you zoom in a little?
Right. You can see the bowel.
Now what we do is, I can come back with a scissor, or the ligosure gives me an opportunity of only using the scissor. Can you see that?
Can you zoom in a bit, please? Okay. Can you zoom in?
Okay, so the ligosure gives me the opportunity of only using it as scissor. And I will show you multiple times how you can use this without changing instruments. So your time is saved.
No, the brilliancy of this bipolar or the sealing devices is that the lateral thermal damage is around only 2 millimeter. So
Ramanuj, your voice is very low. Speak a little louder, please.
the beauty about this bipolar sealing devices or energy devices is that the lateral thermal damage is very low, 2 millimeter only. So that is probably the beauty of this. So rather than using a monopolar,
Yeah,
you
agree.
can.
Agree. So the lateral spread with a monopolar cautery will be high,
Right.
and with a bipolar it will be low. So I'm just doing this for no reason. This is not going to interfere with our.
Now, once the additions are down,
Yeah.
do you feel there is a gap in the midline?
So there is no gap in the midline. There's a deficient posterior rectus sheath, and there is one small tiny hole. Can you see that?
Yeah. Can the cameraman zoom in a bit, please? Yes.
I think you can see the yellow pad of fat.
Yes,
there.
yes, yes.
Yeah,
we can,
that's a
we can, we
subcutaneous
can,
tissue,
we
so
can.
that has to be a hernia.
Looks
when
like
we
a
are
Swiss
not
cheese
going-
now.
When you're going to write the operative note, we must write M5W2, and you also must write M4W1. Okay? So just to tell the juniors that when you're writing the report, that's how you should write. Now I'm going to do the term. What does it mean? Transabdominal retromuscular approach. Okay? So you can do a TAPP or a TAM. Now, Sumanta is doing a TAPP. You can start doing TAPP when you're doing from here at this level, okay, which is a level between the umbilicus and the pubis, because then the posterior rectus sheath becomes deficient. But when you're above this line, that's the arcuate line, you will get a posterior rectus sheath, in which case you will have to do TAM. मेरे पाँव में वो दे दो ना diathermy please. मेरे पाँव में diathermy दे दीजिए और ये हटा दीजिए ना garbage वाला please. ये बाल्टी हटा दीजिए ना. Thank you. So, I am going to score it for you.
Okay, so Dr. Beck, can you again repeat that point? Because I think that is an important point that needs to be decided, whether you are going for an E-TEP or a TAR or a TAPP.
Yes, I'll repeat that again.
Right.
So, if I were to do a hernia which is lower down here, that's the groin hernia. That is where you will have a groin hernia. Then TAPP is enough because you will have to reflect from here. You want at least 5 centimeters overlap of the mesh from the defect, so this is enough. But when the defect is in the entry abdominal wall, like an M5, then you cannot start from here, right? Because this will be only a 3 centimeter mesh overlap.
Right.
You have to come back till 5 to 7 centimeters, which is here. Therefore, if you start doing operation here, you can reflect the peritoneum if it is possible, but more often than not, you will be able to get into the retrorectus space more easily than the pre-peritoneal space. Therefore, this patient will generally land up with a TAPP.
Right. I think so that is
Did
a
I
very
make myself
important
clear?
statement that you made, because it all depends upon where is the defect and how much amount of peritoneal flap are you going to make comfortably.
Hold this now.
Because once you have the peritoneal flap that is comfortable, then the closure of the defect and placement of the mesh becomes easier. That's important. I think Dr. Beg will go to the other side for a minute. I think Shumant, audio to the OT1, please.
Just to, for the postgraduates, term is trans-abdominal retromuscular. It's not TAR, okay? That's a transversus abdominal release. That's a different issue altogether. The operation is planning to do is a TARM, trans-abdominal retromuscular.
So that, it is sac. Okay.
Back with you. Shumanto, we are back with
Sir,
you.
so
Right.
I have dissected the cord structures. You can see the left hand I am holding is the sac, and then this is the gonadal vessels. These are the gonadal vessels, and this is the vas deferens. So I have dissected up till the direct defect area and planning to divide that. Since it's a congenital hernia, it will be a complete sac. I can go up to the fundus of the sac and dissect it out. But the thing is, if you keep on dissecting this area, inadvertently you will be injuring small blood vessels, and you may injure the
definitely,
vas, and post-operative there can be orchitis, ischemic
Exactly.
orchitis
So-
or epididymal orchitis will be there. So I have decided to divide the sac right here. So
No,
that
absolutely, because see, I think that is a very important point that
so
you
you can
made,
see the
Sumanto.
inside of the sac.
Absolutely.
So inside of the sac can be seen, and then contents are already reduced. So this is the one more advantage of TAPP repair. You can see the contents are already reduced, and then you can kachi.
Okay, now so I think Sumanto made a very important statement. You see, Sumanto, this ischemic orchitis issue is seen particularly when you damage the veins, because arteries are not very commonly damaged.
Right.
When the more you go on dissecting the distal part of the sac,
Right.
the problem is that the veins that are attached in that pampini are gradually damaged, and that leads to a congestion of the testes. So I think that what he has shown is a perfect one. And then, Sumanto, the important thing to ask about
Right.
that the proximal part of the sac.
Right.
Okay, so what is your plan?
So this proximal pad that I am holding here with my left hand instrument, I will be ligating it with a loop that I have preformed loop is there, a vicryl loop. I will be just ligating the Maitland. Not pusher আছে কি আছে Maitland ঢুকিয়ে দেবো তারপরে নট পুষার দিয়ে একবারে করা যায় তো আচ্ছা ঠিক আছে ঢুকিয়ে দিই কেটে দে ওটা বাইরেটা ঠিক আছে এবারে আয় দেখি
Okay, Sumanto, what is the suture that you are planning to take?
Vicryl. So it's a 2-0 vicryl.
Okay.
So usually if you have the preformed loop already, I mean the one which we use for appendix operation, the catgut loop, true loop. So it can be used, or otherwise you can form a loop and then you can apply it. So it's a 2-0 vicryl, absorbable suture. So it
Okay, can an preformed loop or particularly
আচ্ছা এক সেকেন্ড দাঁড়া এটাকে আগে কায়দা করে নি
Sumanto,
Sir.
what will happen if we keep the sac open? We do not give a tie. Suppose we don't give a tie to the sac.
ধর নট পুষার দে এক সেকেন্ড
If we
So
do not,
if we keep it open, there will be a rent in the peritoneum.
No, but
that
we are-
can, in the post-operative period, that can lead the bowel, intestinal loops, go inside the pre-peritoneal plane into the groin space, and that can lead to post-operative intestinal obstruction.
I think, yeah, I mean, my answer to Utpal's question is, if you have got a very floppy lower peritoneal flap, and when you are closing the upper and lower peritoneal flaps, if you incorporate the defect into the closure and make sure that that is closed, then you don't need to put an endoloop.
Right.
I mean, the other question, Sumanto, is because you have got a remnant sac on the other side, on the distal end,
Yeah.
I mean, just tricks and trips
কাঁচি
to prevent a
এটা বেরোবে
hydrocele.
না আচ্ছা কাঁচিটা বাহাতে দে কাঁচি
This happens to all of us, okay?
So remnant sac in the distal sac actually, so
Yeah.
that can be left behind, or what you can do is you can pull the sac and slit it in two pieces.
Exactly, yeah.
Yeah, so that if you can slit this remnant sac, there will be the chance of postoperative hydrocele formation will be less, hydrocele and seroma formation.
Absolutely. I mean, seroma, we are not worried. Seroma will eventually resolve.
Yeah.
But I mean, in case the mouth of the distal part closes down, then it becomes a hydrocele and it will never resolve.
Right.
So it's a good idea to fish mouth or slit open the distal end of the sac.
Okay, so the herniatomy part has been done. Now we have to do the paritalization of the cord structures. Now my next target will be to create enough space in the myopectoneal space, myopectoneal orifice, so that I can place a good size mesh, at least 15 by 12 centimeter size mesh. For that we need to paritalize. So what is paritalization? while I am pulling this sac, you can see the cord structures are also coming with this. So this should not be there. And you have to parietalize, means you have to push the gonadal vessel and the vas deferens towards the parietes. So that while pulling this peritoneal flap, it should not come, it should lie over this area.
Sumanto, you said about the vessels, right? So what about the vas?
Vas is there already, sir.
No, no. How much do we need to, separate it from the peritoneum
Same,
also?
same, sir, same.
Okay.
Actually, you have to parietalize the whole thing, the cord structures and the vas deferens. And if we consider like anatomical landmark, then I'll say that from the defect margin at least 5 to 6 centimeter below. Okay. I'll show the other landmark by which we see and progress up till.
But the vas goes medially, I suppose.
Yeah,
Isn't it?
medially there are certain landmarks till which you should dissect. First of all, medially the vas will come like this and turn medially. The point which vas turns medially, you should stop the dissection over there. So that means the adequate dissection is there. Till now you can see the vas is coming directly downwards. At a certain point of time you will see the vas is turning medially. So here another anatomical landmark I will demonstrate. So you can see a glistening structure, a loop-like structure, which is glistening structure, which is coming transversely behind the cord structures. You can see this structure.
Yes, yes.
This is a strand and a fold-like structure and a loop. This loop is known as loop of straddle. This is nothing but the extension of the fascia transversalis. Okay, so you need to divide this structure so that you can bring the sac down. Otherwise, there will not be enough parietalization of the cord structure and you won't be able to place the mesh nicely. So this is one important anatomical landmark I'd like to say. So I'll just keep on dissecting over there and divide this with monopolar energy.
Sumanto will go to the other side and you keep your audio muted for a minute.
Sure.
Okay. Dr. Beg, we are with you now again. Audio to the OT2.
So Ramanuj, what we have done is, you can see we are doing a term and we have been able to raise the flap and I will just aste. No. Give me the Savlon. I'll just clean this up for you guys so that it is clear. So what we have done, Ramanuj, is we have made a flap. It was Savlon बोलो ना हबीब जो हम लोग लेते हैं या ब्यूटेडीन ले लो. Let me show you. छोड़ दो मेरे हाथ में. हाँ. So you can see this flap here. I scored it. This is the midline. And एक मिनट छोड़ दो बेटा इसको वहाँ पकड़ के ना. हाँ. Hold it. So this is the midline, and this is going to the opposite side. That is the left retrorectus side. And after scoring, what have I done? I'm not doing a TAPP. What do you see here? Rectus. At the level of the, just below the level of the umbilicus. So this is the retrorectus space. Okay? That is the infraepigastric vessels. And if you go laterally, can you see that the rectus is ending here? And you start seeing the neurovascular bundles. And what you have to do from at this point is, I have gone lateral to the linea seminaris, right till here, can you see that? And made a space. Now, if I cut this tissue in between, that is your lower end TAR. Are you getting me? Hold this.
Yes, we are.
So for students, important to remember that you are going to read about TAR. So the arcuate line will end somewhere here, and then thereafter you will have no posterior rectus sheath, just the peritoneum. That is from our basic knowledge. And what I am doing is, I have created this retrorectus space. I have created this pre-transversalis or pre-peritoneal space. The muscle that you see here is a transverse abdominis muscle because it's transverse in nature.
Right.
And what we are doing is we can go right, if the camera can show, we will go right till the bottom, till we can see the same space that Sumanto is showing you for groin hernia.
Right.
Right, because in same band. Now, I'm happy that Shumanta is doing that because it will help us clear our idea. Pressure क्या है? हाँ, ठीक ही है pressure. Right. So again, once you understand this extraperitoneal anatomy, what happens is you can do most of your groin as well as your ventral. उस तरफ होगा, उल्टा होगा बच्चा. हाँ. So you see how far we can go, Shumanto, Ramanuj, we can go right till the posterior. We are already in the mid-axillary line. And I can keep on peeling this off, and I can assure you I will show you the kidney also if I want to.
Excellent.
But
But
should we-
important thing that how do you keep the nerves away while you dissect? Or
Yeah,
what is the
good point.
fascia and how do you identify the fascia?
So that is another very important point. Now what we have to do is understand that at this level, between the transverses and the posterior rectus sheath of the peritoneum, there are no neurovascular bundles. Okay, that is number one important thing to know. All your structures are between internal oblique and transverses. That's the way it is. And then towards the groin, they will start piercing and getting shown in your groin hernia surgery, for example, TAPP or TAP. So what I'm going to do is leave one fascia transversalis on the TA muscle, and that will protect all the nerves. I don't need to see the nerves. If the patient is fatty, if the patient is thin, we will be able to see the nerve, but that's okay. I'm not hunting for them. I'm just saying that if I keep doing this, I will be in the same space as Sumanto. So as long as you understand, now you can see that is probably the psoas muscle is going to come in. You don't bother about the bleeders, the small ones. If you go after them and you are going to do some thermal damage to the nerve, that's much worse than losing about 10 ml of blood there. Okay?
Right.
So I have kept in a gauge piece inside so that I can soak these blood when they happen. Remember, in this space, the problem of retrorectus repairs are, the chief problem is a hematoma. It's nothing else. The recurrence is lower, but the hematoma is higher. And that is because we're dealing with a space where there's a lot of vessels. So here you are, we have done till here. Okay, now you come back and you can see the TA muscles right till the bottom. And I will come back and I will show you from intraperitoneal that we have come till here. Where is the symphysis pubis? Let's orientate ourselves again. That is the balloon. That's the symphysis pubis. And this must be the iliopubic tract. And we have already started seeing that from this space. Now that is the hernia. So what have I got to do now? I have already raised the flap, retrorectus, pre-transversalis or pre-peritoneal if you may. And in between is the TA muscle, which I divide. And if I divide that, I would have created a flap safely. And I am not going to damage the nerves because I am going to see where they are and I am going to stay medial to them. Okay?
Right. Now, as it is a ventral hernia and there is a lot of scar,
Yeah,
how
a
do
lot
you
of scar.
safeguard the inferior epigastric vessels? Because they
Yeah. So epigastric vessel is here. It is usually posterior to and in the midpoint of the rectus. And you can see that there will be vessels that will give on to the posterior rectus sheath. You got to divide that with a ligature or a bipolar. If you start dividing those with monopolar, they will bleed. So I think very important point is see your epigastric really early and try to look at all the vessels which were going down. We had one vessel which bled. See this one somewhere here. Then there is another here which we cauterized, this one here. They are all branches or perforators coming from the epigastric, but we will not injure the epigastric consciously. If it does happen, you can burn them with bipolar. But see, what we are doing is we are keeping them at the roof. And we are just teasing the structures away. Okay. Now, which portion can I buzz and which portion I cannot? I told you. There when it bled, I did not buzz. Here when it bled, I did buzz. having an idea of the anatomy is important, because then you will know what you can cut and what you cannot, what you can buzz, what you cannot. Now again, coming back here, see, I have already shown you that I have dissected this preperitoneal space, I have dissected the retrorectus space, which will become the preperitoneal space beneath the arcuate line. And at this level, whatever I am cutting is the TA aponeurosis, and that is what is meant by a TAR. When we do it at the top, they are muscular. When we do them at the bottom, they are aponeurotic.
Absolutely. Dr. Beg, we go to the audio for the OT1 for a minute.
do.
Right. Sumanto, we are back with you.
Sir.
I think brilliant paratalization of the cord structures.
Yes. So I'll just show the anatomical landmark over there.
Right.
So medial dissection, if you see, I'll take the camera. Medial dissection, you can see the space of radius over here. You can see the pubic arch almost onto the opposite groin.
Right.
Okay, so this is
Sumanto,
the...
just a query. Do you expose the obturator foramen or the obturator
Yeah,
flap?
I have exposed. I'll show you. So this is the undersurface of the right rectus. This one is the right rectus. This is the part of the left rectus which is visible. Okay, then coming inside medial, camera. Coming inside medially, obturator. Question that how long you keep on dissecting or keep on doing paratalization. এখানে দেখা সোজা কর camera. So you can see the vas is coming like downwards, and then there are two cord-like structures. I am holding with my left hand instrument, and this is the which is going below the cord-like structure. This cord-like structure is the umbilical fold, which is coming towards and going medially like this. This is the obliterated umbilical artery which is continuing, and then this is the vas deferens which is going beneath that. So where vas is turning medially and crossing the right median umbilical fold, this is one point, this one identification mark where you think that your dissection is more or less enough. Then other part is medially. So medial dissection, you should do dissection up till I have mentioned that at least 2 centimeter below the pubic bone. This is the Cooper's ligament. So this is glistening whitish structure is the Cooper's ligament medially, and from Cooper's it down at least 2 centimeters. This has been created. Medially, if you come medially, you can see one nerve like badike. So this is whitish structure you can see. This one whitish structure, this is obturator nerve. This one is obturator nerve. So once you see the obturator nerve, and these are the obturator vessels which will be going inside the obturator canal. You need not to expose, because you have seen from inside that there is no obturator hernia or obturator weakness. So once you see this structure, you can stop over there. Dissection is good enough. Then this is the medial dissection, and coming on to the lateral aspect. So you can see. So again, this is the inferior epigastric vessel. You can see, and while your body gonadal blood vessel, blood vessel. This is vas deferens. This is the reflected part of the peritoneum, which is the triangle of doom. Why? Because the external iliac vein, external iliac vein, and this is external iliac artery. So if you inadvertently injure any of this structure, there will be torrential bleed and will be very difficult to control. So this is known as, your career will be doomed. Maybe that's why this is known as triangle of doom. And then the triangle is formed by the gonadal blood vessel. Then the peritoneal reflection, you can see appreciate the peritoneal reflection over there, and then the iliopubic tract. What is iliopubic tract? You can see a cord-like structure, tendinous structure over there. Here, come, kache. Here, a tendinous structure, you can appreciate a tendinous structure which is coming actually from the anterior superior iliac spine and will be going to the pubic bone. This is the iliopubic tract, and the triangle which is formed in between, there is the gonadal vessel, iliopubic tract, and the reflected part of it is known as triangle of pain. Several nerves are there, lying over there. You can see the branch of genitofemoral nerve, then the lateral femoral cutaneous nerve, psoas. These are all lying over the psoas muscle. This is psoas muscle. So I think dissection is almost done.
Very, very well dissected, Sumanto. you should really have a round of applause, please, because
Thank you so much.
a very good dissection.
So
And
dissection
what is
is-
best important is it's a bloodless dissection.
I catch it.
Right. And I think for the residents who are seeing, the epigastric artery is on the roof. And what joins the roof and the floor are the structures of the cord. So that is how the dissection should be.
So once you feel that dissection is good enough, then you can plan for placing the mesh. But before placing the mesh, you should be absolutely very sure that there is hemostasis is secured. Because after placing the mesh, the dissection area will be behind the mesh. So even if there is some bleeding, it will be very difficult to identify and control. So before that, you have to be very sure there is no bleeding from that side, and then you can plan for placing the mesh.
Absolutely.
So mesh.
Okay, I think we'll go to the other side now. Sumanta, by the time you
Give
place
me a
the mesh.
gloves.
Okay, OT2, please. Dr. Beg, we are back with you.
Yeah. So you can see this is the space of Retzius, and that is your bone. Can you see the shiny bone there?
Yeah, we can see the lighthouse. Right.
Now, I would want you to appreciate one thing, that when you do a same defect which you see in groin, in a groin hernia, primary groin hernia versus an incisional hernia, you look at the scar, right? So it will be very important to have done a lot of these primary groin before you venture for the ventral. Come back, I'll just show you. Give this to me. So first of all, look at the tethering. Look at the deficient PRS. All these Fannin steels will appear as if they are all lower down, but they have a midline component. The rectus has been split. It has been split usually very high. So there's a lot of scarring right from the top. And this PRS is deficient here. Can you see that?
Yes, we can.
The PRS is deficient here because you can see the rectus, right?
Right.
So we don't have any posterior cover at this area on the left side. Similarly, in the midline, which is at the linea alba level, you can find this is deeply adherent, right? So we are going slowly, cutting them slowly, trying to take posterior cover, because we'll need a posterior cover if we want to place a polypropylene mesh, okay? So what we are doing is, so far, this is our defect. We have done our dissection till the space of Retzius, which is here, and we have done our dissection lateral to the linea seminalis, which is here, okay? And now, what we are going to do is, we'll do the linea alba here. Hold this, please. This is the linea alba area. We're going to do this with the hook, because otherwise we may damage the linea alba. We'll do a little bit by bit. And you can see that all this tissue is deficient. So those of us who think that, well, the anatomical location is such that we will be able to do this similar to what we have been doing for groin, well, that is not the right thing to think of. These are far more difficult cases, primarily because this tissue has been violated. You will not get the same plane, but you will get guidelines. You will see rectus, you will see the, you will have to know how to identify the linea alba and stay below it. If you damage the linea alba, that's a disaster. So all that is going to come into play. You can see this big vein here. I'm going to take it with the ligature. Give me the ligature,
Okay,
please.
so by the time, Dr. Beg, we have seen the flap, we'll go to the other side while Sumanta
Please
is
do.
placing the mesh.
Once the flap is ready, we'll call
Right.
you.
OT1, please.
So this is a mesh. This I'm using the paratin mesh. 15 by 15 mesh was there. But what usually guideline says is you have to place at least minimum 15 by 10 centimeter size mesh. 15 is oblique and 10 is anterior posterior. So I have fashioned the mesh. I have cut around 3 centimeter of mesh. Then it becomes a 15 by 12 centimeter of mesh. Then since it will be going like this, the mesh will be placed in the right groin. So you have to think like this. And then I have given a cut over there on the lower medial border. So this will identify, this will help me in identifying the corner of the mesh that is to be go towards the bladder. So this will go towards the bladder, this will come up. And this is the medial end, this is the lateral end. So lateral end is rounded. Because the area of dissection is rounded, since I have, that's why I made the corners rounded, so that I can accommodate the mesh and there should not be any undue folding of the mesh after placing it inside.
So, I mean, obviously the Medtronics is trying to show the mesh. I just want to say this is paratin, which is polypropylene. This is flat sheet mesh. You also have another variety of parietin, which is macroporous mesh. Okay, you can use both in inguinal hernia, lap inguinal hernia, and there is another type which is a 3D mesh or an anatomical mix in the name of Dextile, which comes in a fixed shape and size, 1510 and 1612, but that's much more expensive than this parietin. I use them regularly, so I know parietin exactly costs 2,411 rupees print price. And Dextile is almost 13,500 rupees and 15,000 rupees for the two sizes. So there's a lot of
so I'll fold the mesh now. So this I'm folding the mesh. This will be going like this. So along the long axis, I'll make
just another basic thing for the trainees. Okay, when you hold the mesh, you certainly have changed the gloves, I'm sure. Shumanto?
Yes.
You have changed the gloves.
Yeah, I've changed the gloves.
And one more thing, I think the assistant should also change the gloves. I saw your assistant not changing the gloves and holding
Actually,
the mesh,
he was not
which
assisting in a way. He was just observing the assistant. Two of the assistants are standing on the other side. So he was just, Sudeep was just giving me moral support. Moral support. He is my friend, so giving me moral support. Take out the camera.
No, but this is absolutely mandatory that when you use the mesh,
Needle holder.
Should have new gloves. No questions asked.
Yeah. So for mesh this, and then I will. This is my the end which I am holding is the medial end, going towards the medial end, and this is the lateral end. So this is the needle holder. With the tip of the needle holder, I will hold the end of the mesh and like this, and then I will put it inside.
Perfect.
Then I will take it out, and then I will take the camera so that any of the mesh which is lying inside the port will be pushed towards the right side. This is the lateral end of the mesh. I will push it to the lateral side.
Right. Shumanto, I have seen few surgeons place a stitch on the medial end just to make them oriented in the peritoneum or in the abdomen, that this is the lateral and the medial side. For beginners, what do you recommend?
Sir, can you come again, sir?
We have seen some surgeons
marking the mesh for better orientation.
Marking, I think the cut I have made for the bladder part, so that will give me some identification mark after going in, putting in inside.
Okay, definitely.
I mean, there are three ways, Ramanuj. One is as Shumanto has done, so he exactly knows which is the lateral end, which is the medial end, and he has made a cut in the lower end, so he knows which is upper and which is lower on the medial side. No confusion. Number two is a stitch you can use for better orientation, and a very cheap thing I'll tell you. Use a marking pen, write M and L.
It a medial end.
Okay, because we were talking about the Dextile mesh.
I'll put it inside.
You have a marking,
Taking
M,
inside.
it's written.
Okay,
so you know.
Chala.
So you can use a marking pen and just write M on the medial side. Follow that, you will be oriented.
এটা হচ্ছে ব্লাডার কাটটা, ঠিক আছে? দেখ আয় ভেতরে মেশটা তলা দিয়া আয়, দেখ এইটা ব্লাডার কাট দেয়া আছে। না like not like that, হ্যাঁ এই দেখ ব্লাডার কাট দেয়া আছে, দেখতে পাচ্ছিস?
Okay, Professor Shudeb Shah has made a point which I think is a valid point. Ink is not meant for inside use.
Particularly, ink produces inflammation around the mesh. Okay. Right. I think Shumanto, very good layout of the mesh. Now, I think that the point that he's trying to make is that there should be no rolling of the mesh.
Yes.
Because it predisposes more of those meshomas and all these problems.
Yes. So, the pre-building space nicely and keep it like this. Even after side, if you see there is some folding, you can do a little bit dissection medially. Usually you can see that.
Right. How do you plan to fix the mesh, Shumanto?
So, sir, what guideline says is usually you, until and unless it's a M3 or L3 defect, you need not to fix the mesh, be it TAPP repair, be it tape repair. So I usually don't fix the mesh if the mesh is lying nicely flat and sticking over that area. If the hernial defect size is more than 3 centimeter, then there is a chance of mesh migration and the other things. So to prevent that, I will put 3 stitches. So 3-point fixation. One is with the Cooper's ligament, When one is with the undersurface of the rectus, ipsilateral rectus, I think patient is coming out of anesthesia.
No, see,
Give it.
Shumantu,
And-
we started with fixation with tackers, and then
Yeah.
there were lots of problems. Gradually, we came on to non-fixation. In the meantime, around couple of years back, we came into with glues. Again, the pendulum has swung into non-fixation.
Non-fixation is the ideal, sir, because I think until and unless it's a big defect, even if you plan to do fix, though better not to use tackers. Just put 3 stitches with 20 PDS or 20 prolene, one or the upper lateral end, one with the upper medial end, and one with the lower medial end with the Cooper's ligament. This 3-point fixation will be good enough. So you can see the mesh is lying nicely over that area, and the area of dissection is just good enough so that I may not fix this mesh also.
Mesh fixation, Shumanto, I mean, for the trainees again, one is you don't have to fix the mesh necessarily, particularly in a tape. Number 2, tacker. Tacker may be non-absorbable tacker or maybe absorbable tacker. Then you have the glue, and then you have this suture. Suture again may be absorbable or non-absorbable. The very important thing to remember about trainees is you cannot put any tacker below the iliopubic tract.
Yes.
So 3, 4 or 5-point fixation depending on your level of confidence. Symphysis pubis, Cooper's ligament, 2 and 1 medial to the inferior epigastric artery and 1 lateral to the inferior epigastric artery. This should suffice. 4 should suffice.
Vlog আছে নাকি? Vlog না থাকলে আমাকে এমনি 20 PDS দেন ক্লোজ করব।
I know, Shumanto, you have been trained extensively in JM Hospital, and they don't advocate the use of tackers. It is suture all the time.
Yes, sir.
I think that yes, for resource limited setup also, definitely use of sutures should be much more encouraged.
So actually during our training days we are not allowed to use trackers. So that's why we are forced to do suturing, and in a good way that has helped us to learn laparoscopic suturing. And I think learning laparoscopic suturing will give you freedom to perform many advanced laparoscopic procedures. So that is a must for nowadays, who are young surgeons who are willing to take up advanced laparoscopic surgery or field of practice. You need to learn laparoscopic suturing.
Yeah, I think the only way out is, you should be allowed to...
Vlog 20.
You should be allowed to do tackers or whatever only after you have learned suturing. That is what I think. Because we had done it the other way around. That was the big
Vlog
mistake.
আছে নাকি 20?
And you
Daw
see,
20
if you
absorbable?
know suturing, I mean, you can cross all hurdles. And another thing is that in some rare
20,
cases,
20,
sometimes you
30
are very
আছে না?
exhausted at the end
না
of the
20 আছে
operation.
কত সেন্টিমিটার?
So
30
yes,
centimeter.
in that case, 1 or 2 tacks will do.
Absorbable তো?
But then yes, when you have suturing, it's just like the anastomosis, if you know how to do it, do it the
Absolutely,
conventional
no
way,
doubt.
then yes, if you have a stapler, fine. If you don't have, it's better.
Yeah. No, the other thing is, anyway you have to close the peritoneal folds, and using tackers in that is one, very expensive, and number 2, very cumbersome. So you have to put the suture the peritoneal fold. So as Shumanto said, when you are starting laparoscopic surgery with simple lap cholecystectomies, I think that is the time when you learn extracorporeal and intracorporeal knotting and intracorporeal suturing. Mandatory.
Absolutely. We now go to the OT2.
Huh?
Dr. Beg, please.
Yeah, can you hear me?
Yes.
Okay, so this is a space of Retzius.
Right.
This is from the right side, this is from the left side. So I'm sure you must have seen Shumanto doing that as well. So this space is ready. What else is ready? I hope you saw that did you see the video while we were doing it?
Yes.
All right. So the sac was brought down in toto, so you don't see a circular defect in the posterior rectus sheath. It has been brought down. And this is the hernia. You can see it is...
Can you have a zoom in of the zoom in view, please?
Zoom in view, okay. Can you see it now?
Yes, better, please.
Yeah.
Better.
Okay, so that is the defect. There is a vessel going through it.
Yes, this is
So-
something that I was going to ask you. What is that vessel?
I think it's
So,
inferior.
no, the inferior
inferior
gastric is
more
here,
medial,
yes.
no?
Then it leaves a branch. Yeah, it's probably that only. I agree with you. I agree with you. See, this is the inferior gastric, isn't it?
Yes.
And it goes into the hernia sac, then comes here. Now, the only way that we can close this defect is when we sacrifice this,
Yes,
isn't
we
it?
have to divide the vessel.
Then they have to divide the vessel. You have to close the defect. Once we close the defect, we are ready to put in the mesh. Can you see the vein here?
Yes.
Iliac vein.
We can. That blue
Okay.
thing.
That is the femoral hernia space. That is the obturator hernia space. We don't need to do. That's the obturator. That's the internal iliac vein. That is the beneath that fat. The pulsation belongs to the internal iliac artery, and this is the round ligament. Okay, what I'm holding.
So are you planning to divide the round
Yeah.
ligament, because that is going to give you more
Yeah,
space?
it will give me more space. And we were talking about the nerve. So we are not, this is a fatty female, so to say. So we are not going to try and see the nerves, but we know that this fat conceals the nerve. If there were some nerves visible, I would have shown you, but this is the space where you're going to see it. And when we go to the bottom, you can see the psoas muscle here. Can you see that psoas
Yes,
muscle?
we can see the tendon forming.
Yeah, so that is the psoas muscle. And laterally, we are now beyond the anterosupiliac spine here. This is an avascular space. 1 second. Yeah, that's the avascular space. And I can keep on, as I said, go as much as I need. So if the defect is here, I need a mesh till here. I don't need more. So this should be a good overlap, even if it is without fixation, till the point I'm showing you. And on the medial side, if I can go to the space of Retzius, cover it, that is enough for this defect. So we have got enough space. The idea is to get superior and inferior. So now what about the inferior? From the defect and the groin, you will think of 5. Now we probably have about 8 here. Okay?
Okay.
Visual estimate is 8, because we will be able to put in a mesh till here.
Right. So I think,
Similarly, from the superior margin till this margin, we have about a 7 centimeters. How am I saying all this? Because if you look at the ligature, Maryland,
right.
that's 8 centimeters.
Right. Dr. Beg, we'll just switch on for a minute.
Sure.
To the OT1.
Sure.
OT1.
Okay, for trainees, the suture material Dr. Shumanto is using is a barbed suture, where you don't have to put a knot and the suture doesn't slip. Ektu zoom kora Shumanto?
Ah.
Now, I think you are using a 20 V-lock absorbable, am
Yes,
I right?
yes,
30.
definitely, 30 centimeter.
Okay.
Now
Shumanto-
for trainees, I mean, this is an expensive
Yes.
suture material, costs quite a lot. More than 4,000 is the print price. You can close the peritoneal
With the floral
folds
suture.
with, well, virtually anything really. I mean, you can use
You
a
can use a
2 or 30
Prolene.
high
Should I-
creel,
should I?
PDS
30
Prolene.
creel, exactly.
But this is
বাদিকে
something
ডাউন কর,
very
বাদিকে ডাউন,
useful.
বাদিকে ডাউন, কাছে এসো। ভেতরে
You
ডাউন কর,
see
ডাউন,
there
ডাউন।
are
হ্যাঁ, হ্যাঁ, হ্যাঁ।
like kantas, barbs, okay? So once the suture is pulled, it doesn't slip back. Self-holding.
Shumanto,
Sir.
regarding the upper flap,
সরে,
I mean, do we need to make it a free a bit before we start suturing?
So you can, but I think this is
Not really essential.
nah, just
That's
good enough to accommodate the mesh. I think that's why you can, if you feel that mesh is coming out of the flap, then you can,
Oh, in that case, you will have to.
then
No
in
other
that case
option.
you can mobilize the upper flap by pulling the flap, pulling the upper margin a little bit. So I have given 3-4 throws of V-lock, and then I am just pulling the.
Yes, yes.
Should I-
That
should I?
is
Dure,
the
dure dekha.
most important thing we have to realize when we are using barbed suture. And one more thing, I think everybody watching must have noted that the surgeon here is not picking up both the leaves in the same throw of the needle. First he's going for the upper one, then he brings out the needle, then he goes for the lower flap separately.
Abar
That
dekha.
is the most important thing. as soon as you try doing, I mean, if you want to take up both the leaves in the same throw,
Right.
you'll find you're going to tear.
Yes.
the
Camera up,
peritoneum,
camera up,
yes.
camera up.
Shumanto, one more very important question thing for the trainees. What is your intra-abdominal pressure now?
Intra-abdominal pressure, if the flaps are coming nicely together, I have not decreased the peritoneal
Okay.
pressure. So
Okay.
if it is 14, I kept it 14 only.
Okay,
If I
right.
feel that it is under tension,
Right.
then I will reduce the pressure to 10 or 8 maybe.
Okay.
And then the closure will be under no tension.
Okay, that's fine. I usually lower it, but anyway, the take-home message is if the peritoneal folds are being sutured under tension, then please reduce the intra-abdominal pressure to about 8 to 10. Then it gives you a lax peritoneal fold to be sutured. But I will agree with Dr. Sudhir Shah. When I make the flaps, I usually make 1 to 2 centimeter of the upper flap, routinely. But it has been a wonderful demonstration of a TAPP, Shumanto.
Thank you, sir.
All,
Thank you.
bloodless and all anatomical landmarks shown very clearly.
And the icing on the cake is going on.
Yes. Can we go back to Sarfraz now?
OT2, please.
The only other thing is you don't have to tie a knot at the other end because the barbs are going to hold the suture tight. So a little bit lazy, no knots.
सीधा रहेगा बेटा ये फिलहाल सीधा रहेगा नीचे ऊपर हबीब एक मिनट इधर आ जाओ ना
Well, now, Shumanto, what is your take? Because nowadays, you know, some people say that you are not supposed to use barbed suture on the peritoneum.
না ঠিক আছে ওনাকে থাকতে দাও হাবিব বাস এটা হবে না এটা হবে না এটা হবে না
Can you go to the OT2, please, Dr. Beg?
Yeah, can you hear me?
Yeah, we can hear you. I think
We're going to close this.
defect.
Yeah, we're going to close the defect. We're looking for the right needle holder. This is a barbed suture. Can
What
you
did you
see?
do with the vessel? That the vessel?
I buzzed them on two ends. I have not divided them.
Okay.
Because I don't think it's needed.
Sarfraz,
Yeah.
just for the trainees, on the other side, the barbed suture Dr. Shumanto they was using was green in color. That was an absorbable barbed suture. And the one Dr. Beg is using is blue in color. So this is most probably a non-absorbable barbed suture. Am I right? 10 Vilokto.
I am using a number one
Number one
non-absorbable. They don't have anything else, so that is what we are
Okay.
using.
And Sarfraz, there was one question Dr. Shudev Shah asked. What is your comments on avoiding using barbed sutures in the peritoneal surface because of a possible addition of bowel and causing intestinal obstruction? What is your comment and your
About
experience?
the barbed suture, yes, there are case reports that it causes bowel obstruction. The problem is that for years, these laparoscopic surgeons have struggled to put a knot on one end.
Right.
And this is the first time when something of such convenience has come in for the surgeons. Now, even if it is causing that problem which you are mentioning, I think it will still become popular. ये नहीं काम कर रहा है. This needle holder will not work. Give me a good needle holder, please.
Can you go to the other OT now for a minute? Shumanto, we are with you again. Shumanto, are you with us?
Cable up.
Right.
Yeah. So we are just closing the peritoneal flap. I'm just giving the final 1 or 2 throws to
Absolutely.
close
It
the.
has really been a brilliant operation, Shumanto.
Thank you so much, sir.
Gutless operation, brilliant operation, and for all the trainees, particularly we would like to thank your camera surgeon and your whole team.
Yes,
and
yes.
your anesthesia
So
team.
surgery is always a teamwork.
Definitely.
You are as good as your team. So I think just I'll give a final one locking suture, then I'll cut it.
Today, at the end of the first operation, I think the surgeon deserves a big applause also because he's totally working with a new team here.
Yeah.
That we have to give him that credit.
সুমন্ত তোমার জন্য আমরা হাততালি দিলাম ভাই
আরে থ্যাংক ইউ সো মাচ স্যার কাছি So after finishing the peritoneal flap closure, I will take the needle out. So there is different techniques that we use to put the needle inside and taking it out. So trick is to hold not the needle, but just adjacent to needle, so hold the suture adjacent to needle. Then I will ask the camera person to follow my right hand working port. And while taking it out, you have to see the tip of the needle. And while together, once and the part of the needle is inside the port, I will be pulling the instrument, needle and the port together, and the direction of the this tip of the needle will be downwards, not to the upwards, so that it should not injure any part of the down kor de puro down. So it will be completely under vision. So you can see I am just taking it out, and externally you can see I have taken it out. So I will ask the assistant to hold the needle, and then again put the chart dekha port ta dekha. So now I am putting the instrument first through the hole, and then putting the port first under the guidance of the instrument. So you can see.
Yeah.
Right. So these are just small tricks not mentioned in any textbook, but while learning from the masters, I have just learned these tips and
tricks. That is the reason that we have this workshop, so that not everything will be written in books. There are things with experience and tricks that we need to learn.
Badike dekha, badike down kar. So you can see.
Coming back to Dr. Sudeb Shaha's question, I think when you are using barb suture on peritoneum, if it is possible, please make sure that there is no free loop of bowel just below that. To try to cover it with omentum.
Yeah.
So that's the safest way to do.
Right.
But I think barb is being used for peritoneal sutures extensively all over India and the world.
Yes.
And both absorbable and non-absorbable.
Sumanta, I think you have done a brilliant job. Sumanta, now by the time
Neutral,
you are ending
neutral.
up,
Exactly, that is what he's doing. He's putting the
he's
omentum.
just putting the omentum as a
So
patch
that
over
prevents
that.
direct confrontation between the barb suture and the bowel loop.
gas to suction cannula ache.
Sumanta, by the time, do you like to put in say a gauze roll or a mop roll to prevent a seroma in the groin?
Sir?
Do you like to put anything or an external pressure on the groin to prevent a seroma?
Yes. After finishing the operation, I will put some Gamzee roll and put one strap of Dynaplast, so that I can obliterate the space, groin area, as much as possible.
So we keep it for 48 hours so that seroma is a bit avoided. But very well shown, Sumanto, and
so
you
gas
really
off
need a round of applause. A very good beginning of the workshop of the Sasicme 22. And definitely the big credit to the Department of Surgery, NRS Medical College, led by Dr. Sudeb Shaha and his
one more small trick which Sumanto is doing. He using a sucker. He's pushing it into the space between the peritoneum and the mesh. A very small hole. And then he will suck it and deflate the abdomen at the same time. So by the time he is going to close, there will be no dead space. Am I right, Sumanto?
Yes, sir, definitely.
Yeah.
True. So the sucker, actually, I have used the sucker for the first time in this operation at the last step of the operation. So there was actually...
Exactly. Yours was so bloodless. Job very well done, Sumanto. Thanks a lot.
Thank you so much. Thank you.
Can we go over to the other side, please?
Sure.
Yeah, are you back?
Yes, Sarfraz?
Yes.
I'll just ask you a trainee question.
Please.
You were saying at least 5 centimeter, if not 7 centimeter overlap
Yes.
Around the defect.
Yes.
Now, is that what you follow, or you follow what we call the mesh area defect ratio? At least 13:1, if not 16:1, the formula of Tulo and Deboy.
Yeah, so this is actually the paper by Hotters, the
Right.
first time. And they said that if you have a ratio of 16:1, and then the recurrence rate will be 0. As soon as it falls below 9, the recurrence is close to 30%, and if it is 13, it is 9%.
Right.
Now, this is about bridging repair. वो दे दो ना,
Right.
एक कैंची. So this paper is about bridging repair, not about repairs which have a defect closure. So that is the caveat.
Okay.
Always read that paper very carefully, because although we follow that,
Right.
but that is actually for bridging repairs.
Basically, that's for IPOM and IPOM plus.
Correct.
Right. Okay. Okay.
Yeah, हाथ धो ना. So here you can see what have we done. We have closed the defect. If it was
একটু ক্লোজ করে দেখাতে বল ভাই একটু zoom in.
Can you see the defect closure?
Yeah, fantastic.
So done. So this was a barbed suture. So it makes it easy because you don't have to make knots. You're not dependent on your assistants also. Come back, come back, come back. And I'm going to remove this barbed suture right away by taking out the trocar. I don't like to leave it behind, because then, the less number of things there are in your inside your peritoneal cavity,
Right.
the better it is, because you don't have to remember. Already we know that we have to remember there is a gauge piece here.
Right.
Trocar do na beta. Trocar do. So now what is the issue now? We have already done two things. One is that we have created the flap. 2, we have brought down the hernia sac. And 3, we have closed the defect. Udhar dikhai na beta. And then we are now going to put in a mesh. That is all there is to it. This is a TARM, as you rightly pointed out. Yahan dikha do.
I mean, basically, for trainees who are watching this procedure,
Yeah.
what Dr. Beg is doing is actually what he was supposed to do in the E-TEP RS. Okay.
Yes.
It's just the other way around. He has gone. Okay.
Yeah, we are going to be in the
exactly, you would have
same
seen the
space.
same thing. Apart from the peritoneal closure or
mesh.
the closure of the posterior rectus
15 to
PRS, everything else is the same.
No, I
Yeah.
think that it has been a better, say, thing for all the audience, because we got to see the intraperitoneal
हो
additional
जाएगा.
lysis. Right. We got to see the two sides, the preperitoneal and the intraperitoneal view. I think, Dr. Beg, what is the trick? Because both of you had a very beautiful peritoneal flap. So what is the trick to raise a good peritoneal flap?
So I think this is not a virgin area. When you do primary groin hernias, you will learn all the normal planes. When that, if you do at least 10, 20, 30, understanding where the epigastric is going to come, where is the psoas, where are the nerves, where is the anterocephalic spine, where is the iliopubic tract, where is the symphysis pubis, where is the space of Retzius, and you know that there are layers here. I will just put in a finer point here. The fascia transversalis here is bilayer. Try to keep one layer at the rectus muscle and one layer at the bottom. Similarly, keep one layer with the nerves. Okay? So
It's all about planes and
it's all about
understanding
planes.
that, right?
But you learn with the virgin surgery. This is a violated area. So when you see violated area, it will always appear difficult. Oh my God, this is looking difficult. I may have made it look more difficult, but the point is that this is going to be difficult, because every time you cut any tissue at the midline, you will find there's a scar. And you may inadvertently injure the linea alba. You can't do that. 2, if you're going to go from break away from the linea seminaris into the pre-peritoneal space, lateral to the linea seminaris, then what are you going to do? You're going to do a TAR. But that TAR cannot injure neurovascular bundles. That TAR has to be safe, and that TAR has to be only as much as needed. For example, you cannot do more TAR here in this patient. It's not needed. This patient needed a TAR. Why? Because the defect was at the level of the linea seminaris. Can you see the rectus has ended?
Yes, we can.
Yeah? So without doing a TAR, you cannot do the surgery. You cannot have an overlap which is lateral. So this is exactly what we have done. Compared to an E-TEP and a TAM, I will make another finer point, an advanced point. If you did an E-TEP in this patient, you would have unnecessarily violated the PRS of the opposite side right at the top. Not needed, but you would have to do it. But when you're doing a TAR, you can do as much as needed. That is the difference between a endoscopic reef stopa versus a TAM. So I hope you you all should appreciate that point. We already have a lecture on that, very important lecture. Whenever we see a L3 hernia, my go-to procedure is a TAM. Although in this patient today we wanted to do an E-TEP because I wanted to demonstrate it. But you can see that in a TAM, it gives you the liberty of dissecting as much as needed and no more, right? Now I'm going to put in a mesh, and although this patient, I would have preferred a scale, but I don't have one. So I am going to use a 15 by 15 centimeter mesh, centering around that defect.
Right. Now, how do you fix the center of the mesh? Do you mark it outside and then put it or give a central
You could
stage?
do that, definitely do that. And you can see that those sutures are going to help me. You will see those sutures of the barbed sutures are going to help me. I'm taking a heavy polypropylene. That's another point I'm going to make.
Yes.
Usually we take lightweight meshes, macroporous. Here I am going to use a, tooth faucet, a tacker dena mere ko. So, nikalo na beta. So what I'm going to do is, I'm going to do a heavy mesh. Why heavy? For the postgraduates, for the residents. We know that the macroporous mesh, A, contracts less. B, if you have an infection, it clears the bacteria better. However, the heavyweight mesh has the advantage of decreased recurrence because of the weight. And in these lateral hernias, this is not coming from evidence. This is not coming from expert opinion. So level 4. So, do grasp for the. So, if you see a lateral hernia, the biomechanics are different. Therefore, here the forces which are acting are different. What we should do? So what we should do is, I also use a heavy mesh when I am doing a lateral hernia. They will withstand more pressure and more force. Although if you read Dr. Todd Hanniford's paper, you will realize that the maximum force which is generated in the body is about 160 while jumping and squatting, whereas the meshes that we place can take a... Now you are asking about centering, and I will show you. This is a square mesh, right? It's a 15 by 15, so it's a square mesh. If I put it here and look at that blue thread, which is here, I am going to shift this
Zoom in a bit.
in a way that that center of the mesh and the thread is okay.
Can you
Now,
zoom in a bit, please, on the center?
I'll just show you. Don't look at that thread. That thread is not the... That thread is going to come from... Yeah, I need tacker. Can you see that thread now?
Yes, we can.
Yeah.
Now,
So,
important
give it
thing,
to me.
like on Shumanto, what he did was that
Yeah.
he did not fix the mesh. He rolled out the mesh and said that, okay, that was beautifully aligned.
Yeah.
So, what is your plan, Dr. Beg?
So I'll tell you something honestly. I would have used a bigger mesh at my center.
Okay.
I would have used a heavy mesh, but maybe 20 by 15. Vertically, it would be 15 or 17, I would say. But laterally, I would have been able to put in a bigger mesh. Okay?
Now, as you have said, a bigger mesh. Now, on a technical point, how wide do you think should be the wide? That means from the center of the defect, how wide should be the underlay or the overlay? Like 5 centimeter, 10 centimeter, which one do you think will be the optimal?
So, Ramanuj, you probably know it better than me that this literature comes from just one paper where they said at least 5 centimeter overlap for a fixed mesh. When you're talking about an unfixed mesh, that overlap might be questionable.
Absolutely.
So try to put in as big, tracker, there.
I
Try
think
to-
that's a very important point that you made, that for
Yeah.
fixed meshes which are not going to migrate, that 5 centimeter rule is a
Yeah.
good one,
Yeah,
provided it's a 3-dimensional 5.
yeah.
But for meshes which are not fixed, I think the larger the mesh, the better should be the
Correct.
coverage.
But
Yes,
then I
that's
will-
a very important point.
Absolutely. But when you have closed the defect and you're putting it in between the two layers, then perhaps a 7-8 centimeter overlap is good enough. But then, if you look at a midline hernia, which is 15 centimeter wide, then I think all these questions are going to be revisited, and the best thing would be to put in a mesh coming from the diaphragm to the pubis, from one psoas to another. So that's, I'm just trying to put in as many points as possible in the brief time that I have with you all about how the world is thinking about the hernia these days. As far as this is concerned, this is acceptable, this is fine, this looks good, this looks pretty. I will fix the mesh unlike Shumanto, because I always believe that there's no harm in doing 1 or 2 fixation. I can use suture, I can tack it, but to make things easy today, I will tack it because we have to go for pseudocyst and probably a CA rectum. So I'll save time. Otherwise, I can suture it one here, and then I can suture. Come back, please.
Now, sutures or tacks, what do you prefer?
So it depends. If I am doing a groin hernia, just one tack, then all right, just one tack. IPOM, there is no question of suture, it's always tack. And when it comes to extraperitoneal repairs, E-TEP, only suture, no tack. TARM, because the TARM requires suturing of this flap, can you see this flap? And the ports are so close. Just going to make a point here. See, this is the angle that I'm going to get. If I had to suture, this is how close the camera is going to show me, and this is the ergonomics. Very difficult. Unless I'm a robot, it's not going to happen very easily. It's going to happen with a lot of stress. So tacker it is. So, और कुछ नहीं है, दे दो. So they have an Ethicon secure strap. I still prefer metallic tacks, and that's another point which is of aberration. I think everybody should know that people are again moving from metallic tacks to non-metallic or absorbable tacks, but the robustness is not there. Apart from BARD, which has a capture, the robustness is not there. And even capture is steel in the shaft. So I'm just going to show you. यहाँ पे एक वो दे दो ना ग्रास पर मेरा. So I'm just going to show you one tack here, and I think if Shumanto did not show a tack, number one, don't tack on the bone, tack a little above the bone, okay? Because you don't want to have issues of bone pain. Now that's number one, and for me, one here and one diagonally there is enough, and I will explain the reason when I have time about anisotropy, contraction, and how diagonal fixation may be helpful, but maybe that is for another day. And just to make this look a little pretty, some of you might be thinking, let us make it look as flat as possible. It's not needed.
Sarfaraz, what tack are you using?
I'm using an absorbable tack. Piche aana beta, piche aaiye. Absorbable tack by Johnson & Johnson.
Okay.
That's called secure strap.
Secure strap, okay.
Yeah.
I can see Ethicon now, yeah.
Right. Now, वो कम कर दो हम Salim, pressure 8 करो. So this is the time. I'm going to place one corner, one midline first.
Okay. Are you again going to use a barbed suture for the peritoneal?
No. On कर दो बेटा. On नहीं किए. Yeah. No, I will not. So as I said, I can, and I have done it in my center when we have plenty of time, we would do it. But if there are too many cases, we will not. Much of this is about practical aspects of practice. So here you see, for many of you who would want to finish this surgery, इसको हटाओ ना please.
Yeah, see, trainees, Dr. Beg has reduced the abdominal pressure to 8 now.
Yeah, very important point. पीछे रहना अभी.
And as we discussed in the previous TAPP, he is closing the peritoneal folds or the folds of the PRS with tacks.
So there you are. Now what happens is, I'll just show you after deflation. You should see this. That many of these small holes that you see, यहाँ दिखाएंगे नहीं बेटा? Okay. और इधर नहीं दिखाएंगे? इधर नहीं दिखाएंगे? हाँ. Take. Okay. So just to show you something. That bleed is because we are tacking it to a muscle. Let me just show you. If I deflate this, हाँ अभी गॉज पीस लेना है तो वो निकालना पड़ेगा. दिखाओ एक बार. गॉज दिखाओ. हाँ. Let me hold this. 5mm telescope है ना? I am just going to close this and deflate it and give me a suction. Give me a suction. Give me a suction. Now see this very carefully what I am going to show you. Habib, इधर पे देखो ना बेटा. See this. What did you see?
Yeah.
Is there any fixation required? If it was not fixed also it would, but then the space that you create is high. And I think a little bit of my bias is that we should have some fixation because the mesh can migrate. मेरे को मिल जाएगा telescope? दे दो ना. I just wanted to show you that trick to show you that how flat the mesh would be when you desufflate.
Right. Absolutely.
Okay. Take it out and make it 5. So now we are going to, this is the end of the surgery. We are going to convert this into a 5 telescope and take out the gauge piece from the 10mm trocar. That's the end of the surgery. If there are
I
questions.
think it has been a brilliant demonstration, Dr. Beg. Brilliant demonstration.
Thank you.
Multiple steps shown, principles shown, and particularly, I think the most appreciable word is that you have seen that the reinvention of the rib stopa again,
Yes.
from a very cumbersome open operation, very difficult open surgery, to a laparoscopic surgery, which has now, should be usually, you have identified all the principles, the brilliant peritoneal flaps and the placement of the mesh. I think you deserve a round of applause from the audience.
Thank you.
Thank you,
I just
Sarfraz.
want to tell you all that it is important to believe that you can do things laparoscopically.
Yes.
There will be plenty of steps in any surgery. Remember to break them down in your mind. Each step, understand how you would want you to do, how would you want your cameraman to assist you, how would you want your entire team to be with you. When you break this surgery into many steps and you take each step at a time, you can achieve these things laparoscopically. Now this TARM is a doable surgery. I would say that, for example, purely endoscopic retromuscular repair surgeries are difficult, but when it comes to, उसको मत लगा, सिर्फ एक दे दो. नहीं ठीक है, एक लोग ग्रास पर दे दो.
Okay, Sarfraz, thank you. Thanks a lot for a wonderful demonstration.
Thank you. I'm just going to take the gauge out. I'll be there.
I think we'll wait for the next OT, and I think the plan is on the OT1, we're going to have a TEP to be shown for a bilateral inguinal hernia, whereas on the OT2, I think we'll be having a laparoscopic
Suction दे दो.
gastrostomy for the pseudocyst of pancreas.
See this again. अब निकाल लो. निकाल लो अभी.
Sarfraz,
Yes.
post-operatively, would you put any additional pressure on the anterior abdominal wall?
Always we put in a GAMG with a Dynaplast,
Okay.
which we keep there for 3 days.
Okay.
Remember, the side effect of a retromuscular repair is hematoma.
Right. And how long would you keep it for?
We keep it for 72 hours, and
72
then the
hours.
patient can take it off in the house and take a bath.
Okay.
Sure. सवाई आइए टीम आ जाइए ऋषभ आ गए
A very good morning to all. We start with the next operation on a bilateral inguinal hernia. First of all, we will have a brief clinical review of the patient. Okay. So, one of our residents will be right. So, you can come in the front of the screen and then.
A 54-year-old gentleman presented with right inguinal swelling for 6 months, which was insidious in onset, gradually progressive, and not associated with pain. The swelling increases in size with straining and reduces at rest. The patient has a history of chronic constipation. He is a construction worker by occupation without any history of substance abuse. The patient doesn't have any lower urinary tract symptoms. On examination, the patient has a bilateral inguinal swelling, the right is more than the left, with an expansile cough impulse, which reduces spontaneously on lying down. It is an uncomplicated bilateral inguinal hernia. On the right side is PM2, whereas the left is PM1. And the plan is to do a totally extraperitoneal inguinal mesh hernioplasty. Thank you.
Thank you. Okay, so I think that we'll be again going in for a brilliant demonstration by Dr. Sumanto. Okay, Sumanto, I think you are live now. Is the audio feed coming in nice? Hello? Is the audio feed coming in nice? Sumanto? I think the video is coming on, but we need the audio feed.
ঠিক আছে?
Right, Sumanto, you are audible now.
Hello.
Good.
Hello.
Very good morning again, and I think we have had a clinical discussion that
Right.
it's a bilateral inguinal hernia. The right side is bigger than the left.
Okay.
So it's a PM2 on the right and a PM1 on the left.
Right, sir. So this is a bilateral direct hernia, PM2 and PM1. So my plan is to do a laparoscopic bilateral TEP repair, that is total extraperitoneal repair. The one previously I did was transabdominal preperitoneal. This time I will not go transabdominal, but I will dissect the layer by layer and go initially into the retractus plane and then into the preperitoneal plane, and the whole operation and the repair will be done in the preperitoneal plane. So this is total extraperitoneal plane and for extraperitoneal mesh placement. So with me, this time in the previous operation also and this operation I am using Stryker 1588 system, and the previous case I used 10 mm scope with 30 degree angulation, and this time I will be using a 0 degree scope 10 millimeter 0 degree scope for the operation. And with me on camera there will be Dr. Soumit De, and the scrub there will be scrub other surgeon will be Dr. Arnob De. So I am Sumanto De, and we De brothers will be operating for this case. So on the anesthesia aspect, anesthesia kyun nahi? Anesthetist who are there? Dr. Shreyoshi Mukherjee is there. Dr. Mohim Prasad De is also there. So this is the whole team, and right now flask e gorom jol lagbe agertar moto flask e gorom jol.
Right. So by the time you start in, so we'd like to
External
wish
camera
our
time.
thanks to
Tor
the
pechone ache.
anesthesia team
White balance kore nin.
led by Dr. Dipankar Mukherjee,
Focus
Dr.
karo,
Archana
focus.
Rai, Dr. Mrityunjoy Mishra, Dr. Nabonita
ক্যামেরাটা পুরো
Roy,
ঘুরিয়ে দাও আমার দিকে,
Dr. Mohima
অভিষেকদা।
Prasad De, Anuprabha Basu, Avinav Verma,
পুরো ঘোরাও, পুরো
Madhumita
ঘোরাও।
Ghosh,
এইটাকে একটু সরিয়ে নিতে হবে,
Obipsha
ফ্লুইড সাইড।
Sarkar, Shreyushi Mukherjee, Shonit Chaudhary, Urunangshu Pal, Shaurav Naga, and Dr.
ঠিক
Vishwajit
আছে
Roy.
দে
We'd like to thank them for
স্ট্যাব
their
নাইফ
help and their assistance with us for the whole day. Thank you. So Shumantu, we are again back with you.
হ্যাঁ ওখান থেকে নিতে পারো, তুমি অ্যাক্সেস করতে পারো, আমরা ট্রলি সরিয়ে নেব, এখান থেকে করো, কোনো অসুবিধা নেই।
Right. Shumanto, we are back with you.
রিট্রাক্টরটা দে।
And definitely what you are doing is now the
At-
gold
at a-
standard,
at a
which has
artery.
remained the gold standard for the last
বড়
20
আর্টারি,
years.
বড় কার্ভড আর্টারি। Yes sir. So first I will get
Right.
the retractor's access by the infraumbilical approach. Just the external camera is visible. So this is the head end side, this is the foot end side, this is the umbilicus you can see.
Right.
So here, just at the lower border of the umbilicus, I will give a incision, vertical incision around 10 millimeter, and then I will dissect layer by layer by subcutaneous tissue, then identify the right anterior rectus sheath just lateral to the midline, and will give a nick over the right anterior rectus sheath. We'll split it. Once I split the right anterior rectus sheath, we will be seeing the rectus muscle, right rectus muscle. Then I will retract the rectus muscle. Once I retract the rectus muscle up, we can see the posterior rectus sheath. And I will be placing my first port, the camera port, 10 millimeter cannula inside the retractor's plane. And then I will do scope dissection. So I will go layer by layer. একটা গজ পিস দিয়ে রাখ আমাকে, গজ পিস, আরো গজ পিস নিয়ে রাখ।
Right. Shumanto, do you like to keep a catheter in the bladder or just...
The catheter is there already.
Okay. So is it a routine practice or do you
Yes,
believe
yes,
in...
yes. For young patients, small direct hernias, which is expected to take less time during the operation, so I don't put catheter. But if it is a big hernia, indirect hernia, bilateral hernia will take some time. So I'll put a catheter, and catheter will empty the bladder also, so there will be no hindrance of area of dissection. And then at the end of the operation, I'll remove the catheter. So usually in my practice, until and unless a very aged person and I'm expecting some kind of post-operative urinary problem, then I'll keep the catheter for one day, and then next morning I'll remove the catheter. Otherwise, on table after extubation, I'll remove the catheter.
I think
It
we,
was-
with,
it was shield,
we
ye
have
dena.
Dr. Manoj with us.
Screen scrub. কি বলে ওটাকে?
Shumanto, by the time you make your ports, now a few words about the sterilization practices that you have in
Yes.
your practice.
Sir,
What is the thing that you recommend?
so my preference is all the hand instruments should be properly sterilized, and for particularly hernia cases, the hernia case in that particular operation theater should be first operation.
Absolutely.
So, and all the instruments should be sterilized by ETO or plasma sterilizer, and if it is available, and if it is not, then I think Sidex immersion of the instrument for at least overnight should be done, and then first case should be ETO instrument and followed by Sidex insertion for disinfection, and then you can do the next cases. So all the hand instrument sterilization is very important, because once you are placing a mesh into the extraperitoneal plane, so it is very, after placing the mesh, if it gets infected, and mesh explantation in this, after these operations are very difficult. So until, unless it's a open, unlike the open operation, the mesh explantation is comparatively easier. But here you are pressing in a plane which is very difficult to access. So mesh infection should be prevented, and for that sterilization is of paramount importance. And particularly at the beginning of your practice, where one case of mesh infection and you can hamper your practice, further hernia practices or laparoscopy or surgical practices, may I say.
Absolutely. So by the time you go in, I think we'll be going to the other OT to have a look at the clinical profile and the imaging of the patient.
Gauge piece.
Okay. Can you have the audio and the video to the OT2? So, Sumanta, I think that we are back with you.
Patient ফিরে এসেছে কি?
Yeah, it's clear, but we don't have the top end view.
ব্যাস নিয়ে ও দেখিয়ে দেবে। তো এই পোর্টটা একটা ওই বাইরের ক্যামেরাটা দিয়ে দেখাতে হবে, এটা দিয়ে এখানে। দাঁড়া, পেশেন্টটা ফিরে এসছে, আগে আবার ওর দিক। এটা এখন রাখ রাখ। আমার ইনস্ট্রুমেন্টগুলো নিয়ে নিয়েছিস তো? ঠিক আছে। গেছে, করবো? উপর দিয়ে দেখা ভার্টিক্যালি, লাইটটা আসছে না, আর উপর দিয়ে আসতে হবে। কিছু দেখতে পাচ্ছি না। পেপার দিয়ে উপর দিয়ে নিয়েছো এখানে, দেখতে পাচ্ছি না। না, ধরতে হবে না।
Sumanto, are you infraumbilical or supraumbilical?
ইনফ্রাআম্বিলিক্যাল স্যার।
Supraumbilical.
দেখতে ইনফ্রাআম্বিলিক্যাল নিয়ে এসো এদিকে, উপর দিয়ে
Infraumbilical,
দেখাতে
না?
হবে।
No, because we don't have the top end view, so we are having a difficulty.
দেখা, এখান দিয়ে লাইট দিয়ে দেখা। ঠিক আছে,
Right,
দেখা
now
যাচ্ছে, দেখা
probably
যাচ্ছে।
it is better. So do you need any
So you can
special
see that-
retractors for retracting the sheath on the muscle?
Yes. So I have just given skin incision, retracted the subcutaneous tissue, and in this, after dissecting the subcutaneous, you can see the whitey structure. I think it's a little bit, देखो ये camera देखे देख, हाँ हाँ. This whitey structure that right now I'm pointing is the right anterior rectus sheath, just lateral to the midline. Okay, so I will be incising and giving a nick over there. একটু দেখা, লাইটটা ভেতরে ঢুকছে না। হ্যাঁ হ্যাঁ, এখানটা রাখ, একটা ব্লেড দিকে, লাইটটা দেখা। So I'm giving a nick over the right anterior rectus sheath, and then I'll be splitting it to see the underneath the rectus muscle is visible. So I'll be taking the rectus muscle also with my left hand instrument and lifted it up. Now you can see another white structure. No, you cannot see. So with my left, actually it's not appreciable with the scope. Light is problem is there, but with my left hand instrument, I have lifted up the skin, subcutaneous tissue, the right rectus muscle, the anterior rectus sheath, the right rectus muscle, and I am seeing the what space that now I am seeing is the right retrorectus space just lateral to the midline. So now I will be taking the cannula, only the cannula, no other one. আরেকটা ছিল না, হ্যাঁ খুলে দে, টকারটা খুলে দে। I will be just putting this cannula inside. এটা আবার পুরোটাই গোল পুরোটা। দাঁড়া দাঁড়া, দেখা দেখা, কিচ্ছু বোঝা যাচ্ছে না। দেখি, না না দেখি, তো শালা ঢুকছেই না। আচ্ছা, হোল্ড ইট, জাস্ট আমি ঢুকিয়ে দেখে নিই একবার। দাঁড়া, একবার ঢুকে দেখে নিই। এ স্কোপই ঢুকছে না, কোথায় আছি রে? হ্যাঁ ঠিক আছে ঠিক আছে ঠিক আছে, এটা ধর, এটা ধর, তুই এটা ধর, এদিকে এদিকে, জাস্ট এটা হোল্ড কর, একটু সুচারটা দে, আর ওই ভেজানো গজ পিসটা ভেজাস নি, একটু জলে ভিজিয়ে দে, নর্মাল লাইন। না না, স্যানিটাইজার, জল চিপড়ে দে, জল না, এটা স্যানিটাইজার।
Okay, Shumanto, I think that you're taking some stitches in the fascia.
Yes, sir. So not the fascia, actually after placing the port inside, to fix the
Okay.
port at that position, so that
Right.
there will be no air leak from the surrounding, at a watch piece, from the air leaks from the surroundings. What I will do is I have taken 10 Mars silk and taken the skin subcutaneous from the one side and to the other side, and then I will be placing a wet gauge piece. This is a wet gauge piece, wet in normal saline, and I will be putting this.
Will you like to take a purse string or is it just a figure of 8?
More or like a figure of 8 only. So just to occlude the spaces surrounding the port so that there will be no air leak. So here. ধর ধর এখানটা, হ্যাঁ ছেড়ে দে ছেড়ে দে ছেড়ে দে ছেড়ে দে ছেড়ে দে, এবার ধর, ছাড় ছাড় ছাড়। একটু টেবিল ডাউন আছে, ফুল ডাউন, আর কি ডাউন, আর কি ডাউন হবে, তাহলে একটু ডাউন করে দাও, ধরে রাখ, হ্যাঁ ছাড় 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 ছাড়, হ্যাঁ ছাড়। প্রেশার 12, ফ্লো 20। আচ্ছা কেটে দে, এটা কেটে দে, এগুলো রেখে দে সব। প্রেশার 12, ফ্লো 20, হ্যাঁ। ক্যামেরা জলটা দে, লাইট অফ, টপ লাইট অফ, হেড ডাউন, টেবিল ডাউন আছে পুরো না?
Okay, now Shumanto, I think you have done a fixation of the...
টেবিল পুরো ডাউন, ইয়েস স্যার, টেবিল পুরো ডাউন, শুকনো মপটা দে, মপটা। আচ্ছা একটু হেড ডাউন করো, হেড ডাউন, ঠিক আছে ঠিক আছে, ওকে স্টার্ট করেছো তো, ঠিক আছে থাক। সো আই হ্যাভ ফিক্সড দ্য মাই ক্যামেরা পোর্ট, দেন আইল জাস্ট বি আফটার ইনফ্লেটিং ইট, আইল জাস্ট পুট, করো 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 করো, বাস বাস বাস, ঠিক আছে। সো জাস্ট বিফোর ইনফ্লেটিং ইট আইল জাস্ট কনফার্ম whether I am a correct plane or
Shumanto,
not.
you need to be a bit louder, please.
Yeah, sir. So I have fixed my port, and now I am inside the retractors plane with my port. So I'll just inflate. So you can see once I have started pushing the gas.
Right.
So the space has. This is, you can see the ready structure. It is the muscle above, and the whitey
Right.
structure. It is the sheath below. So I am using
Shumanto, the important thing to ask about is that how did you know that you were behind the rectus sheath?
So it's under vision only. The whole dissection has been done under vision.
Right.
So after putting the scope, you need to see the two structures to confirm whether you are in a correct plane or not. So one is above, it should be muscle, and below the whitey structure, it should be sheath. There is a posterior rectus sheath.
Right.
So if it is not there, if you can see the yellow fats all around, then you are in a correct plane. You are in a wrong plane. Either you are in a subcutaneous plane or you are in a pre-peritoneal plane.
Right.
Then you need to adjust accordingly. Garam jal.
I think we have with us Dr. Makhollal Shah, the President of the Association of Surgeons of India, West Bengal State Chapter. A very good morning and welcome, sir.
Good morning, sir.
Yeah, thank you, Shumanto. I was observing your TAPP on virtual platform. It
Yes,
was
sir.
very well demonstrated. So now you are going through TP.
Yes, sir. So what I am doing is using a 0-degree scope. I am just going grazing along the posterior rectus sheath and doing a scope dissection. So some surgeons are doing balloon dissection to create the enlarge the rectus, this retractus dissection. But here I am used to do with this mopta ekhanei dak. This using 0-degree scope. So I find it comfortable using this only. So gradually I will be, right now I am standing on the left side of the patient, and gradually I will be moving my scope along with the port. You can see, so I am going from retractus plane, and this is the arcuate line. Below this line you can see there is posterior rectus sheath will be deficient, only the preperitoneal plane will be there. And the loose areolar tissue plane you can see the above fat is there, and below the loose areolar tissue plane, you have to follow that plane only. And there will be small blood vessels which you have to bypass for the initial part of the dissection. And just, you can see I'm just making a tunnel in the retractus plane to create, from retractus plane to create the pre-peritoneal plane also. I have to head down korbe. Head down.
Sumanto, this is Dr. Manas Datta.
Right.
Yes. Actually, I think for the beginners,
yes, sir.
The balloon dissection is much preferable or better than a direct camera dissection, that with the 0 degree. What do you think?
Actually, it depends on from whom you are learning and from how you are learning. So from where I have learned, from the beginning, from the first day also, you have seen this dissection. So in this plane, with this identifying the anatomical landmark and creating the space, I am used to do scope dissection. Those who are learning with balloon dissection, they can start doing balloon dissection, but there are other chances of other complications while doing balloon dissection. You may rupture the inferior epigastric vessel, or you may rupture the linea seminularis if you inflate the balloon too much. So that learning will also come under proper training also. So
yes,
from whom you are learning and from how you are learning, that has to be understood. Yes. So you can see the inferior epigastric plane on the roof, the inferior epigastric artery. So this is the inferior epigastric artery at the 12 o'clock on your screen. So the inferior epigastric artery should be, you can see the pulsation also. That is the inferior epigastric artery. This is the pre-peritoneal retractus and the pre-peritoneal plane. It is jol dibi amake. Jol.
Dr. Shumanto.
Sir.
Dr. Shumanto.
Sir.
When you make initial insufflation, why do you keep the flow rate? It is observed that if you keep the flow rate very high, it creates a good space.
Yeah, so I have kept the pressure at 12 millimeter mercury and keep the flow rate at 20 liter per hour.
Yeah.
20 liter per minute.
So, yes, that is important. If you keep the flow rate very high, this carbon dioxide creates a good space. So, and in addition, you are doing telescopic dissection also.
Yeah. So I think the right retractus space has been created. So I will be placing my first working port at the level of the umbilicus, lateral to at the just medial to the linea seminularis.
So you don't make midline ports?
No, I don't do midline ports.
So you will be going by both two lateral ports on parietal space?
Yes.
So you need to dissect laterally so to create this lateral port?
Yes, sir. So the port insertion should be under vision. You can see the port is coming here and like this. So this port placement should be done cautiously because inadvertent injury to the posterior rectus sheath with the tip of the trocar can create pneumoperitoneum. Ultimately, you can lose the space. So once I have kept the right hand working port in the right retractor space, now I will start creating the pre-peritoneal and the retractor space I'll try to enlarge the space. I am holding the camera with my left hand, and with my right hand I am using a hook and diathermic part amar kache ache. So cutting take 0 kore dao. So little bit of cautery application and traction, counter traction is very important. So I'll come to the midline part. Bas arna. ঠিক আছে কিছু করতে হবে একটু টান হালকা করে বাস দাঁড়া একটু গ্যাসটা খোল, একটু হালকা করে খোল, অল্প করে, হ্যাঁ হ্যাঁ, বাস বাস, খুলে খুলে রাখ, একটুখানি হালকা হালকা খুলে রাখ। So with my hook, I have come towards the midline, and here I am dividing the median raphe, that is the posterior rectus sheath, which is coming like this and inserting onto the linea alba. So just below the linea alba, there is a fatty membrane. একটুখানি বাইরের দিকে টান, হ্যাঁ হ্যাঁ, there is a fatty curtain, rather you say, and you can, once you divide this curtain, you will be entering onto the opposite rectus plane. So I will show you.
Okay, by the time Dr. Shumanto does the brilliant operation, I think along with our anesthesia team, with the surgical team, we have the theatre nurses led by Mrs. Kajol Das, Chobi Sarkar, Nasim Farhana, Meet Bishwas, Sagorika Das, Jhorna Haldar, Shravani Kaur, and Ritesh. Ritesh is the brother. In the next shift, that means after in the next theatre shift, we will have Antara Piplai, Deboshmita Adok, Joyita Das, and Shravani Ganguly. So with them, we also have the support staff of Gyanatosh Das, Binod Ram, Moheshela, Jagadish Pal, Kundan Chaudhary, Shuman Pal, Dipanjon, Tony Hela, Amit Mullik, Raghu Rana, Ajoy, Shakil, Rohan, Manoj, and Fuli Ghosh assisting the whole team. So a loud round of applause, please, ladies and gentlemen, for all the theatre nurses, our support staff, without whose help this workshop would not have been so brilliantly and so flawlessly conducted. Thank you, everyone.
So you can see I have divided the median, the curtain, I was about to say, the fatty curtain. Once I have divided the fatty curtain, I am onto the opposite rectus. You can see the undersurface of the left rectus. So I am onto the opposite rectus plane. And again, you have to follow the loose areolar tissue plane to enlarge that space also. The loose areolar tissue plane is the correct plane.
Shumanto, your initial approach is to make space for creating ports.
Yes, yes. So this is the left inferior epigastric, you can see. So inferior epigastric should lie above along with the muscle, and this fatty layer should come down. So I'll just follow the midline. This is the midline. This is the midline. So I'll follow the midline up till the pubic bone. Once I identify the pubic bone, then again I'll come back to the left rectus space area. This is just to confirm, identify the plane of dissection and whether I am in a correct plane or not.
Hook is your prime instrument for this space creation?
Pardon, sir?
Hook is your prime hand instrument for creating this space?
This is hook. I am using hook only. So with hook only, I am till now I am using hook only. So for this step, hook is good because the loose areolar tissue can be hooked and cauterized and they will fall down. So you can see the bone.
Yeah. There's the midline. Symphysis pubis here?
Yeah, the symphysis pubis. And then once you come laterally, you will be able to identify the other Cooper's ligament and all these other structures. So once you see this pubic bone, you have to follow this plane only. So if you come backwards, so pubic bone and follow this plane, not above, not below. So you have to allow at the level of the pubic bone, you have to keep on dissecting to enlarge the space. On the other side.
Which side you are going to operate first? Which side?
First I will create I put my left hand working port. For that I have to create the space and then I will decide. Any space is okay. So right or left is fine for me. But first I have to put the left hand working port and then I will decide which side to operate first.
What I'm saying, if there is a bilateral hernia, which side you approach first, right or left?
Left, I will start with the left and then come to the right.
Okay. The plane is important. If you are in the right plane.
This is the left direct hernia. You can see the preperitoneal fat is going onto the Hasselbalch's triangle over there.
Yeah.
Okay, so I'll come to it later. But first we have to create enough space in the rectus plane to put my left hand working port. Once I put the left hand working port, then I will go to that side to dissect.
So you're yet to make the third port.
Yes. Dar. Return. Someone. একটু ধর, এটা একটু ধর, এটা একটু ক্লিন করে দে।
ঠিক প্লেনে থাকলে
ঠিক আছে, দাঁড়া, ক্লিন কর একবার, জল কি হলো, খুলে গেছে।
It's important to see that no peritoneal rent is made. Once the peritoneal rent is there, is some difficulty in going to this space.
Yes. So you can see the pre-rectus and then the preperitoneal plane is created a bit, and the inferior epigastric vessel can also be seen clearly. So I have created the left rectus space also. Now after by external palpation I am just trying to do the surface marking of the side that I am going to put my left hand working port. So preferably in this area. Then I will ask my camera assistant Dr. Shomit to hold the camera, and just to I came back onto the left hand side again, and left side of the patient, and then I will be seeing here.
Do you insert a needle to see that you're in the right place? No.
Usually I don't do, sir, because once it is clearly seen, I can put the port. So that thing is only thing you can injure is the inferior epigastric vessel. So you can see the inferior epigastric vessel is on that side at 12 o'clock position, and now I'll be putting the port on the left hand side of the inferior epigastric vessel. But yes, it's a good technique to put a needle first to see you are in a correct plane, and to identify the track that you are going to insert the port. So now I am putting the third port. এখানে আসছে, এখানে এই যে দাঁড়া, here you can see the tip of the instrument. Yes, right. Till now the gas was going through the camera port, so I will change it to my left hand working port once I have kept it inside. Now বাহাতে আমাকে সফট গ্রাস পাত দে, আর রাইট হ্যান্ডে মেরিল্যান্ডে।
Shomant, you pass on to the next OT?
Sure, sir, sure.
Other OT, you are having a patient of pseudopancreatic cyst.
Take.
Yeah. Dr. Sarfaraj Beg is going to operate this patient, and probably he will go for a cystogastrostomy. I'll give the clinical summary of this patient. This is a 32-year-old gentleman who is presenting with intermittent pain abdomen. The pain was dull in nature, arising from the upper abdomen leading to the back. There are no aggravating or relieving factors, but this patient get reduced on medications. He had several similar episodes of previously pain. which was apparently normal. The pain is actually nausea and vomiting for the last 1 week. Patient has no comorbidities and is known case of alcohol abuse. On examination, there is a 4.5 by 5 cm ill-defined, non-tender, cystic, immobile lump in the epigastric region, extending towards the left hypochondrium. Ultrasound revealed a cystic lesion in relation to the pancreas. CCT whole abdomen reveals a large, multiloculated, well-capsulated cystic lesion in the body and tail of pancreas measuring 14 by 3 by 8.1 by 14.3 with a approximate volume of 830 cc. Can the CT plate be shown?
The inferior epigastric vessel, you can see, I'm just pushing it up, okay?
Okay. There the CT scan plate, you can see the large cystic lesion and the stomach is pushed anteriorly and it's a large cystic lesion with some separations also.
Like I'm asked us there, you can
So
see
it's a
this-
diagnosis of
this is a pseudocyst.
pseudocyst of pancreas.
Okay. It also
The plan is to do
pre-peritoneal fat which was
laparoscopic
going towards the
cystogastrostomy.
defect.
The
Okay.
patient is getting ready, he will come on to
Pseudocyst টা
you.
উপর দিকে তুলে দেবো, এই
Okay.
pre-peritoneal
The-
fatটাকে টানবো।
Pass on the sound to Dr. Shumanta, OT1.
Sir,
So Shumanta, you are going to the lateral space now?
Sir, so I have identified the inferior epigastric vessel on the left hand side. You can see the nice pulsation. And coming onto the medial aspect of the inferior epigastric vessel. So this is the this is the left rectus, this is the inferior epigastric vessel, and beneath the pubic bone you can see. So
Yes.
this is the Hasselback's triangle. The pubic arch, the inferior epigastric vessel, the lateral border of the rectus, and this triangle is formed known as Hasselback's triangle. And
Yes.
this is the pre-peritoneal fat which is herniating into that space. This is known as a direct hernia. So that's why it is called a direct hernia. And you can see I am pulling the fat towards me, and you can see a whitey structure. This is known as the pseudosac. Okay, or it is nothing but the fascia transversalis again. And I am just dividing the tissues and
we can see the pseudosac, yes, very
just
nicely seen.
pushing the
We are pushing
pseudosac
it
towards
out.
the defect.
Yeah.
So this fat should fall down and the pseudosac should go up. Here, like this. Okay. So now you can see the Cooper's ligament also, the glistening white structure. This is the Cooper's ligament.
Yes.
Okay. And the direct area, the weakness, area of weakness. The left hernia is a smaller one. Right hernia was the bigger one clinically. So I'll first dissect the left side. And this is the whole pubic bone you can see. The idea is to dissect at least 2 cm below the Cooper ligament. So small vessel can be easily cauterized using the
Shumanta, you are doing a very good dissection.
Thank you,
There
sir.
is almost no bleeding here in the right plane.
Hi.
And in every case, you need to also exclude a associated indirect sac.
Right, sir. So I'll be, after doing a little bit of medial dissection, I'll be
So
coming
once
on to
you
the
find a
lateral
direct
aspect.
sac, you have to dissect the deepening area and go to the lateral space and also
Should I go
exclude that is associated. Sometimes there may be a small indirect sac also.
Yes. So I'll definitely look for the, because you have to enlarge that space to place the mesh. So you have to see lateral dissection is also very important. So I will come into that area lateral to the inferior epigastric vessel, and then with my tip of the instrument I will try to enlarge the space like this. Like this. Okay, come. Here you can see a membranous area. So that is the potential space that you need to create. This is the lateral space of Bogros. It is coming out.
Yes.
But you have to enlarge it. And for that you need to do this kind of dissection. The tip of the instrument should lie together, and then you
So
stick.
again, like TAPP, you need to go just medial to the anterosepaliac spine.
Yes.
That is the limit of lateral
Sorry.
dissection.
Yeah.
Because to place a mesh of 15 by 12, you need this space.
So for dissection on the left hand side, I am standing on the right shoulder. Again, while I will be doing on the right groin dissection, I will be standing on the left hand side, left shoulder. Okay, so this is the area that I need to enlarge. Here, the loose areolar tissue plane, again, loose areolar tissues are your friend. So
Yes.
here you can see.
Yes. Very, very nice dissection. You're on the right plane.
Yeah.
Almost there is no bleeding.
So again, a little bit of space creation. I'll try to create more space.
So this is the region of deep ring. You will find the gonadal vessels here.
First, I'll dissect all these structures, loose areolar tissue, which are actually holding the inferior epigastric vessel. So that inferior epigastric vessel should be safeguarded first, and then, so if there is any indirect hernia or cord lipoma, it should lie in this area, lateral to the inferior epigastric vessel. So I will come, but first I need to dissect this space a little bit more. Okay, again come here, here. So again you can see a loop-like structure. The initial last scales also I have demonstrated. This thing is coming from this area. You can see from the lateral. Pechone thak. See, while I am pulling this iliopubic, this is nothing but the one fascial extension of the iliopubic tract, which is coming behind the cord structures. Okay, so iliopubic tract, anterior suprailiac spine to the pubic tract. A part of the iliopubic tract, which is a fascial extension, which is nothing but the extension of the fascia transversalis, is coming behind the cord structures, and it is forming a loop. Okay, until and unless you divide the loop, you won't be able to paratalize the cord structure. Again, I am holding it with my left hand instrument, and tip of my right hand instrument, I will be dividing this.
Yes.
See? Be gentle, be slow.
Sumanta, show the peritoneal margin, peritoneal lining here.
Peritoneal lining is down, sir, only. So here you can see the peritoneum down there.
Yes, yes.
Okay, so I am just good. I am at a good enough distance from the peritoneal margin. Medially. So this pulsation, you can see, this is the external iliac vein, and lateral to it will be external iliac artery. So be cautious while using any energy source near to it. Okay, so inadvertently you may injure these structures, and there will be torrential bleed, and it's very difficult to control. So be very gentle. Small blood vessels can be easily cauterized, but these vessels, once injured, is very difficult to control. Okay. So cord structures will come out gradually. I will demonstrate each and every structure. I will try to demonstrate. But first you need to divide all the loose areolar tissue. Ektu aste. Okay. So you can see the peritoneal fold here. Here is the peritoneal fold here. Okay, I am staying above to it, and these are the loose areolar tissue, maybe some cremasteric fibers which are actually holding the sac. So I will just try to. So again, you can see the sac down there. Sac margin is visible. Here is the sac margin. These are the cord structure. I will be dividing in between. Okay. Again, you can see the peritoneal reflection here. You can now clearly appreciate the peritoneum coming down. It's a pretty thin peritoneum. So sometimes while pulling the peritoneum, inadvertently you may injure the peritoneum, and then you may lose the space. So be very cautious while doing paratalization of the peritoneum. In this step is very particular. Cauterize, stay above the peritoneal fold. Okay. So with the back of my right hand instrument, I'm just pushing the cord structures away and dividing whatever structures which is actually holding the cord and the peritoneal together, so that the peritoneal will fall down once I divide those structures. Should I have to pitch it? Should I? Okay, again, the limit of dissection should be same as TAPP. Once you see the vas is turning, this is the vas. So this is the vas, you can see, it's covered by some fascial tissue. You should not disturb it. And once you see the vas is turning medially, you should stop doing the dissection. That is the one anatomical landmark of medial dissection. But till now it's coming down straight, so I'll be just keep on dissecting until I see the landmark. Hi, Kache.
The point to dissect is so that the mesh does not roll up.
Yes, sir. Okay, kache. So you can see the peritoneal reflection down there.
Yes, yes.
So laterally, I'll be going now. Come, amar dike chola hai, to suvida hobe.
So this is important, that you have to reflect the peritoneum at least 5 centimeters beyond the deep ring and the point where the vas and the vessels are diverging.
Sure, majkhane. So this is the space of Bogros that I am creating now, lateral inguinal space. So you can see the peritoneal reflection at this corner here.
Yes.
Okay.
Yes.
So peritoneum is coming down nicely.
Can the assistant put his finger in the anterospheric spine so they can idea that where
Yeah.
laterally have gone?
Anterior spine hath de. Sir, this is the, should I? কোথায় দেখ anterior ciliac spine হাত দে দেখা ক্যামেরা দিয়ে দেখা দে হাত দে ওর so here is the anterior ciliac spine so beyond the anterior ciliac spine
so up to the anterior ciliac spine is good enough for a lateral dissection.
Yeah, so কোথায় গেল আয় কাছে 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 এবার এখানটায় so you can see the vas while I am pulling the peritoneum. Vas is also tenting, so I have to release the vas from this tenting so that the vas will be majkhane Should I? আমার ইনস্ট্রুমেন্ট আটকাচ্ছি ঠিক আছে Now you can see the vas is turning medially, like this. You can see the vas is turning medially. I'll dissect a bit more over there. So you can see the another whitey structure over there. You can see the whitey structure and vas will be going below that. So vas is turning medially and going underneath there. So last case also I have demonstrated this is the nothing but the left medial umbilical ligament. Okay, so once you see this anatomical aspect that vas is turning medially and going underneath another
cord-like structure. So this is another landmark of doing the completely saying that the medial dissection is good enough. Right. And again, here you can see the you can see this structure.
Yes.
This is nothing but the obturator nerve.
Yes.
Is a left obturator nerve. Okay. So these are the third anatomical landmark where you can say that my dissection is good enough.
Yes, your medial dissection is already complete.
ভুলে গেছি চলো উল্টো পাল্টা বলে চল 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 right. I think the left-sided dissection is good enough. Sir, anything to add? একটু ক্লিন করে একবার দেখি ওদিকে কে শুরু হয়নি বাঁচিয়ে ঢোক হ্যাঁ 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 দাঁড়া হ্যাঁ চল গুড দেখা এদিকে একবার জাস্ট টু ভেরি শিওর হ্যাঁ আই থিঙ্ক ঠিক আছে তো নাকি আর করতে হবে সরে একটু পেছনে সরে হ্যাঁ বন্ধ হয়ে যাবে এইটাকে ছাড়িয়ে দিই ঠিক আছে ওকে চল এবার আমরা ডান দিকে আসি আই থিঙ্ক লেফট সাইডের ডিসেকশন ইজ ডান সো আইল কাম অন টু দ্য right dissection, right groin dissection. So I'll change my position from right shoulder to left shoulder. Again, the right inferior epigastric artery can be clearly seen here. So the right inferior epigastric vessel should lie
Dr.
above.
Sumanta, you have changed your side.
Yes, sir. I am from right shoulder, I have come to the left shoulder.
Okay.
And you can see the small blood vessels which are actually branches of inferior epigastric vessels, inferior epigastric artery which is coming down. These vessels should be cauterized and divided because sometimes once you inadvertently dissect it off, tear it off, sometimes the oozy bleeding will be there which is very nagging and it will obscure the area of dissection. So small blood vessels these small blood vessels can be easily cauterized with Maryland. Now I am just, you can see that with my back of the right hand instrument, I am just pushing the inferior epigastric up. And if this is the inferior epigastric vessel, you can see the hernial content. Again, the pre-peritoneal
it's a
fat
direct
is
hernia
going.
again.
Yeah,
Yes.
so right direct hernia, I'll be approaching. So, but before that, I have to divide all this loose areolar tissue. Aye. So right direct hernia was a bigger one. So I'm anticipating more amount of content on the right side. কাছে Here the pubic bone is getting on the right side getting delineated, and these folds can be divided. Okay. কাছে Now I will be pulling the hernial content like this with my left hand instrument. Give the traction towards the opposite side, and just apply little amount of energy and dissect all the pseudo sac
So you can see this is the pseudosac, this white structure. This is the pseudosac. I will be pushing the pseudosac towards the defect and bring the preperitoneal fat inside the area of dissection. Sometimes in situations
So
where there
this
is
is pseudosac you are pushing.
yeah, this is the white structure. This is nothing but the fascia transversalis, known as
Do you,
pseudosac.
Sumanto, do you fix the pseudosac to the
So
Coopers?
if it is a big defect, like more than 3 centimeter,
Okay.
then I will just pull the sac. After finishing the dissection, I will pull the sac and fix it with the right Cooper's ligament.
Yeah, right side hernia appears little bigger than the left one.
Yeah. So I'll just see. This will prevent post-operative seroma formation, and smaller seroma can be may not cause any discomfort to the patient. Large seromas, more than 5-6 centimeter size seromas, can cause a discomfort, and the patient may feel that even after hernia operation there is still a bulge over the groin. So it is very difficult to explain. But again, you have to this kind of counseling should be done beforehand, before taking the patient. That if there is a large indirect or direct hernia, these seromas are bound to happen. But in case of large hernias, you need to explain to the patient thus that post-operative bulges will be there, but this will not be a hernia, and that will subside with time. So that kind of explanation before the operation will give a patient a confidence. But if you have not explained the patient beforehand, and patient in the post-operative period will come with a bulge, and they will feel like even after the hernia operation, the hernia is recurred immediately. So you can see the right Cooper's ligament is visible now, and this is the inferior epigastric vessel. Again, I have to push it above and stay away from the inferior epigastric vessel. Right. Okay, better. And lateral to the inferior epigastric vessel, the medial space are more or less created. I will dissect it for the latter, but now I will be trying to create the lateral groin space. The same way, the tip of the two instrument together, and then try to enlarge the space lateral to inferior epigastric vessel. See, again. Okay.
So going to the lateral space.
Yes. So gradually the space is getting formed, the space of Bogros. And now you can see there are a layer of tissue, a fascia transversalis, which is actually going like up like this. You need to divide this layer so that you can enlarge the lateral space of Bogros more. And for that you need to use a hook. At a hook, hook. এখানে আছে. Right. So for this step, you have to press the posterior rectus sheath or the fascia transversalis like down like this, and then only just the loose areal tissue. But you have to be very cautious. Just behind this layer, the peritoneum will be there. So if you inadvertently injure this along with the peritoneum, you may lose the space.
Sir, please. What do you do? Dr. Sarfaraj, please go a little slow. Dr. Sarfaraj. OT2. Just wait for 2 minutes. 2 minutes. Yeah, sir, please. We welcome Dr. Niranjan Agarwal from Mumbai. He is here to participate in this workshop. He will be doing some good anorectal cases. So I request Dr. Sudeep Shah to please.
So on my left is our president of the West Bengal State Chapter, Dr. Makhon Lal Shah, and on my right, Dr. Niranjan Agarwal. But this particular year, he is a very important person as per the surgical fraternity of the country is concerned, because he is the organizing secretary of ASICON 2022. And this conference, as you know, is being held, physical after a good many COVID years where we didn't have any conference. So since he has come here as our resource person, I would request our president to felicitate him.
Dr. Shudev Shah is handing up a memento from our side.
A small memento on behalf of the organizing committee.
This is small, what is big? এটা আবার সেই loop of straddle, হ্যাঁ এই যে
So
divided.
we'll have second session for the anatomical case. Start now.
No, as soon as the TEP gets over, this OT will be entirely Dr. Agarwal's.
Okay, okay. Sound 22. Sound 22. Dr. Sarfaraj.
Yeah.
Yes, we have not been briefed. We have given the summary of this case.
Okay.
So tell us how you have gone in. What are your reports? Where are you standing?
Okay. Just I will just take out this. ये नहीं काम कर रहा है ना एटा होच्छे ना
This is a pseudocyst going on.
So I just give you my port positions.
Yeah.
Do you have an external view?
Yes. Very nice view.
External view, do you have an external view? Makonda, you have an external view?
Yes, very good view. What system you are using?
Okay, this is a Carl Stoss. I will just show you the external view. Okay.
Keep audio to OT2, eh?
I will just show you the port position. Can you
Yeah,
just keep
port
it
position,
there?
your position.
Yeah. This is the xiphoid process. This is the umbilicus.
External camera, please. Show clearly.
Can you
Yes.
see with the laparoscopic camera? Because there is no external camera here.
Yeah.
Hey, but he's. এটা দেখাবেন?
Sister, আসছে।
This is the xiphoid process. This is the umbilicus. We have made a 10 mm trocar just below the umbilicus. Because the cyst is so big, I have to keep enough distance from the cyst inferior wall. Generally, our tendency is to go through umbilicus, but always keep it below. In fact, I could have kept it even further below and readjusted after the cyst is decompressed. Yeah. Two more ports on the right pararectal, one port in the left pararectal. If you see like this, you can understand this is the xiphoid, this is the 10 mm port, these are two right pararectal, this is one left pararectal.
You are standing in between legs?
No, we tried to do between legs, but there is no leg feasibility for that. And the lithotomy is such that it will not allow the instruments to move.
Okay.
So
it cannot be made leg apart.
Yeah. And generally, I don't mind standing on the right because that's how we do our bariatric surgery also. Some steps, not all steps. And then what we are doing is I am coming from the right side and I am going to open the stomach at the most prominent portion of the cyst wall. You can see that I've already scored.
Anterior gastrotomy are doing.
Yeah, anterior gastrotomy, I mean. Yeah. So what I'm doing is I first use the hook, but it is not very accurate, so I switched over. You can see that I have scored it already. What is the meaning of scoring? That is the diathermy here. Till here I made so that I know that this is the area I want to open. There is also a Ryle's tube inside, so as soon as I enter, I will know and I will see the mucosa here.
You always use a ligature or you can use a harmonic also?
I can use a harmonic also, but it's not here, so whatever is available, it is fine. Also remember that this patient has got some you look at these collaterals. Can you see this, these gastroepiploic are so big?
Yeah.
Which means this patient has developed some sort of a left-sided portal hypertension. So I would be a little wary and I will use a good energy source for whatever I do. In fact, I am expecting bleeding when I open the cyst wall. So even that I'm anticipating.
Yeah, if there's portal hypertension, these vessels are very notorious to bleed and difficult to
Yeah.
control even with a good energy source.
So now I've opened this thing adequately. What I will do now is, I am going to do some everting stitches. You can see the posterior wall of the stomach here.
Cyst is bulging inside.
Yeah, the cyst is here. I can feel it. I am going to do some everting stitches. So give me silk, please. Silk 20 silk. इसको निकाल लो. दे दो हमको दे. निकाल लो. So I am going to take 20 silk from the 10 mm port inside and park it there, and then again we will do some stitches to evert, because we want to have good vision while doing a cystogastrostomy. Also, sometimes the liver is big, we may need to do liver retraction in this patient. That is not the problem, so we don't need to put in extra ports for the liver. Oh, this is still here. So, nahin, रुक जाओ, leave it.
You take a everting stitch on the cut margin of the anterior.
That's right. I will take some stitches on the cut end of the gastrostomy. I will do that. हाँ, हवा नहीं निकल रहा ना? Yeah. So go in, please. And you will see those silk stitches. Now you will see what I will do. I am going to take, since I am standing on the right side, stitching is a little different. Don't show the metal of the trocar. And there is some problem with the CO2, and that is why you will see continuous fogging in this operation. I've tried to rectify for good demonstration, but so far I have not been able to. So what we will do is, we'll take this.
The telescope is fogging. Just
it is a
just
bad-
little hot water.
We tried everything. But ठीक है, I will manage. There are some big vessels, so I need to avoid. निकाल लो बेटा, और क्या करोगे? गरम पानी लिया? लिया. दो लगाओ. So we will make these stitches at the top and the bottom. What will happen is this will become prominent. अंदर है ना. काम आएगा. So our idea is to now aspirate. So I'll need a long aspirating needle to be sure that we are not aspirating blood. And if there is only clear fluid, then we are sure we are entering to cystogastrostomy. This is not a walled-off necrosis, somebody was asking, because this is already more than 6 weeks, and if you look at the CT, you can see the C-cyst wall has also matured. There is no history of chronic pancreatitis, looks like a sequelae of acute pancreatitis. Okay, so there you are.
Safar, I think this patient being a chronic alcoholic, we need to exclude associated chronic pancreatitis also.
Yeah, so I'm just going by what I was told. Does he have a history of alcoholism?
Yes, yes.
Okay.
Patient has got
Then
alcohol
of course,
abuse.
Of course.
But
So now
there's
this
no
is
comment
an
about the
ipsilateral
pancreatic
suturing,
duct. But
which is why you will see it's a little different from suturing when you do from between the legs. That is more ergonomically easy than this. वहाँ से scissor आ जाएगा क्या?
Dr. Sarfaraj, suppose this patient has got an associated PD dilatation also. If the patient has got a dilated pancreatic duct on the background of this large cyst, what will be your approach? You do just a cystic drainage or?
So large cyst with what? Dilated, it's a dilated duct.
Yeah.
No, so again, it may not change the treatment, because when you see a cyst in front of the stomach, then you cannot change. Unless it is a distal tail cyst, then you can do a LPJ, excise the cyst as well, that's possible.
Yeah.
In the body, is it possible to change the plan? Technically? By doing the drainage of the cyst, we would assume that we are also draining the duct here. So this is a bad one. So you can see we will expect some bleed even in doing the posterior cystogastroscopy. I'm already making up my mind to use a blue cartridge. Okay, scissor please. So when you see suturing of the from one side, it will be a little different. So be prepared to see that the ergonomically, we will not be able to make as good as a loop when we stand between the legs. That's more triangulated. This is less triangulated.
Dr. Sarfaraj, what is the length of your gastrotomy? Anterior gastrotomy is about 5 or 6 centimeters?
About 8 to 10 centimeters so far. Okay. You can see those big veins, so I just don't want to get into their way somehow. Now what I will do is, give me one more still, please. It's ready, acha.
Yes, yes. Pass on to OT1. OT1. Dr. Shumanta.
Sir.
We are with you. We have seen the
Sir,
very
I
nice
think I have
dissection.
finished
Yes.
the right side dissection also. I'll just show
Equally
you the
bloodless.
anatomical aspect.
Yes, yes.
So this is like to bark or hookta. So this is the inferior epigastric vessel.
Tempting.
This is the right rectus muscle underneath of the right rectus at the 12 o'clock on your screen. So in between there is a defect which is around 2.5 to 3 centimeter defect.
Give me a
so this going through the Hasselbeck's triangle, the Cooper's ligament can be seen down. So this is through the Hasselbeck's triangle. So this is a direct hernia again, right PM2 as mentioned in the USG report. And then there is a Cooper's ligament and coming on to dhor ekটু ধর এটু আমাকে মেরিল্যান্ডটা দে So Cooper's ligament is coming down like this. I have dissected 2 centimeter below the Cooper's ligament. Okay.
Yes, yes, there will be space.
Space of red GS.
Yeah.
And then medially there are important anatomical landmarks are like this is the whitey structure, this is the obturator nerve. Okay, this is one point where you should stop doing medial dissection. Then coming on to this where the vas is turning medially, you can see vas is coming down like this and then again turning medially and will be going beneath the median umbilical, right median umbilical fold. So here, somewhere around here, will be the median umbilical fold. It is going below that, you can see. Okay, it is going below that. And then again, this is a pulsation, you can see. This is the external iliac artery.
Yeah.
Medial to is the bluish structure, external iliac vein.
Yes.
And coming on to the triangle of doom, this is the triangle of doom. Gonadal vessel, vas, and this space.
Yes, very nice demonstration.
Okay.
Yes.
Then coming on to the lateral aspect, there was a cord lipoma here. You can see that other than the cord structure, there is good enough space over here. Actually, this is because the cord lipoma. Dekha niche dekha. See, this.
Yeah, we find a big lipoma dissected
Yeah,
out.
big cord lipoma was there. So I have dissected it off. So again, the cord lipoma, I always look for the cord lipoma. Whether
You
it is
like
there
to
or
excise
not.
this pad of fat or
Yeah,
you just
no,
keep
no,
it?
I just dissected it off and keep it like this medially. So cord lipoma is dissected off all along, and then this is the psoas muscle. Dekha, ekhane dekha. Psoas muscle, you can see the nerves going on to that.
Yeah.
Genital branch of genital nerve, then
And the
lateral
psoas
femoral
minor.
cutaneous, all the other nerves are going like this. And then coming on to the lateral aspect, this is the space of Bogros. Space of Bogros, this whole space of Bogros, the triangle of pain is formed by the gonadal vessel, the iliopubic tract, anterior superior iliac spine to pubic. There will be the iliopubic tract here. Here will be the iliopubic tract and below the peritoneal fold. So I have dissected enough to put the peritoneal fold down so that this is a triangle of pain, lots of nerves. So no part of the mesh fixation should be done below this iliopubic tract. You may injure, you may entrap the nerves and that can cause severe postoperative chronic groin pain. And then this is the fatty layer, you can see this is the Dulux fat or Dulux fascia, which is actually covering the psoas muscle and the nerves overlying it. So
the dissection should be good enough that you have to measure that at least 5 centimeters, 5 centimeter from the down and proximally 5 centimeter, downwards 5 centimeter, and medially 7 centimeter, laterally 7 centimeter. So that you can place at least a 15 by 12 or 15 by, minimum 15 by 10 centimeter mesh over that area. If
Sumanta, do you need to dissect this lateral peritoneum? Yes, this part?
The downward dissection I have done.
Yeah.
My mesh will be placed like this, obliquely. Okay, so if it is required, I can divide a bit here. I can divide a bit here, but I think I have done enough dissection. I can accommodate the mesh.
Yeah, there is adequate space for the mesh to be placed.
Yeah. So
Okay,
I'll just
fine.
put the mesh.
Very nice dissection.
Thank you, sir.
Almost bloodless.
Thank you, sir.
That is how it should be done.
Thank you, sir.
And what's your fixation strategy for the mesh?
So no fixation, sir. No
you
strategy.
don't even fix one in the Coopers?
No, sir. If it is a large hernia, I mean more than 3 centimeter defect, then I will fix the mesh. Otherwise, in TAPP or TAPE, I don't fix the mesh.
Do you use anatomical mesh that is now available?
No, I don't use anatomical mesh. I use only flat mesh.
Okay.
Flat mesh, medium weight polypropylene flat mesh.
Because these are costly, but this follows the curve of this area.
But it is not required, sir. The flat mesh usually lie nicely over there. I'll just demonstrate that also.
Yeah.
Mesh, gloves change.
Audio to OT2. Audio to OT2.
Yes, I
Yeah.
can.
Sarfaraj,
So what I have done is a very technical job only.
Yeah.
I have made 4 reverting stitches on the anti-gastrostomy so that you can see the posterior wall well. There is no need for any retraction required from the assistant. And then what I've done is I've taken this stitch is on the wall of the cyst and the posterior wall of the stomach. So entry wall of the cyst and the posterior wall of the stomach are taken in this stitch. So what happens is when I'm going to decompress, it will not fall apart. That is what it will help me do. Now what I'm doing, I'm taking aspiration needle and I will put it inside and I'm going to aspirate. And if you can, somebody can see from outside, they could have shown that it is a hemorrhagic fluid. I will just take it out and
Cystic fluid is a bit dark in color.
yeah. So you can see those fluid, right? I will just show you. You can see the fluid color now. I don't need to show you now because you can see this overflowing from that area. Now what I will do is I am going to make
show this.
Yeah, if I can, I will go through this area or I might choose a different area, but I will now make a posterior gastrotomy, enter into the cyst wall and fire a stapler. So,
you will fire a stapler in the posterior wall?
Yeah, I will do a cystogastrostomy with a stapler. I'll show you.
Can it be sutured after incising with the ligature?
So I will just try to make things as easy as possible. Ek blue stapler load karke rakho. I want to make sure that we do this safely. I can in fact suture this entire thing, but it will take time. Rather the posterior gastrotomy, if I can just suture and the rest I can fire one stapler, it will give us far more security. It is not only about skills, it's also about being safe. It will be much safer. I'll just show you how this will look. So I think I should take a hook and enter. Give me a hook, please.
There used to be a lot of debris inside the cirrhosis, so need to remove all the...
We will do that. So I am going to first make this.
So you are using a green stapler?
I think blue because I am more worried about hemostasis in this case.
But the stomach wall being thick and cyst wall, green would be a better choice?
Stomach wall, I will see the thickness. I will decide on the stapler a little later. I am more now worried about the hemostasis because of those veins. So first thing I am going to do is I can see that I have, because they are going to bleed. You can see already that it start bleeding and then we will lose it. So another option I have got is to make a port at the top here, go right inside and then cut with the diathermy on it. So that's another technique that we use in difficult situations. I will see what I can do. I am contemplating. I think ऊपर से ना एक वो पकड़ते हैं. I can see that wall here. Okay. So if I can, So if I can just push one trocar directly and then open on it, show me with the camera.
Dr. Sarfaraj,
Yeah.
Dr. Sukumar Maiti speaking.
Sir, কেমন আছেন?
Hello. Where before opening this posterior wall into the cyst, and you have said you will use the stapler. Is it whether a stay suture?
I have given a stay suture, sir. Here is a stay suture.
Not. Oh yes, you have taken. How many stay suture you have taken?
Only one, and that is basically on the cyst wall and the stomach, posterior wall of the
Stomach
stomach.
wall.
I
So-
can take one more here and
Okay,
divide in between. That is also possible.
Okay, that will help to make the opening and also
Okay.
to apply the stapler.
ठीक है sir. I
More
will do.
than
I
one.
can actually see the cyst wall here. That is why I was wondering, but it's okay. Give me another stitch. नहीं वो silk. That's a good idea. The other idea that I was contemplating was to put in a direct trocar from the top here into the cyst wall and then cut over that trocar. So generally if I can use a plastic trocar, it will not conduct electricity, and that is something I can do. इसको निकाल देना बेटा. ऐसा गॉचपी से ढुके जाना. So you can see how much of bleed it is still happening just because of small nick. So it's
Probably there is associated gastritis.
no sir, there is hypertension. You can see. Show her the collateral. You can see the collateral.
Hypertension is there, huh? Oh.
That is because of that. So in any case, उसमें जाएगा ना? Why are you giving me? Silk. सीधा मत
Audio
करो.
to OT1. Audio to OT1.
Sir, Habib. सीधा मत करो.
2000-15,000 টাকা করে দাম
Dr. Sumanta?
স্যার
Yeah. You have trimmed the mesh to 15 by 12, eh?
Yes, sir. 15 by 12. I have fashioned it in the same manner I have done for the last case, and then I have placed it inside and unfolded it, and just want to tuck this mesh behind the peritoneum so that no part of the mesh should be, no part of the peritoneum should be behind the mesh. Peritoneum should not go behind the mesh. Peritoneum should lie always anterior to the mesh.
Yeah. Yes.
So that is the most important part while placing the mesh. So you can see that the mesh is nicely sitting, and there is no undue folding. You can little bit of
So you
adjustment.
said there will be no fixation. So
No
you place the
fixation
other
is
mesh,
required.
overlap
So
it up.
keeping the defect in the center, keeping the defect in the center, I have covered almost. You can see the 5 centimeter, 5 centimeter from above below, and 7 centimeter on the laterally and medially.
Okay. Thank
And
you.
below.
Thank you,
Thank you.
Sumanta.
Thank you,
Very good job you have done. Very nice dissection, almost
Dissection.
bloodless.
Thank you, sir.
You're in the right plane. That is how it should be done.
Arekta mesh.
Okay,
One
thank
more
you.
mesh.
Audio to
এটা ধরে রাখ এটা
anticipal explain. Anticipal explain that.
নাড়াস না
Bailout hernia. So same dissection. Safaraj, you are putting suture here at the posterior wall?
Posterior wall with the cysts. Yeah, so it's containing both the stomach as well as the cyst wall. काट दोगे उसके ऊपर please?
What length of stapler you are planning to fire?
अच्छा हो गया. 60.
60.
Yeah. Suction कर दोगे please? देखें, wait.
So you have a 12 millimeter port?
Yeah, I have. बिना मेटल के बेटा. Straight हो गया.
You take the stapler to the right mid-clavicular port?
Yes, so I will take the one through which the Maryland is coming, or the one through which the, I think I will take this one, because it is in the line of the cyst, so maybe the lower mid-clavicular. I haven't yet taken out all the sutures. They're all the needles are lying in the parking lot which is just above the liver. Bada. Suction le lo. So now we have got 3 needles all parked at the top and 1 gauge piece which can come very handy in cleaning this area. Remember, it will bleed. When it bleeds, we will just lose all vision. So we have to be ready with that. So that is now the, as Dr. Sir was saying, that if we have, here, hold this. Now I can, आगे हेल्प करिए ना से, हवा कहीं से निकल जा रही है. ओके, मैम, अंडर कर थोड़ा मसल रिलैक्सन लगेगा, थोड़ा से नीचे आ गया. Okay, so now we are ready with these 2 stitches to go in between. Still there's some bleed, but it's okay. We will take a bipolar now. Give me a bipolar, please. Give it to me. And we will go a little easy. I'm going to buzz this a little bit. Without taking the, I think, एक वहाँ पे एक और port बनाइए तो, on that side. Then we will do this. हाँ, give me one more port, so that we can have a suction ready if need be. ये एक रहेगा, like this. पकड़ लीजिए, मत छोड़िए. हाँ, give me one more for. आप ऊपर आइए. Come, be comfortable. एंड यहाँ पे दे दे एक नीचे, दे दो, देखो, 1 more 5 here. हाँ ठीक है, ओके. सक्शन वहाँ से दीजिए. टेक अ सक्शन. या, गिव मी अ हुक नाउ ऑन दिस साइड.
Pass on to OT1. Pass on to OT1. Sound to OT1. Yeah, Dr. Sumanto.
Sir.
Yes. So you are place the mesh with good amount of overlapping.
একটু আস্তে শুনতে পাচ্ছি না.
Yes. So both the meshes are placed.
Yes, sir. So you can see that if you have done enough good enough dissection on the lateral and medial aspect, so once you unfold the mesh, the air pressure, the pneumo pressure will automatically push the mesh over that area and it will fall into place.
Can the late mesh be pushed little more laterally?
Sir?
Lateral, the late.
So in case of direct hernias, I will concentrate more on the medial overlap. In case of large indirect hernia, I will concentrate more on the lateral aspect.
Yeah.
So that is my actually practice. So there is no indirect defect over that side. So from this area, around 5 to 6 centimeter is there.
Yes, you have gone beyond the deep ring.
Yeah.
Yes. But I find there is a huge amount of mesh overlap in the midline.
Yes, sir. So this is the peritoneal fold you can see, and the mesh should be lying above the peritoneal fold.
Yeah.
Like this here, and then the medial part you can see that good amount of overlap is there, at least 3 to 4 centimeter, 4-5 centimeter overlap is there. And then again I will confirm the position of the previously placed mesh on the right side just to align it nicely. Yeah, like
yes,
this.
defect
I
is
think,
well covered. Yes.
I think that is done. If there is hemostasis, it has been confirmed beforehand already, so there is no bleeding.
Perfect hemostasis. There is no bleeding at all.
Nothing is there.
Yeah.
So I'll just keep my I'll ask the just into normal position, neutral position.
So keep the instrument there and then deflate.
Yeah, I'll keep the instrument on the lower aspect of the mesh. Lower aspect of the mesh like this, and then the instrument like this, and then I'll gradually deflate the pneumoperitoneum here, like this and like this.
Yes.
Thank
you, Shumanta.
Yes, thank you, sir.
Fantastic job done. Very good case for demonstration, and this is how it should be done. Thank you, Sumanta.
Thank you, sir. Thank you so much. Thank you so much.
Dr. Sarfaraj, we are back with you. OT2.
Okay, we're just trying to make sure that that bleeding can be circumvented and we can enter into the cyst under controlled manner. नहीं उतना दूर मत जाओ. We should be able to. No, अभी भी नहीं आया. Be very careful what we are doing. It's okay. It's okay. It's okay. That is fine. छोड़ दो. छोड़ दो. Now we are dissecting. मत करो. Give me the gauge, please. Show me the gauge, please. Show. So maybe we are dissecting between them. So we're not able to enter. We'll have to probably go from the top. Once more we'll try, but let's first have a hemostasis. I'll keep it pressed for 3 minutes. And then again, the other option is to make a 5 millimeter plastic port लो दो या 10 millimeter plastic वो जो सामने है ना और एक है वही चाहिए हाँ उसका 2 चाहिए 2 हाँ so what I'm going to do is see this is a I can use 5 you have a 5 millimeter plastic ले लो so the other option that we do is sometimes this is what the problem is with the bleed. As soon as you cut the posterior wall, will hamper your vision and this will not allow you to enter safely. So what we'll do is we'll put in a 5 millimeter trocar right from vertically from this point into this and then we will cut open the cyst on it. That is safer and that will definitely give us a good access into the cyst. So just bear with me. These are good tricks to learn, especially when you're doing these cases. This patient is bleeding more because of the collaterals. If these collaterals were not there, I would say that this would be, just a 2-minute thing because you would have gone into the posterior wall, you would have seen the cyst wall, and we are using good energy sources. Despite that, we are having bleeding, which means this patient definitely has got good collaterals there which are bleeding. Need to be careful here. Keep a bipolar instead of this. Add a bipolar on, with that instrument and make that 50. Make that 50. Ready? 5 plastic आ गया? Could have gone inside. Somehow we didn't. Bipolar लगाओ इसमें. Can somebody do that for me? हाँ, तो उसको रहने दो. Bipolar लो. 50.
टीबीटा हो गया
बाइपोलर नया आते जब तक इससे करो लिगा शॉट दे दो उधर से वहाँ से दो.
Dr. Madhumita Mukhopadhyay has joined with us.
Welcome.
So she'll keep in moderating. So your now job is to fire a stapler in the posterior wall.
Please. Somebody is releasing. Yeah. So what we are doing is हवा कहाँ से जा रहा है देखो. Keep it to your side. Yeah. So bear with this. This is not going to be a pretty sight. We'll try to keep it as controlled as possible. हवा आने दो पहले. हवा आने दो. So we need to be patient here, not be in a hurry. If we are in a hurry, then we will actually lose vision. हवा नहीं है क्यों? कोई शक तो नहीं कर रहा, मैं तो नहीं कर रहा. थोड़ा पीछे आओ. थोड़ा पीछे आ जाओ. Keep the pressure low, blood pressure low. Ma'am, keep the blood pressure low. Okay. थोड़ा कैमरा पीछे. This is the. नहीं वो वाला रेस फॉल्स आ रहा है. No, तुम्हारे लिए एंगल ठीक नहीं. छोड़ दो. It's okay. छोड़ दो. Yeah, I will give you the पीछे आ जाओ थोड़ा सा. हाँ, yeah. थोड़ा पीछे रहो. give me the bipolar, you take the suction and give me the bipolar. But bipolar should, yeah, suction should be through intelligent suction, not anywhere. दो bipolar दो. थोड़ा सा जगह कम क्यों हो गया? सलीम देखो ना, 8 क्यों है वो? हम लोग तो कुछ अपना रिलैक्सेशन ठीक है मैम, बिकॉज हमारा स्पेस नहीं, हमारा स्पेस छिलो किंतु ये पेटটা एकदम थोड़ा पीछे रहो ना. Okay. Wait. Take your metal out. Yes. ठीक है, रहने दो. It's okay. Just keep it there. Ma'am, pressure tag कमी दिन तो. Pressure tag कमी दिन. Suck here. Suck here. हाँ, हो सकता है. I'll just keep this pressed for some time. हबीब को कैमरा दे दो, तुम जाकर उधर सक्शन करो. हाँ. थोड़ा और आना, मैंने आई नहीं सम. बाइपोलर देखें. इधर नहीं. So suck intelligently. We will have to see that place. There is no space though. Suck so that the blood is not there. नहीं हो रहा है. बाइपोलर काज করছে কি? तो बढ़ी दिन ना. देखें. बहुत वीक है. बहुत वीक है. छोड़ो बेटा. देखे देखे देखे. हाँ, that's the one. That's the one. That's the one. सब कर सकते हो. सक प्लीज. उठा के रखिए ऐसे को, आपका वो बहुत नीचे है. और उठाइए. जगह नहीं है क्या? तो हवा कहाँ आ रही है? आई थिंक ये लीक कर रहा है फ्रॉम द जॉस. चलो, हवा मत निकालो. हवा नहीं आ रहा है सम हाउ कहीं से. तो भी निकाल लो. निकाल जाओ. साफ करके आ जाओ. I think we may have coagulated the vessel, and hopefully we will have a cleaner view. कहाँ से आ रहा है? Okay, I got it. ये निकल गया है. ड्रॉ कर दो तो. घुसो. इसका ड्रॉ कर. इसका. देखा मेरे को. अभी भी है. Okay. Do we have space now? हवा है अभी? हवा अभी भी नहीं है, ये तुम्हारा हो नहीं रहा है, छोड़ दो बेटा। हाँ वही वही, अच्छा और उसको पकड़ना होगा, ये लो अब ऐसे पकड़ो, ऐसे और ऐसे घुमाते रहो, पकड़ के घुमाइए। हाँ अब हट जाइए, मेरे तरफ मत आइए, उधर 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 अदर साइड, नहीं नहीं, हाँ हाँ
What is the fistula?
उधर जाओ ना बेटा।
Okay, in the OT1, we are going to have a anal case to be done by Dr. Niranjan Agarwal from Mumbai.
जाओ तुम जाओ, कोई एक तो जाना पड़ेगा।
Dr. Debarati Raichuri will give the brief about the patient. So, Dr. Niranjan Agarwal is going to do a lateral annular sphincterotomy. So, Dr. Debarati, please give the details of the patient.
सक करो भैया जल्दी से।
The patient Rajiv Das, male 16 years, presented to the OPD with complaints of pain in the perianal region associated with a burning sensation during defecation since the last 6 months. There is complaint of intermittent bleeding per rectum during defecation resolving spontaneously since the last 6 months. The patient has a history of constipation. On examination, there is a skin tag at 7 o'clock position along with an active anal fissure at 7 o'clock position. Currently, the patient has no active bleeding. The plan is to do LAS under spinal anesthesia, under local anesthesia. Sorry.
Picture 21 is we want to see the points of block. OT1 is on? No, getting cleaned. Okay, okay.
জাস্ট একটা 24 ঘন্টা কম্প্রেশন দিয়ে রাখ, চলো কভার করে দাও। হ্যাঁ সব নিয়ে থ্যাংক ইউ।
Sound 22. Is a bleeding from the posterior wall, Sarfaraj?
Yes, yes, it is.
Yeah.
So as I said, now we were anticipating this. I have the last trick, but first I will have to stop this bleed. Then we will use our trick of putting in the trocar and then. But first, let me stop this bleeding completely. Suck, 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 suck. Go closer and suck. Ah. Here, 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 here. Here. Suck that please. Yeah, yeah. So that should be don't leave it. Now leave it. Give me the gauge piece. Gauge piece. Gauge piece. Yeah. Suck on the gauge piece, please. Suck on the gauge piece. जगह खत्म हो गई क्यों? हाँ. हाँ पूरा सक कर लो. Suck on the gauge piece, please. नया गॉज पीस एक ले लेना. एक प्लास्टिक ट्रोकर देना ना मेरे को. हो गया? अब मत सक करो, अभी हवा आने दो. ये तुम्हारा ट्रोकर निकल गया.
ना एक ब्लीड করছে মারতে থেকে কমছে.
उधर देखो, वहाँ पे तुम वेन मार रहे हो. दिखाओ बेटा जहाँ काम हो रहा है. ठीक है, ऊपर चलो.
না এখানে
ऊपर चलो.
গ্রিন শেপার দেওয়া উচিত. গ্রিন মানে ব্লিড করছে তো গ্রিন শেপার না দিলে ওয়ালটা নাও নিতে পারে. ব্লু আছে,
আনএক্সপেক্টেড ইনসিডেন্ট হয়,
ব্লু আছে না, ব্লু স্টেপলার না, ব্লু স্টেপলার
স্টেপলারের মধ্যে ওরা সবই নিয়ে আসে
না, গ্রিন হলে ভালো হবে এটাতে.
হোয়াইট হলে ভালো হতো।
Hello.
না হোয়াইটে কম.
Hold this.
হোয়াইটে থিকনেস কম.
Give this to me. This is बस. और वो देखें, ट्रोकर देखें, नीडल देखें. नीडल दिखाओ पहले. वो जो एस्पिरेशन नीडल, व्हाटएवर नीडल.
একটু লাভাজ টাভাজ করতে হবে.
I will make this trocar go into the thing. Syringe दो. थोड़ा सा हटाइए. थोड़ा सा हटाइए और कैमरा थोड़ा पीछे जाएगा. दीजिए नाइट्रो सिरिंज. कॉस्पीस वापस लगा दो. हवा क्यों चला जा रहा है बार-बार इतना? Don't suck when there's lag. Syringe. ठीक है. थोड़ा पीछे रहो बेटा, थोड़ा फोकस भी तो रहना होगा. वो दे दो. जगह चाहिए, स्पेस चाहिए. पाँच है, पाँच. That thing. या छोड़ दिए बेटा, छोड़ दिए बेटा. अच्छा, अब सक्शन देखें. सक्शन दिखाइए. ये ट्रोकर भी निकाल दिया. अब निकाल लो, देखें क्या आ रहा है. अभी हम लोग ठीक जगह पे हैं. नाउ वी हैव टू जस्ट कट ओवर इट. मगर स्पेस कहाँ है? स्पेस चाहिए यार. तुम उधर देखो, तुम उधर मत देखो. इसको ऊपर करो, इसको ऊपर करो. देख रहे. उधर देखो आप. इसको इधर से दिखाओ. उधर से. इस छोड़ दो इसको बेटा. ओके. सक्शन तुम्हारे पास है. आई थिंक वही निकाल करके, मगर स्पेस ही नहीं है तो पूरा चला जा रहा है. तुम कैमरा कर रहे हो, तुम कैमरा सही. करो. नहीं होगा. No, too much of. Could have been simpler. It's too bloody actually. निकाल लो. सक्शन हमको दे दो. एक बार. Give this to me. Okay. It's not bleeding now. And this is the now I will tell you to just withdraw that. वो नहीं ready करो बेटा. थोड़ा सा withdraw करो. हल्का हल्का withdraw करो. And go in when I tell you. हाँ चलो आहिस्ते आहिस्ते. आ रहा है ना. स्टेपलर रेडी करो. हाँ 12 ट्रोकर करने दो. और एक वहाँ पे सक्शन दो पल्लवी को. ऊपर से क्यों आ रहा है बेटा इतना?
Dr. Sarfraz, is the cyst content drained?
Cyst content what?
Is the cyst content drained properly?
अंदर आओ. Yeah. So now you can see us going into the cyst wall. Go inside. Can you see that we are inside the cyst wall?
Yeah.
नहीं अभी रुक जाओ. थोड़ा आगे मत जाओ. I will just make that more clear, and then when I fire a stapler, then you will see that it will become easy to appreciate. ऊपर से एक वो ले लो ना. हाँ, don't take my section, take another section. Go from the top. I will just now and make you understand. This is our trick when we get into trouble. If it is not opening up easy. Stapler ready? Don't know, beta. ये अब मेरा सेक्शन ऑन हुआ. मगर अब मैम का ऑन कैसे होगा? You need 2 sections, I said. मेरा तो हो रहा है, तुम्हारा हो रहा है? Just clean that area where we will fire a stapler. Go inside when I come out. Don't say that. Okay. Give it to me, give it to me, give it to me. Keep that way here. Let me just be sure that we are in the wrist wall. Chalo bhai. I will just do a cystoscopy. ये पकड़ो ना, एक जन गिर जा रहा है, बाहर आ जा रहा है. थैंक यू. और ज़रा एक जन मेरे को वो दो तो बेटा सक्शन करते रहो आप. हाँ, ये दे दीजिए हमको. हाँ हाँ, एक सेकंड.
Cyst appears almost empty.
Yeah, it is empty. निकाल लो. So I just wanted to check that we are not in between. We are not dissecting between the wall and the stomach. We are in the cyst. That green color and yellow color is sure shot that we are inside the cyst. But I want to just make a little more certain.
Can you pass on to OT1?
Bipolar. Yeah.
OT1, Dr. Agarwal, can you hear us?
Yeah, I can hear you.
Yeah, we would like to see the point block you are making for doing this case under local anesthesia.
So, I'm going to demonstrate this Fisher case, lateral sphincterotomy under local anesthesia with some sedation. So, sedation has been given? Yeah. So, my anesthetist has given full set and Fortwin, right? What have you given? Full set and Fortwin, right? And atropine, tramadol and midazolam. So,
yes. He is on infusion or given a shot?
Hello?
He is on midazolam infusion or he is given a shot? Patient is on midazolam infusion? Sound to OT1?
It is single shot.
Yeah.
No infusion. And what I have taken is a xylocaine with adrenaline and a sensorcaine mixture.
Yeah.
Normally we use a 25 or 26 gauge needle, which is 1.5 inch, because smaller the needle, the prick is lesser painful, and a little amount of fluid will be injected at one time, which will dissect the tissues in a smaller manner, right?
Yes, sir. It's good practice to use a 26 gauge needle, the initial puncture.
So right now I'm using a 24 needle. The first thing is to inject in the subcutaneous area. You need to sedate this patient.
So what's your plan? You do a peri-anal block first and then?
Yeah, once I'm planning to do a lateral sphincterotomy on this patient.
Hey, block. How do you block?
Yeah, block. I'm just telling you, the patient needs to be sedated completely, please.
You block the pudendal.
Yeah, because he is going to prick otherwise. So first thing is I'm going to raise a bleb beer at 6 o'clock position.
Yeah.
He's a young, sensitive man. Okay. Normally in such kind of sensitive men, we even give ketamine around 10-15 milligram to keep the initial prick painless. Then the second prick is anteriorly.
You do a pudendal block also at the level of ischial spine?
Yeah, there are two types of blocks which we use. One is a perianal block and the second is a pudendal block.
Yeah.
So right now I am just giving the perianal block. See, I am requesting my anesthetist to keep the patient calm.
For a moment, you can pass on to OT2. Dr. Sarfraz? So you have,
Yeah, I have gone inside the, just want to be sure that we are not dissecting.
sound to OT2?
वहाँ से एक
Yeah.
section दो बेटा. तुम्हारे तब
So Dr. Sarfaraz, after putting the stapler, how long you wait? 30 seconds?
Yeah, I'll wait 30 seconds. But this is not a Johnson & Johnson stapler. This is a Covidien stapler. So there is no question of waiting here. You can fire. Ma'am, right stoop thoda sa
Is it a
withdraw
power
kar-
stapler or just?
No, it's a simple stapler. But I'm just wanting to be sure that we have the cyst wall. Pallavi थोड़ा सा help कर सकती है. हाँ, yeah. So camera जो है ना वो दिखाएगा कि we are in the cyst wall. कैसे दिखाएगा? It will go here and it is going to show me that I am taking both the walls and there's some green color in the posterior aspect of this. So fine, looks okay now. Come back. Yeah. So with the trocar trick, we are able to at least do most of these, salvage these problems. I hope no more bleeding, because bleeding would make this.
Yeah, bleeding is controlled now.
Take this. So Pallavi, what is wanted is ये नहीं. छोड़ो इसका. What is wanted is this. How do you know that you are in the cyst? That is the most important thing from a surgical point of view. So this is what you want to see with one, and with the other you want to suck that area out and show the green. Can you see that now? Craggy thing. So we are inside. पीछे जाओ. Now we are sure. Now we can fire. If we want, we can fire one more stapler. So I'm firing now.
Yes.
That will make a big aperture of the cystogastrostomy. We'll see if it bleeds. It doesn't bleed. So we used blue because in this patient, एक यहाँ पे घुसाओ ना ग्रास पर. So more fluid now coming. नहीं कोई ग्रास पे घुसा दीजिए ना. घुसा दीजिए. Take one on your side, Pallavi. So there you are. Now the cyst is going to have a good drainage. And you can also see the inside of the cyst. Now this can be done endoscopically these days. But not everybody will have the infrastructure to do so. So the options of open and laparoscopic drainage will always remain. Laparoscopy, of course, is good, but you can see that there are certain issues with it. Now that is the pani do na mere ko isme lagao na pani. Now I have seen the CT scan. In the CT scan there is not too much of debris or necrosis. Phir nikal jao, वापस आ जाओ. There is not enough necrosis or debris.
Anterior also you will fire a stapler, you will suture.
Now we have finished with the stapling. Now I'm going to suture on my side. The one on which side, ye laga lo. The one on which side we opened up, that I will put in sutures. The stapler remains like that. So we'll use a V-lock if possible, if it is available.
Okay. Sound to OT1. Sound to OT1.
Open the full vial in this. What is this? What is this, sister? Sister, what is this? Huh? You didn't mix with that? This is BP again, na? Yeah. Give the xylocaine with adrenaline. Huh?
Can we go to OT1?
Take, where is the xylocaine adrenaline?
Hello, sir. Dr. Agarwal.
Yeah.
Can you just tell us what you're doing right at present?
So we are just preparing the local right away. We are trying to mix the xylocaine adrenaline and bupivacaine, and the patient was oversensitive. The moment we touched, he was jumping. We asked the anesthetist to give some sedation to the patient. Normally we sedate the patient initially so that the pricks are painless. Once the anesthesia local blocks are given, then you don't need any more sedation, you know. then the sedation takes, the local block takes over. The initial pricks are the painful pricks which needs to be made painless by either giving some Fortwin Phenargan or Fortwin full set or either a small dose of ketamine. Now you can give it to me. See, he is a young man and is surrounded by so many people. He is bound to be anxious, you know. So I don't blame him for jumping here.
We can do it under spinal anesthesia also.
Yeah, we can do it under, but I wanted to demonstrate to the benefit of the delegates how we do under local.
Okay.
That's why I choose. You can definitely do under spinal, there's no issue. So the posterior and the anterior dermal wheel which we raised, which have got anesthetized by now, through the same prick we are injecting on the both sides. So you aspirate and inject in the perianal area in the subcutaneous tissue. Give me a gauze piece. Gauze piece, more local.
Have you used those needles which have got 4 prongs? Means it's on a circular type of a thing and it has got 4 prongs, so we place it and then on one injection it goes to all the 4 sides.
Sorry, you are asking me?
Yeah.
What did you ask, sir?
Means instead of pricking with the needle at 4 sides, is any needle available which has got 4 prongs? So you place it directly and then you inject through one port only.
No. We use the ordinary BD needles only. Okay. And the pudendal block, this is the ischial tuberosity, the midline from the anal canal. You just prick it, the needle touch the bone, withdraw a bit, see there is no blood, and inject in a fan-shaped manner there. That's the infiltration into the ischiorectal fossa as well. Same thing on the other side. This is the tuberosity. Midpoint, go laterally, touch the bone, aspirate.
Dr. Agarwal, do you need to palpate the ischial spine by putting your finger in the anal canal?
So normally we can do it the tuberosity also.
Okay. Go middle to tuberosity.
Because it would be, when you are injecting local, you don't want to do a rectal examination right away, right?
Do you need a longer needle or just a hypodermic needle?
Normally I use a longer needle, 1.5 inch, that's what I said.
Yeah.
And a thinner needle, around 25, 26.
Maybe a spinal needle of 25 gauge.
Spinal is too long. We just need 1.5 inch actually.
Yeah.
Doesn't matter. That only minimizes the number of pricks and the amount of fluid injected per second reduces, so that the tissue dissection is less and the pain is less. Okay, now you can see he is much relaxed over here. Can I get some xylocaine jelly? So you must massage it adequately so that there is you give adequate time for the local anesthesia to act.
Yes, sir. You need time. You can pass on to OT2. OT2, please.
Yeah.
Dr. Sarfaraj, you are putting some stitch on the staple line?
Yeah, I am putting it on the left side, right side, because that is where we made an enterotomy. We haven't stapled it. So that was just an aperture. Whereas on the other side, it is a stapler. So that is not required. But this side, I need to put in stitches.
Yeah.
Otherwise, the cyst wall may fall off from the stomach and lead to peritonitis.
The anterior gastroctomy will close with a continuous suture or interarterial suture?
Anterior will be a continuous suture with a 2-0 PDS.
Okay.
Oh.
Sound 21. Sound 21.
Are you back with me?
Yeah, Dr. Agarwal.
Yeah, can you see
what's your take on closed versus open internal sphincterotomy?
What's my take on what?
Closed versus open internal sphincterotomy.
Okay, closed versus open, they both yield the same results actually. Closed is the gold standard accepted. See, now my finger is moving in easily without any problem. The local anesthetic block had acted. Whenever you insert a speculum, don't insert transversely immediately. First insert vertical because that is the split of the anal canal. It goes easily, then the next step you insert horizontally. Now you can see a posterior fissure at 6 o'clock position.
Focus
with
please.
the internal sphincter
Camera,
there
please
and
show
there.
the area.
There is a tendency that, please somebody hold this. Now you can see the fissure with the sentinel tag and the hypertrophic papillae. The base is made by the internal sphincter. So there is a common tendency that we can see the internal sphincter over here, so why not divide it over here? So when you divide it over here and it heals, then there is a keyhole deformity formed in around 30% of the patient, where the patient will keep on leaking mucus discharge, and hence it should be not done. The sphincterotomy should always be done in a lateral manner. So the usual positions are around 4, 5, 3, you can use any. I am just going to demonstrate. This is the first, this is the internal sphincter. The first depression which you feel is the intersphincteric plane, and then there is the external sphincter. So the first depression is here. When I come out, I am coming again. You can see on this side for the benefit of those who have not seen. So when you come out, this is the internal sphincter deficient there, and then the external sphincter start, right? So,
Dr. Agarwal, how do you tackle a large...
You can make it taut by pulling the speculum blade. Now people can do it in an open manner. People can insert a laser fiber through this. They can do it through laser also. You know, people are doing with cautery also. This is the internal sphincter which we are supposed to cut. This is the dentate line. The extent of the division should be only up to the
Camera, please come closer.
Line.
Camera, please come closer to this site. Yeah.
Camera kidhar hai?
Yeah.
Which side is the camera?
Dr. Agarwal, if sometimes there is a large skin tag, how do you do that? Large skin tag?
I am going to excise that skin tag.
Okay. Do you do at a fissurectomy also?
Is it visible now?
Fissurectomy along with the sphincterotomy?
Yeah, it's visible.
Yeah. You don't actually need to excise the whole fissure. You just need to excise the skin tag.
Okay.
Is it visible now?
Not clearly.
Just check that it is visible so that they can see. Okay, can you see now? There's some darkness. Please adjust the light.
The light is very less, sir.
Yes, I can understand. I can see.
Now
also.
it's better.
Yeah, no, still better. It needs to be still better. See, the light is going here. Take it from there. तो रीएडजस्ट प्लीज. नहीं टॉर्च नहीं है, लाइट एडजस्ट करो तो हो जाएगा. Yes. Better. So can you see my finger dipping into the intersphincteric plane?
Right, sir.
This is the internal sphincter, and then it dips here, and this is the external sphincter. So I am going to put my blade into the intersphincteric plane there.
So
it's a 15 number blade with me. I turn the cutting edge medially, and from medial to lateral to medial we are going to cut. So few strokes, 1, 2. You always keep your finger inside to guide so that the mucosa doesn't cut. And once the last few fibers can always be broken with the fingertip. So this sphincterotomy is complete.
Dr. Agarwal, do you hook this sphincter against a hemostatic forceps or just keep on dividing?
No, so when you are doing an open, you take an incision, you visualize the sphincter and you pick it up and then you cut it. In a closed sphincterotomy, if you put in an artery, then the incision would become bigger. So there's no need actually. If you can see the sphincterotomy is complete. The gap has gone there, in particular. Last few fibers which you see, you can always do a sphincterolysis like the one I just did, and you can keep like a pinch cock mechanism over here so that the bleeding stops.
And
The
important is
extent
you
of
have to
the
avoid a mucosal rent. You have to avoid a mucosal opening.
So I have not done any mucosal
No, I'm not
opening
telling
here.
you. I'm saying
That's why
that.
we keep in a finger inside. So you keep a bit away, and then the last few fibers you press it and you divide them so that the mucosal damage is not there.
Yes, yes.
Okay.
One should avoid mucosal damage. That's what I'm
Yes,
saying.
yes, 100%. Otherwise, you'll end up in a fistula. By mistake, if you have done a mucosal damage there, then it is better to convert it like a fistulotomy rather than leave it alone like this. Now you can see there is hardly any bleeding through the wound, and it is a very millimeter wound.
Dr.
Can you see
Agarwal,
this?
what is the length? What is the length of your
Yeah, it is the
sphincterotomy?
length of the fisturectomy is from sphincterotomy is from the dentate line downwards.
Okay.
So you can see the gap here. Can you see the gap now?
Yes, yes.
And there is hardly any bleeding over there. So that is a lateral sphincterotomy, closed lateral internal sphincterotomy you call it. And see now the passage of the speculum has become so easy. It is just walking inside and coming out. That spasm has gone away. Do you appreciate this?
Yes, yes.
Yeah.
Yes.
Now what I am going to do is, there is no need to excise the whole fissure. We have to just excise the skin tag over here, right? So give me a scissor.
Would you put suture on the rent you made with the knife?
No, this is not required. It's a very small wound. You have seen that. I have shown you the wound.
Yeah.
See this? Can you see this wound?
Yes, yes.
It's only a puncture wound which will heal. Now,
Sir, what do you do if the fissure is large?
local.
Hello?
The patient moved a bit, so I am injecting more local here.
Dr. Agarwal, what do you do if the fissure is a large one? Here it's a small defect.
See, once the sphincterotomy has been done, the theory is that the spasm goes away and therefore there is more vasodilatation. That is what the chemical sphincterotomy agents do. So once there is vasodilatation, the circulation increases and the wound should heal. So there is no need. If there are raw areas or there are fibrotic edges, you can cauterize them or you can remove them. The only thing which is required right now is that you take care of the sentinel tag, because it's going to regress only minimally and the patient will feel that his surgery is not done. That's why you do the sentinel tag excision, and you can cauterize the
So for
papilla
the,
which is on the proximal side.
so for the sentinel tag, it's just for the patient preference, or there's any other benefit? So what if you don't do it?
You can also burn the granulations here with your cautery. Yes, madam, you were asking something.
Yeah, so I was asking for this removal of the sentinel tag.
Yeah.
What if we don't do it? It's only for the patient preference? Or like...
Yeah, see, why does the sentinel tag occur? The sentinel tag occurs because of the inflammation and infection in that area. It's just an overgrowth of epithelial tissues. It is not a pathology in itself. Now when the spasm is gone, the ischemia is gone, it's not going to trouble. But the patient always keep on feeling that there is something there.
Okay.
And if there is a very small tag, then you don't even remove it, it is alright. If there is a large tag, then it is always better to remove it, because the sense of being cured of the disease has also to come from the patient side also,
Right.
This small wound, either you can take an interpreted suture over here, or you can leave it open also. Vicryl 30. Vicryl 30. So this is a 3O vicryl with round body needle, and we are going to just take interrupted suture here, 2 suture, and that should suffice. Sure. Just a needle holder gets stuck. Every time it is getting. See this? You can cut it very short because you don't have to remove it. They will fall up on their own. Give a gauze piece for dressing. Betadine लगाओ. Betadine और jelly था ना? Wet the jelly with you, no? So you can see that wound which we use for sphincterotomy, there is no oozing there. And this wound, there is small oozing. I can still press it, or I can take another suture also there, or cauterize, you know. That's it. Jelly. You really don't have to pack the anal canal for this. Just a small gauze kept. Sure. So this is all that is required. You don't have to pack the wound actually. That finishes the surgery. So one can do a laser sphincterotomy also, but laser you have to be careful. There is a energy which is burning inside. So when you go from lateral to medial, you don't have the control over how much heat is being generated. So there are chances of puncturing the mucosa more. So whenever you are using a laser, it is better that after the puncture, you go from medial to lateral, because then at least you will not burn the mucosa by the heat of the laser fiber. But you have to be careful when you go medial to lateral, there may be some damage to the external sphincter also. So things needs to be under control. Is this all right? Any questions on this? Normally I use a T bandage, but you can put a plaster. Micropore लगा चलेगा मैथी सर micropore लगाओ.
Thank you, Dr. Agarwal, for excellent demonstration of the case.
Okay. You want me to change? Or? Change better. Sure.
আস্তে টিপলে সাউন্ড, লং প্রেস ক্লোজ।
कैंची नहीं नमका तो उसको भी काट लो और थोड़ा ऊपर करो। हाँ ऐसे तो बालेंगे ना उससे। रुक जाओ। False. पीछे ले। Don't show the danda. Change the angle. Angle change. Angle change. Step in. Take. Pallavi. नहीं वो पल्लवी को करने से अच्छा होता. Patient will wake up happy. Catchy. Pani. All needles out. गज फीसेंगे. Let it be. हाँ ठीक है. Head down করবেন. Section. नीचे दिखाओ. पाँव की तरफ दिखाओ. ইরিগেশনের জন্য জল দেওয়া আছে? ঠিক। ক্যামেরা অফ। জল জল ও কাছে নিয়ে এসো, জলটা কাছে নিয়ে এসো। হেড ডাউন করো না। সার্জিক্যাল আছে? দুটোই গজ দিয়ে দিয়েছি। হ্যাঁ, हाँ পুরাও কোলাট্রাস ভরা। জল যাবে? জল নেই। ठीक है, तो छोड़ दीजिए, छोड़ देते हैं। আচ্ছা কি লাইভ ট্রান্সমিশন? তাহলে কথা বলবো না, ছেড়ে দিলাম। একবার জিজ্ঞেস করে না লাইভ ট্রান্সমিশন আছে কি নাকি ছেড়ে देबो? निकाल लो इसको, साफ कर लो, हो सकता है। Okay, so this is the end of the surgery. We could fire a stapler 60 blue and do a cystogastrostomy, following which we did a suture closure of the right end of the cystogastrostomy because there was a hole with a diathermy, and thereafter we closed the anterior gastrotomy, and that is the end of the surgery. This patient has got huge collaterals. I would be worried about the bleeding. I would keep the Ryle's tube there for about 2-3 days. Make sure the blood pressure is low so that the patient doesn't bleed into the Ryle's tube. So those are the precautions that I would take in this particular case. But since it's done laparoscopically, the patient should be comfortable after waking up, and this huge cyst, 15 centimeter size, gone from this abdomen should be able to provide this patient a lot of relief. So thank you very much. I think that is the end of the surgery. We will thank our anesthetists, the surgical team here, everybody, and thank you. There were some hiccups because of this bleed, but that's something that was expected. So thank you very much. We enjoyed this surgery. तो वो है. So I would like to, of course, put in a special thanks to my team, Dr. Pallavi, Habib and Salim, because they have been here and helping us, and all the team from NRS, Rishabh, Asif and Ramita. So all of you, I know this is not something that we do every day, so it's fine if we had hiccups.
Thank you.
It's all right. Thank you.
This.
Yes, please.
This 70-year-old gentleman presented to our outpatient department with a chief complaint of something coming out while defecation during straining of his anus associated with intermittent PR bleeding and pain while defecation for last 6 months. On examination, there is no pallor or any other significant history on general survey. And on PI examination, there is grade 3 hemorrhoids in the location of 10 o'clock, 5 o'clock, 7 o'clock and 11 o'clock position. And there is normal anal tone and there is no associated skin tag.
Alice forces. Another Alice. So are the moderators with us? Can we start this?
Dr. Agarwal, can you hear us?
Yeah, can you hear me?
Yes, sir. Can you tell us the findings?
Hello?
Can you tell us the findings?
The history will be told by any resident who is giving the history?
They have told the history means after you have held those skin tags with Alice tissue forceps, what is there what we can see?
Sorry, I didn't follow. I can tell you these are grade 4 hemorrhoids. You can see it over here. And the plan is to do a conventional hemorrhoidectomy, the closed hemorrhoidectomy, not the open one, the Ferguson one.
Okay.
So, yeah. You can see they are prolapsing out. There is no thrombosis or anything. The two main hemorrhoids are out of this. These 4 o'clock one is the bigger one. So we'll do the 4 o'clock first.
Okay.
Hold this. Yeah. So give me a 2O Vicryl.
What you have injected initially?
So I inject Ilocan adrenaline only 10 cc for hemostasis. The patient is under spinal anesthesia actually. Okay?
Okay.
Jelly. So first thing is you should try and palpate the pulsations of the terminal hemorrhoidal artery branches. So if you can ligate that, then nothing like it. I can feel it over here. You are a resident doctor? Feel it. Just replace my finger on this. Yeah. Are you feeling the pulsations? Yeah. So she is feeling the pulsation just at the site of the pulsation around 2-3 centimeter above the dentate line. We can take a forceps transfixation suture over here so that the bleeding decreases when we excise the hemorrhoid. Now, since this is a grade 4 hemorrhoid, the best technique is still the conventional hemorrhoidectomy. You can do a laser on this patient, you can do an MIPH on this patient, but the recurrence rate would definitely be higher with both the procedures. So, leave it loose when I am trying this. If it is grade 3, then maybe laser or MIPH would be still advantage in the short term at least. So first stitch is the pedicle stitch which you tie and keep it long. Cautery. Fine. Now how much would you excise? You have to maintain the skin bridges between the two hemorrhoids which are large. So if you excise too much, then there will be no skin or mucosal bridge. That will cause anal stenosis in the long run. So you have to start planning right away. So these are benign things. They are not malignant. You have to be radical. So this is the cutaneous junction. You can see this is the external hemorrhoid portion and this is the internal hemorrhoid portion. So what you do is just hold it just beyond the hemorrhoid portion and you can use cautery, scissor, blade, tooth forceps. And mark your incision right in the beginning. So you don't have to, as I said, you don't have to excise more. So on the skin portion, we'll use a cutting current, cautery. Cautery, please. Correct? Started? The hand switch works. So this is the external hemorrhoid. नहीं चल रहा है. नहीं चल रहा है बाबू. कटिंग नहीं चल रहा है. कटिंग चाहिए ना. हाँ? Okay. Yeah. So you just mark your incision where you want to excise the how much you want to exercise right in the beginning, right? This is the pedicle, you saw that. And this is the enodome which is most sensitive. So you want to exercise it as little as possible. So you make a dumbbell shaped incision over here, right? Gauze mop, कुछ तो दे दो. Towards the pedicle, you can have a larger engulfing incision. On the mucosal side, you can use the cutting coagulation current. And when you come to the enodome, make it narrow. That is the whole idea of making it a dumbbell shaped. So you can see here also, we have gone very narrow in the enodome area, and then towards the mucosal aspect, we have taken a larger chunk. So now when you start exercising, you will appreciate what I was saying. So they were very fleshy hemorrhoids to start with. In of the pedicle suture, if the pedicle suture was not taken, the bleeding quite high. I want a gauze piece, please. You can use a blunt as well as a sharp dissection. Just push the loose areolar tissue back. Can you appreciate the entire hemorrhoidal mass is engulfed in my incision, and yet there is a lot of tissue left behind. Now at this level, you can start pushing the internal sphincter. Here, there is some blood. Can you appreciate now?
Yeah, we can appreciate.
The inner one. This is the internal sphincter. Can you see the transverse fibers?
Yes, yes, we can see, sir.
So you narrow down towards the pedicle where you had done the stitch, and you had kept the stitch long, right? So first thing you see is that the incision, the hemorrhoidal mass is like, can you see this?
Yeah, we can.
Are you with me? Hold this.
Yes, yes. Can you hear us?
I am not hearing any comment. That's why I asked you whether you are with me.
No. We can appreciate.
Okay. Let's have some discussion also for the benefits of the juniors who are here. The same suture which I had kept long, I have taken to the other side. Hold this. ऊपर करो उसको. ऊपर करो.
So here you are using the same suture that...
yeah, which I had kept long, the pedicle suture.
Yeah.
Yeah. Caesar. Take this. Gauze dena.
Dr. Agarwal.
Yes,
Dr.
sir.
Maiti speaking. The technique what you are showing, that is unique in the sense that you are preserving the skin so that cosmetically and in relation to the wound and scar, it is much better than the standard technique usually followed.
Pardon me, sir, I couldn't follow anything what you are asking.
No,
The
not
voice-
asking.
the
I'm just
audio,
making a...
audio is not clear.
Voice is not clear. Dr. Niranjan.
Yes, sir.
I'm just appreciating the technique you are following.
Okay.
The unique part of this technique is that you are preserving the anal skin
Yes,
and
sir.
there is no wound in the perianal region.
That is most necessary, sir.
Yes.
Because we always thought that hemorrhoids are only pathological. They are not actually.
Exactly.
They are there. They form some part of the continence also.
Okay.
You know, so when you excise them, you have to be very careful. As much is required, which has become, these are physiological structure which become pathological. So you excise only which has become pathological. Don't do a radical surgery here. If you try to excise too much, there will be a problem in the post-operative period. So you saw that I have taken one more transfixation suture. And now I am going to do the hemorrhoidectomy. So the hemorrhoid tissue is removed. Now if I leave it at like this, it becomes Milligan-Morgan. This is Milligan-Morgan, that's all. If I cut the suture. But I am going to do a Ferguson, as I said, a closed hemorrhoidectomy. So for a closed hemorrhoidectomy, I need to close the raw area. And to close the raw area, any suture like in surgery, you have to do it without tension. If you take the edges together in tension, they are going to break down.
Yes.
So most people who don't take closed suture, they blame that it breaks down. They are breaking because we are not taking them properly. Right? Just remove this. So in this you can also bury the pedicle which you have sutured to protect it from the hard stool, etc. So what we are going to do is, again the same suture which was kept.
Sir, you are using 30 Vicryl?
No, I am using 20 Vicryl, sir.
20?
Yes, sir.
Okay. So I think present day there is no scope of using catgut?
No, nobody uses catgut anymore.
In hemorrhoidectomy, will you add lateral sphincterotomy? Because many patients complain pain in the postoperative period because of the presence of wound, sometimes more than
No, we
two.
use either a rapid Vicryl or a You just saw that I sutured that skin edges in the fissure case with a Vicryl suture. I did not use the catgut. So you see that the pedicle gets buried and I have no difficulty in approximating the two ends. This also helps me in hemostasis from the two edges, you know. Because if you keep on burning it with cautery, then there will be a lot of necrosis in the post-op period. It is better to underrun them. Please mop. Please mop. So you can take a continuous suture. And the last suture, you should keep up the gap. You should not close the entire wound, because if there is any oozing or any bleeding also, it will come out from the opening which you leave in. Leave this. So you can see I have left a small opening there. I have not gone beyond that. Cut. Hold this. Can you appreciate the 4 o'clock hemorrhoidectomy? Dr.
Yes, sir.
Maiti?
Yes, we can appreciate.
Yeah, there is no bleeding, there is approximation without tension, and the pedicle is buried. Now coming to the next hemorrhoid, that is the 7 o'clock hemorrhoid. Same thing, jelly. Feel the pedicle, the pulsations are felt at 7 o'clock position there. Vicryl. You want to feel better? You are also a resident. Are you able to feel? Okay. So both my assistant doctors have felt, and now I am going to take a pedicle stitch there. See, they have to see. Unless you show, the camera will not be able to pick up.
Sir,
Right?
in this case, instead of hemorrhectomy, Milligan-Morgan, whether staple hemorrhectomy may be more useful?
I told you that these are grade 4, and the incidence of recurrences in grade 4 with stapler are more. You know? And Dr. Shah also wanted me to demonstrate conventional surgery. It is not that you cannot do, you can do stapler in this, but then the patient should be explained that the recurrence rate will be higher.
Sir, in our student days, we used to learn that hemorrhoids are mainly venous disease because of the pressure in the vein due to the gravity. There is congestion, particularly commonly seen
now
in
there
portal
are enough-
hypertension. But there is a change in the trend. Now the arterial component is given more importance. Your opinion regarding this?
So it is nowadays proved that there is not only a venous, there is an arterial element also to this. Idhar karo beta. There is an arterial element also.
So there is a combination of
And there
both.
is a and so this is the external hemorrhoid where it is ending.
Yes.
So I will start from there. This is the anodum. So, अरे बाप रे कितना आवाज है पीछे. Who's making that noise? Somebody is very happy today. And as you go towards the pedicle, you can engulf more tissues, right? Same thing here. When you get chance. Again, when I come to the anodum, I reduce it. Is my head coming in between? Is it seen? Gauze. So hold like this. Hold this one. Don't pull it too much, just hold.
Dr. Agarwal, do you do an anal stretching at the end of the procedure or no?
No, I never do that. In fact, it is contraindicated also nowadays. Unless the patient has a fissure, you should not do it. And anal stretching should be not done for fissure also. If at all you need to do anything, it should be sphincterotomy and not stretching. Because stretching causes uncontrolled disruption of the sphincter at multiple places. You know, that's why the incidence of incontinences with stretching are much more compared to sphincterotomy.
And what is the incidence of post-operative infection following this procedure?
Following hemorrhoidectomy?
Yeah, because
see, even though you are operating in a dirty area, How many times have we seen actual infection in the hemorrhoidectomy wound?
Yeah.
Practically very less. The reason is being because the vasculature here directly drains into the liver, phagocytic. And that's why any bacteremia here will be taken care by the liver. So the incidence of infection is very low in hemorrhoidal surgery. Compare it with wounds which you would have taken in other places, with fecal contamination, like an abdominal wound with a fecal fistula, the infection rate, and compare it here, you will find that their incidence is very low. Okay, again you can appreciate that the edges are coming without tension, mop. This tissue you can see in between the skin and the mucosa,
Yes, sir.
mucosal bit.
Yes,
So
sir.
we have preserved them quite a bit, which is required in this kind of cases, so that there is no anal stenosis. And as I said, the last stitch should be kept open. Cut. आराम से. Show. Take this. Take a scissor, cut this, cut this. You can see there is no bleeding here also at the second wound, right? Now the last hemorrhoid, which is at the 11 o'clock position, that was quite small, jelly. Hold it. Now this is comparatively a very small hemorrhoid. You can see this, right?
Yes, sir.
So the choices with you is either you can inject some sclerotherapy over here. If you have a laser, you can do a laser over here, so that you don't really need to make a wound like you did for the other two prolapsing hemorrhoid. You have a laser here, right?
Yes, sir, we have a laser.
So we can demonstrate laser also in this case at the same time. Give me the laser fiber. So you can do a hybrid kind of a procedure. So even in laser, you have to first ligate the feeding vessel, otherwise the recurrence rates are very high. Give me some jelly. So first feel where the pedicle is, like we did in the open surgery. लेजर मशीन वाला किधर है? There. Feel at this position. Right? Give me the stitch.
The immediate post-operative results looks excellent.
Forceps, plain forceps. Yeah. See, anteriorly is the most difficult part to stitch, huh? So see the needle holder. I am not holding the needle holder in my finger or thumb. I have just used pronation, supination, and holding the needle holder without gripping it. Remember, more surgical knots you use, the better hemostasis you will get. I will need some ice cubes also. See the laser. I am waiting for the laser fiber. So in the same patient you can see that there are various degrees of hemorrhoid and each degrees can be tackled separately. You know, you don't have to have one say for all the problems.
Sir, while we are waiting for the laser fiber, can you just describe us the technique as to how you would do it?
Describe what, sir?
The technique of laser ablation.
Okay, fine. So you saw the first step in laser is a finger-guided hemorrhoidal artery ligation, or you do a Doppler, whatever you want.
Yes.
The hemorrhoidal artery needs to be ligated. And once you have ligated that, then you need the coronal fiber which has got a pointed tip of the laser. And the energy is delivered in pulses, that is 3-second pulses and 6 watts current. Now, where do you puncture? There are multiple theories and multiple methods which people are using. I normally puncture it at the mucocutaneous junction. Why? Because there is a anastomosis between the vessels supplying the external hemorrhoid and the internal hemorrhoid at that level. Right? So we use it from there, and when we are burning, that will take care of the vessels of the external element also. If you other people go it through the intersphincteric plane or outside the external hemorrhoid, and they have to puncture the internal sphincter and then reach the hemorrhoidal tissue. So there are chances of damaging the external as well as the internal sphincter, and that is why it should not be done. So you puncture through the mucocutaneous junction, go towards the hemorrhoid, you will not be able to progress further because you have already taken a stitch. And then with 6 watt 3-second pulse, you deliver the current in a radial manner and come out. Don't deliver more than around 150-180 joules per hemorrhoid. And be careful, when the light is too bright, you are very close to the mucosa, then that will get ulcerated in the post-operative period. If it is too dull, then you are very close to the internal sphincter. So that will damage the sphincter. So you have to be in between the sphincter and the mucosa. Remember that.
So do we need to inject any fluid around the hemorrhoids to protect the other structures, like as we do in varicose vein?
Do you need to inject what?
Fluid around the hemorrhoids to protect the structures.
No, I have never used it. But you need cold, either ice pack, or you need some kind of cold water spray there, so that post-operative, the latent heat which is released by the laser heat is taken care of.
Okay, sir.
Jelly लगाया? इधर लगाओ ना इसके ऊपर. And don't wait for the laser to shrink on the table. Don't keep on giving energy. The laser heat will ablate and cause fibrosis in period of days. It will not be immediately on table. So to try and do, chashma hai wo? If you try and do it on table, you will burn more. Remember that. So this is a fiber. This is not a coronal fiber actually. This is a bare fiber. And the machine is 1470. Lasotronic 1470 machine is being used. So what is the difference between 1470 and 980? The difference is the depth of penetration and the medium of penetration. 1470 uses water as a penetration medium, whereas 980 uses blood as a penetration medium. And the depth of penetration in 980 is more, it is around 5 millimeter, whereas in the 1470 it is only 2 millimeter. Now can you see this mucocutaneous junction? Can you see the mucocutaneous junction? No response? Okay, you puncture it there.
Yes, yes.
Yeah, you have gone inside, now you progress the fiber. ऊपर का लाइट बंद करो. Can you see the light?
Yes, yes.
Yeah, so it is neither very dark. If I bring it close, now you can see it is so bright. So this is near to the mucosa and I should not do that.
Okay.
Okay, and if I take it completely away, it becomes dull. So I am in between now and I am not able to progress further because of my stitch. So now I will start delivering the current. I have pressed the pedal and like a span-shaped manner, I am giving the energy to all the portions. कितना गया? कितना watts गया? Lesotronics 100 already delivered. Now 125 delivered. How much? Okay, so this is my last this thing. Yeah, light चालू करो. You can see there is no bleeding. We have ablated the whole tissue. It will shrink in a period of time, not on table. Take this. If you,
Okay, that's
I need
nice.
some ice, finger ice, ice. Loud. Give me some saline at least. Saline. Huh? Huh?
So, Dr. Agarwal, here the ice packing is required, na?
Give me some water here. Put it in this. ऊपर से कट करो. ये चश्मा निकाल दो. Laser दे दो उनको. We have finished. So this is over now. I would like all of you to appreciate that the tissues in between, the most important part in grade 4 hemorrhoid is the mucocutaneous junction between the two hemorrhoidectomy is maintained, right? Here also we could have done that if the piles was bigger, but we purposely used the laser because it was a smaller grade. Is that correct?
Yes, Dr. Agarwal, one thing, for the laser treatment, the ice packing is required here.
Sorry?
Ice packing is required.
Ice
here?
packing is required. That's what I said. I am waiting for the ice pack only.
Okay.
Normally, only after hemorrhoidectomy, we don't even pack it. We just keep a small gauze pick over there as a wick, but no packing is required.
Okay.
Even the ice pack which we put will get dissolved in another 15-20 minutes. So there is no packing. Hemostasis should be achieved on table. It should not be left to the pack.
Yes.
The incidence of urinary retention as well as pain, etc., are all more if you do a very tight packing.
Yes.
You see there is no bleeding coming out right now,
No,
right?
no, that's nice.
Yeah. Chalo, some cold saline or some ice pack, something please.
Thank you, Dr. Agarwal. It's a nicely presented.
I think if there is another case going on the other table, if you want to see, we have practically finished here. Just waiting for the ice pack. Who's operating there? You can take the camera. So they are moving the camera to the third case. Any question on hemorrhoid, you can tell me right now.
No, thank you, sir.
Yes, madam.
It's nicely presented.
Saline डालो इस पे. Saline डालो. No, I am not putting that. I will put the cold saline.
Case number 3. This patient has a chief complaint of intermittent pus discharge per rectally since last 10 years with pain during defecation. This patient presented to the OPD with the same complaints, and there was an external opening noted 6 mm away from the anal verge. He is a known diabetic on regular medication, and he has a surgical history where outside this facility there was an excision of the external opening was done. The MR fistulogram is suggestive of low anal intersphincteric fistula in ano with enteric opening at 7 o'clock position.
Camera, please shift to table 2.
Always a pleasure.
দুটো লাগবে, তিনটে হলে ভালো ওটা।
Sir, can you hear us?
Okay. I am Dr. Sukumar Maiti from the OT. Is the region visible?
Sir, this Madhumita, it's not visible right now, it's visible, but the site has to be focused.
Okay. So as you have heard from the history that it is a case of fistula in ano, and the clinical examination and the investigation report, the MRI probably have been done. It's suggestive of low transsphincteric fistula. Okay. So there are two common operations for fistula. One is fistulectomy and other possible fistulotomy, and there are for complex fistula, horseshoe fistula and other fistula, fistulectomy is not possible. If you try to do fistulectomy in those patients, there is the problem with sphincter. But if it is a lowly placed fistula and the fistula tract passes through the lower part of the sphincter complex, then you can sacrifice only a part of the sphincter and you can complete the fistulectomy. So it is said that if you sacrifice 1/3 of the total length, total dimension of the sphincter, total thickness of the sphincter function will be maintained. So in spite of that, the aim of the operation is to remove the infected tract completely, at the same time to preserve the sphincter muscle complex. So in this patient, this opening, external opening was fibrosed. There was scarring. We could not see any granulation tissue, or neither we could see any discharge through the external opening. On palpation, we tried to assess the fistula tract, where it is going. And from this region, we tried to palpate here. We can palpate a tract. We can palpate a fibrous tract here, which is directed towards the posterior midline. And now placing the index finger, lubricated index finger, and pressing against the right wall of the anal canal, and the thumb is on the outside skin, I can well palpate the fistula tract, which is passing from this region to this midline region. And in the midline region, the internal opening is palpated, but neither there is any elevation nor there is any hollow or opening. Sometimes the internal opening is so big that the tip of the finger can just be placed on the internal opening, but here it is as flat as that of the external opening. So we are still now not sure whether we can demonstrate the internal opening or not. To demonstrate the internal opening on the operation table, there are dye tests. Probing is a test that should be reserved at the last part of the you're searching the internal opening. If you once probe it, that can cause the false passage. So before that, we must try the dye test. The dye test means not only the dye, that includes water jet test, that includes the hydrogen peroxide test, and the dye test. And the commonly used drug dye which is used is the methylene blue. Many surgeons prefer methylene blue, but some surgeons will not prefer methylene blue, because methylene blue, once it is in the tract, somehow by accident, if the tract is opened up, then that can spoil the surrounding tissue and stain by staining with methylene blue. So many surgeons do not prefer the methylene blue. If water jet shows the internal opening, then no need of performing the other test. Sometimes the tract is closed with the debris, then water cannot pass through the debris in the lumen of the fistula tract. In that case, hydrogen peroxide is very useful, because that dissolves the debris and hydrogen peroxide makes its own tract so that it comes out through the internal opening. So in this case, as we could not find the external opening properly also, we just scraped with the scalpel, and still now we cannot find any granulation tissue. I don't know whether I will be able to demonstrate the. So I'm just holding the skin here. So we prefer the narrow tipped Alice forceps so that the trauma is less. If it is a broad based Alice forceps, then that will cause more trauma. Give me two Langenbeck. না এর চেয়ে লম্বা লম্বা চাই, এরকম চাই আরেকটা, একই রকম সিমিলার একটা চাই, এরকম সিমিলার চাই. So this Langenbeck is used here. আরেকটা the Alice দাও. And just as we palpated the internal opening here, I am holding the skin here to pull. Okay. Till now, I can Langenbeck in. So I can use to have a better inspection of the dentate line, because in fistula of cryptoglandular origin, the internal opening is always at the dentate line. In case of secondary fistula, Crohn's, tuberculosis, etc., the internal opening may not be in the dentate line, but it all cryptoglandular origin fistula, and if it is without any intervention, if it is a primary operation, first operation, the internal opening is supposed to be present in the dentate line. So I am introducing this instrument. So before that, a little dilatation is needed. So once I place it, and if the light is properly placed here, eta goli swap koro. You see, we can see this area, but till now there is no discharge of pus, or there is nothing which we can indicate the position of the internal opening. Here we have to depend mainly on our palpation. So the suspected area is here. Suspected is here. এবার Alice tissue forceps দাও আমাকে. Alice tissue forceps দাও. আর এবার syringe দাও. Give me syringe. না আরেকটা এই এই ব্যাস, এবার সিরিঞ্জ দাও, জেল কো দাও, জেল কো দাও, ট্র্যাকটা দাও, কভারটা, শীতটা দাও, জেল কো শীত। So I usually take a gel co sheath and cut the tip. Water to. So this এই ধরো। So I try to negotiate it, but still it is closed, so fibrous. I prefer always to do the fistula operation when there is mild infection. It is in a fibrous tract, it is very difficult to operate, and when there is severe infection, it is also difficult operation in the sense post-operatively there will be too much infection, and also in the situation of presence of severe acute infection or presence of pus, it is also difficult to isolate the tract. So here I am trying to negotiate, but I am failing. Till now I am failing. এবার আমার সেই প্রোবটা দাও, ওই যে ফিস্চুলা যে আমার প্রোবগুলো আছে, না ফিস্চুলার যে এটা আছে ক্যানুলা, মেটাল ক্যানুলা, যেটা আমার 5টা ইনস্ট্রুমেন্ট দিয়েছিলাম, 5টা ইনস্ট্রুমেন্ট দিয়েছিলাম। অ্যাডসন দাও, অ্যাডসন দাও। এনি সাজেশন ফ্রম দ্য হাউস, এটা দাও মোছো। So anyhow I am searching to find out the external opening, but external, both the internal and external opening are not. I try to attack the fistula from the internal opening. Once I lose the position of the internal opening, the chance of recurrence will be high. Anyhow, I have to remove the internal opening. So my searching for the internal opening should be perfect. If you do not do anything for the external opening of the external tract, that will not cause any harm. If you perfectly attack and remove the internal opening and the proximal tract, because proximal tract is the only part which is epithelial line. The rest, the external part is not epithelial line. So somehow with little force I am doing this, but these things, this little pressure should not be applied or tried at the site of the internal opening. Okay, syringe daw. Now I am trying to do the dye test with water jet first. ঢুকেছে? এবার পুশ করো তো, জোরে করো, আমার মুখে পড়তে পারে ছিটকে। যাচ্ছে না, যাচ্ছে না তো, যাচ্ছে না তো, যাচ্ছে না, যাচ্ছে না, ঠিক আছে। So it is not going, it is so fibrous. Okay, দেখি এবার। So as it is not going, so before going to the site of the internal opening, I do some little extra cut in the region so that I can find the granulation tissue. My object is to find the granulation tissue first. So probably we have got it. দেখি প্রোবটা দাও।
Sir, do you routinely excise the external opening?
No. Do not routinely. In this patient, the external opening was totally closed by fibrosis because I could not show the initial first part. Then you see now it is easily going. Okay. So I want to get a successful dye test. I want to get a successful dye test. Hydrogen peroxide দাও।
But what you're excising is basically a blind thing, isn't it?
Blind? No. I am excising the skin around the external opening to get the granulation tissue of the external tract in the deeper part. Until I reach little bit deeper to the skin surface, I am not able to find the tract. I can palpate the tract, but I cannot find the tract. So I have to excise because this step is important. So
Yeah, another query, sir. You're, I think, introducing hydrogen peroxide now.
Yes, yes.
So is that the only marker that you used, or do you also use methylene blue for
Not
delineating
methylene blue.
the tract?
Here, as the tract is fibrosed, I hope some debris will be removed by this.
So it will act as a pressure mechanism to wash the tract.
Wash the tract.
Right, sir.
That it may be possible. If it is not possible, I have to remove blindly the. না ছাড়ো এবার ছাড়ো এবার এইখানটা দেখাও এইখানটা দেখো এই অ্যালিসটা টানো I want to see the internal opening perfectly. I have to. We should not be very hasty. We have to wait after putting the dye. Little amount of dye should be pushed. If too much hydrogen peroxide is pressed with pressure, then it may cause false passage through the wall of the tract. That is also one of the demerits of using hydrogen peroxide. So the pressure should be optimum, and also the amount of hydrogen peroxide should be minimum. I am waiting for some time. Though it is a very simple fistula, I am giving time only to detect perfectly the internal opening.
So are you feeling a resistance, or are you getting a free flow?
Resistance. I am
There is a
getting resistance, not
yes.
putting too much pressure. Okay, so it is not passing because tract is closed. As the internal opening closed, external opening closed, so tract is in a very quiescent state. So there is no significant lumen within the tract. Now next, what I shall do? What is the suggestion from the house? What is the suggestion from the house? What shall I do? Any suggestion? Utpal?
Sir,
Somita?
Sir, I think we can trace down from the internal opening.
Exactly.
We found the internal
Exactly.
opening.
So you see, here is the my assistant, the two PGT, Ria, and you palpate what is the most hard part that is very close to the skin surface. Palpate karo. You see, this is the area. Only this area. So this area, her finger is here, that is very soft, but this area is hard.
Sir, we can't hear you properly.
No, mucho. So this area is very pliable, soft. And this area
Can you
is...
please hike up the audio of the mic that sir has?
Yes. অডিওটা দেখো
মাইকটা একটু বাড়িয়ে দিন যাতে আমরা একটু ভালো শুনতে
আর
পারি।
আর একটু সরাও ঠিক আছে এবার ঠিক আছে so here in this situation what I do the wedge excision of the region, because as it is a low transsphincteric fistula, it is safe to remove do a wedge excision, because that we know more than 85% of the internal opening is at the 6 o'clock position. And on palpation, we palpated the tract is passing to this region. So if I do a wedge excision in that region with adequate depth of about few millimeter, that will include the internal opening and the proximal tract. And then from that region, I will trace the tract externally. Okay. So, এইভাবে করো। I always give a marker above the dented line, so that if there is any bleeding that is in my control, I can, by cautery or by suture, I can stop bleeding. So what dissection I will do, that will be always below the dented, just including or below the dented line. Okay? এরকম ভাবে ধরো শাক করে এখানটা পরিষ্কার করো, মপ দিয়ে পরিষ্কার করো, দেখতে পাই যেন সবাই। হ্যাঁ ব্যাস। So I am starting from this region, marking which region I will excise. I am first marking that. I will not go beyond that region. So for the skin, I can use the cutting cautery. For skin, for less pain, instead of cautery, we can use also the knife. Rest, we can use the diathermy. So you see the sphincter fiber we have reached. You see these are the sphincter fiber. These are external sphincter, no doubt. And little above we will get the external, internal sphincter. Slowly we are making a column, excising a column of tissue. A column of tissue which is indurated and firm in consistency. These things happen in 10 to 20% of cases. The surgeon faces problem not to find the internal opening. In this case, we are proceeding, approaching, we are continuing the operation because it is a simple fistula. But if it is a complex fistula, horseshoe fistula or other, and if I do not find the internal opening, I may not do anything. I may stop the operation, abandon the operation for the time being, and wait till I get a little bit infection and ensure that it is sure about the internal opening, then I will proceed, do the operation. But here it is a simple fistula, radial fistula. Okay. This is a column of tissue is excised, and here as we are going for fistulectomy, what I shall do, here you see, you make a this tract straight, this, like this. So I make this region straight one. So this skin, the tract is below the skin. I am excising the skin.
Sir, I'll interrupt you for a moment.
Yes.
We'll have your video on, but we'll switch off the audio for some time. Dr. Niranjan Agarwal, he would like to speak a little, inviting all our
fine, thank you.
members to the
Yes,
ASICON 22 in Mumbai. So we'll keep your video on, but we'll switch off your audio for a few minutes.
We will all attend ASICON. Already we have registered. So we are happy to attend the conference organized by Niranjan sir. Niranjan sir, as a person, is a very nice man. And I hope as an organizing secretary, we are going to get a wonderful ASICON 2022.
Okay, good afternoon everyone. Myself Dr. Niranjan Agarwal from Mumbai. First and foremost, I must thank West Bengal Surgical Association for inviting me and giving me this opportunity to interact with all of you. So thank you Shah sir, thank you Makhanlal Shah sir, thank you Tamunas Chaudhary and everybody else. In the morning when I was being welcomed, sir said I am a very important man because I am doing the ASICON. So I agree, the crown of thorn is on my head this time. But believe me, as members of ASI, I will not let you regret coming to Mumbai. So those who have still not registered for the ASICON, which is from 21st December to 24th December, please do register. The registrations are online at the website www.asiconmumbai.com, and till the discounted registration still going on. You can choose for residential packages also. We have a live operative workshops running in around 5 to 6 halls on day 1, that is 21st. So you can all avail the academics of the first day also, which is live workshop, and followed by the 3 days of proper ASICON CME. And on the other 3 days also, apart from the ASICON CMEs, we are going to have one day a nurses training program for nurses of the surgical hospitals, because like in Kolkata, Bombay also has many small and medium sized hospitals where the nurses are not formally trained. So for those nurses to train them, we have kept this program. And on second day, we have for the same small and medium sized hospital, those who are running their own hospital, we have got a hospital management CME. You know, people to those who are entrepreneurs, those who are working in corporate, they don't have to look after other than the clinical side of the patient. But those who are running their own hospital, they have to manage everything. It's a one-man army. So to train them for everything of the managing of the hospital, the second day, one hall is kept specially for hospital management CME.
and the third day that same hall gets converted into a hall of innovation. So any company who has got any innovative product or any surgeon who has got any innovative procedures, etc., will be showing their innovative products or cases in that particular hall. So there is a difference, lot of difference in, it's not only a plain Sasicme, plus it's at Mumbai after 27 years of a gap. You know, Mumbai, as you all know, is a city which never sleeps. It's a lively city, cosmopolitan in nature, very safe, and lots of modes of transportation, lot of accommodations available, and your accompanying persons who come with you will also enjoy a lot. We are planning 3 different days program for the accompanying person for the 3 different days. They get a lot of chances for shopping also. So please join us with folded head. I request you to be our guest for Sasicme 2022. Come to Mumbai and make it a grand success and enjoy with us at Mumbai. Thank you so much.
এবার হয়ে গেলে এইটা বাদ গেলে হয়ে যাবে। দেখো স্টিল দেখো এখানে কোনো মাসেল ফাইবার নেই। হ্যাঁ, দিস ইজ ফ্যাটি টিস্যু। আমাদের মাসেল ফাইবার উপরে রয়ে গেছে। আলটিমেটলি উইল শো দ্য মাসেল।
So now we can hear you.
শুনতে পাচ্ছ? So what we have done till now, initially we code out the region of the internal opening and the proximal tract. Then we started from the external site and we made an incision on the skin and just retracting the skin on 2 sides. From the external tract, we have proceeded towards the internal opening. And we have partially dissected internal opening and we have gone externally. So rest of the tract we will separate from the muscle. Okay, ধরো এই রিট্রাক্টর দাও, ছোট রিট্রাক্টর। না, এটা দিলে হবে না, রিট্রাক্ট ছোট রিট্রাক্টর চাই। ওই যে ল্যাপারোস্কোপিতে যেটা লাগে আম্বেল কোট করে যাবে, ছোট্ট ল্যাঙ্গেন ব্যাগ যেটা। We want to retract the mucous membrane. We have marked a circular opening around the internal opening, and that is that mark, circular opening, incision mark. So we are retracting that region. এটাকে এটা উপরে থাকবে, এইটাকে তুমি এইভাবে ধরো, দেখি ধরো এই ছুঁড়ে। So now this retractor is now outside the anal lumen, but that is retracting the mucous membrane of the anorectum. This is the mucous membrane of the anorectum, and this is the sphincter muscle. You can see the sphincter muscle. So we have removed only a part of the sphincter muscle, and till we can sacrifice this sphincter muscle. ধরো এটাকে, ধরো তুমি এটা ধরো রিয়া। হ্যাঁ, না হচ্ছে তুমি এখানটা একটু মোছো, শাখার ব্যবহার করতে পারো, তাহলে এটা আমরা খুলে দিই, এটা আমাদের বিল্ডিং নেই তো খুলে দিচ্ছি। So you can see this is the tract, this is attached with some sphincter muscle fiber, just it is lying on the surface of the sphincter muscle. We are just cutting the superficial part of the sphincter. হ্যাঁ হ্যাঁ, এক্স্যাক্টলি। এবার এটা দেখাও, এখানটা দেখো, শাক করো, এখানটা এতে শাক করো, ভালো হবে। So external and internal opening site in my hand. So middle portion is still attached, and this skin tag we will excise later. Okay, ঠিক আছে, এটাকে রিট্রাকশনে আমাদের সাহায্য করবে। ঠিক আছে, I think everyone can see. So the last part of the middle portion of the fistula tract, I'm just separating it from the underlying sphincter muscle. Rather, I am taking few fibers of the sphincter. This is mainly the external sphincter. That is mainly the external subcutaneous part or superficial part of the external sphincter. You see, can see the fiber? So, till some portion is attached, I will see for hemostasis whether there is bleeding from the floor over which the fistula tract was lying. No significant, no bleeding. Just there is chance of bleeding from the margin of the mucous membrane. I am taking the opportunity to cauterize the margin of the mucous membrane so that there will be no bleeding. Okay. So I am removing the last part. Before that, I am palpating whether there is any tough fibrous tissue, particularly in this region, in the region of the 6th Rocock position present or not. You palpate, my assistants are palpating, all are soft. Okay. Okay, so removed. You see, so this is the region we have removed, and this is the skin, the sphincter muscle. Now the sphincter muscle is present here as well as here. I am just showing the contraction of the sphincter. You see, look, you see, can you see the contraction? So this is the intact sphincter fiber as well as this is, there is sphincter. You can see the contraction of the sphincter muscle is also present in the floor. The unique thing about the fistula or the intersphincteric abscess is that most of the time the abscess lies in the intersphincteric space. And for good thing, that because of the abscess in its typical position in the intersphincteric region, the external sphincter is little bit protected by being pushed outside. And sometimes the intersphincteric abscess make a buttonhole in the external sphincter to come out into the interstitial fossa, and that can open anywhere on the perianal skin. That may be in this region, that may be in the thigh, or that can even go to the anterior abdominal wall or to the scrotum. But the internal opening is always in the 6th Rocock position. Okay? ঠিক আছে, আমাদের হয়ে গেছে, এবার বাকি উনটা কতটা ক্লোজ করব সেটা, that is the question. How much we will close?
Sir, is it necessary to close the wound?
Just it helps in proper drainage. We can close partially closed, not total closure.
Okay, because closure
always
makes...
there is a trend, there is a two groups in fistula surgery. Most of the surgeons prefer the suturing this rent. This is a rent in the external sphincter.
Yes.
Many surgeons prefer to close this rent by giving Vicryl stitches like this.
Okay.
I never do that because this is all the fistula are intersphincteric abscess in origin.
Yes, yes.
Okay.
That's
So I always prefer the internal drainage. I have made a wide opening at the 6th Rocock position. If there is any residual epithelial tissue or if there is residual source of sepsis, that should get the chance of proper drainage internally. It should not wait to accumulate more and more to make another tract to come out through the external opening. So always I prefer to allow the internal drainage of the intersphincteric abscess. So what I will do, just leave all the Alice tissue. You see, the wound appears to be very big. So keeping that portion okay, I will like to close the deeper tissue, but leaving the skin open, skin layer open. This is, you see, this is the fatty tissue. So this is the fatty tissue. Can you see?
Sir, if we keep it open, remains.
No, if that will take long time to heal. But I will keep it partially open. Okay, just give me the Vicryl 30.
Okay, sir.
And you see this tag of skin, this is just a fringe of skin. I can excise it. And when I excise this with scalpel, it bleeds. But if I use the cutting cautery, bleeding may be less. For skin cutting cautery, mocho. And then deeper tissue, coagulation cautery. This triangular fold of skin, so that free drainage will be there. ব্যাস হয়ে গেল এবার দাও 30 দাও আমি কিছুটা ক্লোজ করব কিন্তু I will not close this one. Any comment or criticism from the learned moderator? Is Somita is there?
Yes.
Somita?
Yes, sir.
How do you criticize or comment on this technique when we are unable to find the internal opening or external opening?
So the one thing we try to avoid is the probing, because the probing might create a false track.
So I have not tried probing initially. I tried the dye test with normal saline and your hydrogen peroxide, but I failed. Then I tried probing only from the external opening. I never try probing blindly from the internal opening until and unless it walk in freely. Then probing should not be passed with any force.
So probing from the internal opening is something I have only seen you doing it. I have not seen it with other surgeons, because the direction of the probe is totally blind when you're probing from the internal opening.
No, probing should never be done until and unless you are sure that this is the internal opening. Once you find the water jet or the methylene blue jet or the betadine, I use instead of methylene blue, I use the betadine only. Okay.
Sir, I think as far as the postgraduates are concerned, what we should emphasize is that probing should not be the first modality of delineating the tract.
That is the last modality.
Yes.
Probing is the last modality.
Hydrogen peroxide is the best and the most effective. Yes, we can use methylene blue, but there is always a chance that if it flows through the internal opening, then the whole area sometimes gets discolored.
But still, throughout the world, many surgeons use the methylene blue. That is the preferred dye. Literature and in many things suggest that but I never use methylene blue.
But the other thing is, sir, when you are introducing the hydrogen peroxide, the proctoscope should be in situ, so that we can appreciate where the hydrogen peroxide is coming out from.
For demonstration, proctoscope should be in situ. But for me, I use just to see that region with mild traction of the lateral wall of the anal canal, because if you put traction, that obliterates the lumen to some extent. Okay, for that region, if there is a anoscope, what I was using, if it is in situ, sometimes because of stretching effect, that closes the tract. So what I have seen, if I can observe, I can give a moderate traction to the lateral wall, and if I can see that region, then that will give the good result. Otherwise, too much traction on the wall of the anal canal may cause pressure obliteration of the tract, disturbing the flow of dye. That is my observation. So I'm just partially closing it.
Dr. Maiti, Dr. Niranjan here.
Yes, sir. So we are very happy to get you in our state workshop, because you are too busy now for the ASICON and so many things for the national, and you are a pioneer figure in the international level too. All of us are aware of that, but still you have given time for us. For that reason, we are so happy. Sir,
it's
please.
my pleasure you people have called me. Thank you. I should be thanking you. I have a question regarding the case which you are operating.
Yes, sir.
Prima facie, it looks like it was a very simple low transsphincteric fistula. Am I right?
Yes, sir.
Then what is your experience with a low simple fistulotomy?
Low simple fistulotomy is possible.
Just keep it.
Fistulotomy is possible only when I can negotiate a probe into the tract. Fistulotomy is laying open the fistula. But here in this particular case, and which can occur in 10 to 15% of cases, the tract is closed. Internal opening is not visible. The external opening is also fibrous. As in this case, I could not probe, even in spite of cutting a portion of the skin and the subcutaneous tissue, I could not detect the granulation tissue. There was no granulation tissue in the tract. Granulation tissue is good in the sense that if it is present, then that helps us to identify the tract. But here, we could not find any granulation tissue. Everything was fibrosed. For that reason, sir, I could not enter into the fistula. So fistulotomy was not possible in this patient. And fistulectomy, which is the standard technique of placing the probe within the fistula and remove the tract by dissecting outside the fistula tract, was also not possible because the tract was totally fibrous. What I did a wedge excision in the region of the internal opening, which was evident by proper palpation. I remove a wedge excision, which ensures the removal of the internal opening and the proximal tract, and reached up to the intersphincteric region and traced the fibrosed external tract from the external opening, and dissecting from inside out and outside in, I reached a central point and separated the fibrosed fistular tract from the sphincter muscle complex. And during the dissection, I have taken only the superficial portion of the sphincter. So now, what we have done, we have closed partially this fatty region of istiorectal fossa, but skin region is kept open. If skin is closed, the chance of accumulation of serum is much more. Chance of infection is much more. If the skin is left open, then the chance of infection is less. So I am palpating. I can palpate the depression here. The depression here is intentional. I have not closed the external sphincter here because if there is any sepsis, that should get a free drainage. Instead of coming out, it should drain from here. And at the same time, I have reduced the wound by closing the soft tissue, not the skin. Okay, can you give me a Justin suppository? Justin suppository? No. So,
thank you, sir.
Okay.
I think that was an excellent demonstration. We'll take the video of you because we are moving on to the next OT, where Dr. Niranjan Agarwal will be operating another case of recurrent fistula. So thank you once again. We'll take the audio and video of you
Dr.
now.
Manju, what I will do now, at the forceps, the tooth forceps, what I will do now, just I will put a small gauze pack inside that cavity. Small cavity is there.
The next case, a 40-year-old male presented to the surgery OPD with complaints of pustular discharge from right perianal region for 4 years. His past history is history of perianal abscess drainage done from a local doctor 4 years back. Local examination, external opening is seen at 11 o'clock position. MRI report suggests a thick sinus tract seen extending medially from abscess to right perirectum region via istiorectal fossa and divides into 2 branches. Anterior branch ends in extrasphincteric plane at 9 o'clock position and lateral branch ends in intersphincteric plane at 6 o'clock position.
Last, one more towel clip. इधर नहीं हो, आपको इधर से ले, ये पेशेंट टेढ़ा है ना, तो साइड में नहीं बैठ पाएगा, आपको थोड़ा सा एडजस्ट करना पड़ेगा. Doctor, take some more local. Get me more. 10 cc more. So, are the moderators with us?
Yes, we are here. Tell me, Dr. Agarwal.
Okay, so this is a complex transsphincteric fistula with an abscess formation. You can see there is an external opening over here which discharges pus when you press, and this patient has been operated. You can see all these scars over here but long back, and he has developed this fistula now after 15-20 years of the initial surgery. Jelly, please get me one more syringe of xylocaine adrenaline. When you try to trace the tract, you can fill it up till this portion, and the internal opening, when you feel, this is, you can feel the internal opening at 6 o'clock position, speculum. Can you see this scarring over here at 6 o'clock position? And can you see the pus coming out? Can you see the pus?
Yes, yes.
Can you see this? Moderators, am I being heard there?
Yes, yes.
Okay, hold this. So first thing is we'll, methylene blue.
So this one is the internal opening, right?
Yeah, this is the internal opening, this is the external opening. So I am going to inject methylene blue through this, the external opening. इसमें ले लेना. So inject slowly, don't push it, otherwise it gets extravasated. The very fact that more than 5-6 ml of methylene blue has gone inside, there must be some bigger cavity inside, you know.
Yes. It's still not coming out to the internal opening.
Doesn't matter, in some time it will come. लोकल दिया, नहीं लिया, xylocaine adrenaline. Give the infant feeding tube. नहीं, infant feeding tube. What you can do is you can put methylene blue through the internal opening also, you know. This is the internal opening, right?
Yes, sir.
Can you see so much of the tube has gone inside?
Yes, sir.
थोड़ा ही चाहिए, इतना
So your pus is coming out through the tube.
लो dilution करो. I am injecting xylocaine adrenaline around the internal opening because the moment I start dissecting this, it bleeds heavily otherwise, you know.
Okay.
So So you can see the bubbling here.
Yes, now it's coming out to the external
Okay.
opening.
Now there are multiple options how you can approach this patient. One way is to do a lift over here and scoop out the other things. The success rate will be only around 70%. The other is do a proximal fistulotomy somewhere over here, tie the distal opening of the tract and do laser for the transsphincteric tract. Success rate is only again 75 to 80%. But if you remove the entire tract and divide the sphincter and then repair the sphincter after division, then the success rate will be around 95%. So when you say divide the sphincter, remember you have to be below the dentate line. You cannot go above the dentate line. So how do you feel the, below the pectinate, puborectalis sling. So how do you feel the puborectalis sling? You put in your finger, bend it like this and come out. So this first obstruction, muscular obstruction which you feel is the puborectalis sling.
Yes.
My internal opening is below that. Remember, most of these fistula tracts are below the puborectalis sling unless those who are going into the supralevator portions. So we will start our dissection from the external opening. Now because of the previous surgery on the hip, this patient has got inequality of limb and that's why there is a difference in the position actually. Suction. Alice forceps. Alice forceps. Give to me. You retract there. Hold this. So this is all normal fat over here. We have to go around that, around the tract and remove the tract. You can use blunt as well as sharp dissection both. Right angle. Don't bring this in between. It will. Right angle retractor. Give that cat paw. Hold, take this back. Hold this. Okay. Yeah. Can you see the track going there deeper? Pull. Can you see this tract here?
Yes.
Yeah, it's going up there.
Yes,
So
yes.
we have gone beyond that now. Hold this. Right angle. Yeah, right angle. Hold this. What you can do, you can put in your infantry feeding tube also from here and keep on following. You will get something to palpate there. Or you can put in your probe also. Take the right angle, another one. Another right angle, please. Leave this. Another right angle. Yeah, you can. Hold it. एक मिनट. Okay, pull it up. So it's still going higher. Can you see this? Now beyond this level, somewhere we will get the levator plate also. Let's expose that. Normally we would have expected this tract to come in this plane towards the transsphincteric area and cross the external sphincter, but it appears to be going deeper. Okay. Take a C-shaped retractor. सिस्टर को बोलो C-shaped retractor. हाँ, yeah. Hold this. So there is some fibrosis as I cut over here. I can feel that. Can you see this whitish color fibrosis over here? अंदर कैमरा दिखाओ. Now this is the problem with most of the patients who have been operated previously, because a lot of scarring takes place and you are really not able to identify whether it's a diseased tissue or it's a... Can you see the muscle there?
Yes, yes. fibers are visible.
Yeah. Can you see this muscle fiber? So this is crossing the levator muscle, whereas the MRI said it is not, right? Hold it like this. Have you got the C? No, that is not C. I need to see inside. So I am using a blunt dissection with my finger wherever I can go.
Sir, in this region, according to the MRI, probably in this particular region, there are two tracts. One is supralevator, another is going to the thigh. Is it, sir? This tract, whether part of it is going supralevator towards the levator?
It may be going to the supralevator, it may be going to the joint also, the way it is going. You know?
And another part is going to the
what
thigh.
I am going to do is now, I am going to first tackle the internal opening. Now remember, in fistula, ये छोड़ दो ये सब, छोड़ दो एक बार, आप निकाल दो. In fistula, the main disease in the cryptoglandular fistula is at the level of the internal opening, which is the main culprit.
Yes,
and the other tracts are just an extension of that infection. So, if you tackle the internal opening and do a scooping of the other extension, then also there is a large chance that the fistula will heal. Right?
Yes,
and rather than damaging the muscles there, you should stop.
Yes.
To Alice, please. Hold. Hold. The infected anal glands lies just below the internal opening. So I am going to exercise that now. You saw Dr. Maiti doing it in the last case also. He coded it out from the internal opening.
Sir, one question is from the audience,
Yes, sir.
whether in this particular patient, lift technique is can be done or whether it cannot be done in this patient.
Which technique?
Lift.
Lift, I said, here if you have to palpate the tract, you can do a lift. There is no contraindication. Only thing is recurrence rates are around 30% with lift.
Probably the lift is more suitable for simple radial tract.
Which is more suitable for?
Simple and radial tract.
Simple and radial, low transsphinctic, I only do a fistulotomy.
If it is a intermediate...
this is not simple. You saw the other end of the tract going high in the supralevator plane.
This is high intersphincteric.
You cannot call this a simple fistula.
This is one of the most complex fistula.
By definition itself, once it is operated previously, it becomes complex.
Complex, yes.
And this is actually complex, you can see. Actually, many a times, even MRI reports are not corroborative with your clinical findings.
Clinical findings, sir.
Alice. And give me a tooth for it. Tooth.
Sir, in Mumbai, Asicon, in the workshop, whether fistula cases will be also placed or not?
Sorry?
In Mumbai, Asicon workshop, whether fistula cases will be the part of the workshop or not? Are you planning also?
It will be worked.
So, because Mumbai is the city of your a group of very reputed colorectal surgeons. So we expect that in Mumbai, something during ASICON is to be done on this particular
Yes, it will
fistula.
definitely be there, I promise. The tissues are friable. Alice is not the problem. Can you just catch it? Don't pull it. Don't pull it. It will tear. So we have gone up to the intersphincteric area. You can see there.
Yes, sir.
Can you see this area?
Yes, sir. Yes. So we can see that the internal or the proximal tract is in the grip of your Alice forceps.
Yeah.
You have traced the internal portion of the tract up to the intersphincteric region.
Yes.
And now probably we will reach into the intersphincteric abscess area, and then usually that part is most of the time is wider than this proximal tract. Sir, one thing, what is the exact statistics in your case, the incidence of tuberculosis with fistula in our country? Is it
Tuberculosis in all, I have sent all my specimen for MGIT and gene expert, and on an average around 10% of the fistulas turns out to be tuberculosis.
Tuberculosis. 10%. Actually, what we found, two of our students did the thesis on fistula and tuberculosis. Incidentally, it was less than 2%. That was the surprising, but literature always says that it is more than, as you have said, it is more than 10%.
10% definitely you see, sir.
But our observation, I don't know, it was not too high.
Okay.
Though even in multiple fistulas of cryptoglandular origin,
I think if you do the thesis on a recurrent fistulas only, don't take all the fistulas, then you will find that the incidence is more. But if you compare with, take the volume with simple fistula, then maybe the incidence comes as low.
So another question is, if it is, if the fistula is due to secondary causes like tuberculosis, Crohn's, then the internal opening, the incidence, is it in the dentate line or most of the time it is not
It
at
can
the
be
dentate?
at abnormal lines also.
Same
It
site?
need not be at the dentate line. Dentate line fistulas are mainly cryptoglandular.
Tuberculosis may be anywhere, but still...
Tuberculosis fistula because the rupture of the lymphoid tissues in the submucosal plane.
Okay, fine. So that may not be there in the cryptoglandular dentate line.
So I am going to disconnect it from here now.
Yes. So after excising this portion of the tract and reaching up to the internal intersphincteric space, will you, at the end of the operation, will you like to close this opening or you will leave it open?
I'll see how much more I can remove from the other side.
Okay, sir.
You see, I have dissected this quite inside now.
Okay, probably you are in the intersphincteric space. Your finger is in the intersphincteric space.
Yeah, my finger has
on the right
dissected
side.
quite a bit.
Is there any extension on the left side? Then we will appreciate. So it is reaching up to the external dissection site.
Yes. Only thing, this particular portion is going higher up, this one.
Okay.
You know? So, Alice. So I'll disconnect it here. There's no point in pulling it further. Histopathology, huh? Okay.
Sir,
So this area is clear.
Sir, what is the incidence of more than one internal opening? That is, at the same time, both the cryptoglandular infection occurring at two different sites.
Yeah.
It may happen sometimes. What can be the incidence of double internal opening?
Of what opening?
Double opening.
Double opening.
Internal
internally
opening
are-
more than one.
In a cryptoglandular fistula, it is only seen if there is a previous surgery and some good friend of ours has probed it inadvertently. So it's an iatrogenic opening. Right angle. C आया, C retractor नहीं आया. तो बड़ा वाला right angle था ना उसके sister के पास में. Or if it is a rupture of the intersphincteric fistula inside the rectum.
Okay,
Otherwise, almost always there is only one internal opening, and that is at the 6 o'clock position at the dentate line. Can't see anything. So my vision is slightly hampered because of the position and the depth. So I am using a lot of my finger palpation and tactile sensation to feel the indurated tract. चलो. One more. Give the other one. Give the other one. Light देना अंदर. It is still going higher actually. What I am going to do is, I am going to disconnect it here, because I don't want to cut the muscle higher up.
Sir, can you appreciate how much tissue is there between this external dissection and the internal part which you just took the
This
tract?
much tissue is there. The problem is this tract is going higher, not transverse.
Okay.
ये retract करो ये वाला.
Should we curate the tract before we remove the
No, I
distal
will
part?
curate it, but after disconnecting it. Yeah. Show, they will not be able to see. Retract properly. Take. Give. Light अंदर दो बाबा. Give the light from inside. ऑफ नहीं, अंदर दो. अंदर कुछ दिखेगा ही नहीं. हाँ? So I am following my tactile sensation and cutting actually. Yeah.
So you're holding the tract with the alleys and following it with your fingers
Yeah, I
while
am following
dissecting
the
it.
induration. Beyond a particular point, it is not getting dissected. So we will disconnect it from there. Can you see this granulation tissue? I also can't. ये पकड़ो जरा. Just hold this. So
Okay, now अभी अंदर दिखाओ. Scoop देना मेरे को. So this is the site where I disconnected it. Can you see this? These are the granulation tissues. So this is the bone. As I was telling you, I suspect the bone. Can you feel my scoop hitting the bone? So this man should undergo an MRI of the hip joint. This is the dirty granulation tissue which was going up. So some infection from the bone also should be ruled out. Can you see these granulations?
Yes, sir. So you are also scraping the area surrounding the tract, isn't it? You've taken off the tract.
No, first is where I disconnected the tract.
Right.
I have gone inside. The tract which was going higher up, I was telling you, I did mention that it may be going to the bone. And you put your finger inside, you'll see the bone. Can you? This is the bone. So I'm just scooping whatever granulations are there in that area. Gauze piece. Sure. Just pack it for the time being. Remove. Get the speculum back to me. So all these tissues should be sent for not only histology but gene expert and TBMGIT. There are good chances that this patient may be having some focus of tuberculosis. Take this speculum again. Okay. Give me gauze. Give me some irrigation. So we had disconnected here. There is only normal fat coming here. Can you see this?
Yes, sir.
This is normal fat, rectal fat. Give me an artery forceps. So this is normal looking supple fat tissue over here, whereas this is going to the bone. There has to be some connection because the methylene blue came out of from here, right? So either the tract is coming from higher up and going down into the area. We have removed this proximal area completely, the tract as well as the internal opening. We will seal this area and drain this area outside. So that should suffice. The infection has been taken care of. The muscles have been preserved, and further contamination can be prevented by just closing this area so that no further fecal matter contamination occur. Irrigation चाहिए मेरे को. This is so you can use your gauze piece also as a scoop because that takes a. Can you see the granulations which come out with the gauze piece also? Many a time it takes the shape of the cavity and that scoops out completely. Whereas our scoop is a stiff thing, it may not take the shape of the cavity. Yeah, it's dry now. So I'll just keep it for
hemostasis purpose. Give me irrigation. Just keep it like this. Kidney tray. You can put the suction here. Chalo, irrigation. Two zero Vicryl. Did you get what I was saying, what we are doing, and everybody agrees that that is the only available option right now? Anybody has another suggestion? Dr. Maiti?
Dr. Maiti went for another surgery.
Okay.
But I think we don't have any other option left with us.
So what does the other moderators feel, or any questions from the audience anywhere? There is some little tract which is
Sir,
still
it's
should be pending.
nicely presented.
Sorry?
It's nicely presented. Thank you.
I think there is some little tract somewhere which is there which we are not able to get. But that's why we will keep this area open for drainage of that tract.
Sir, my only question to you is that the external tract that you dissected and the internal that you dissected, they did not communicate at any point.
Yeah, you are right.
So
that's why I said,
yeah.
That is what I am saying. There is some communication which is still pending where we are not able to reach that.
Right, sir. So the external is probably going higher up. So since if you keep it open, that will drain.
Yeah, exactly.
Yeah, but with the internal tract, we did not find the other end of the internal tract.
But
So,
then there is some connection there which we have established through the methylene blue earlier. So that will also drain through this area, no?
is there any possibility of, giving another check with methylene blue to see whether once you're introducing
madam,
through
there is no opening here. You
there's
can
no
see there.
opening, right? Okay.
No, where I can put the, this is only going into the subcutaneous area. And the scooping is also showing normal fat. So whatever that little opening with a thin tract, whichever will be there, that is connected somewhere inside where we are not able to get. So it will also drain outside.
Yeah, principally we did the right thing. We have eliminated the intersphincteric part, which is the source of infection actually. So that is the main thing. Only thing is that one part of bad granulation tissue with the remaining tract may disturb us in the post-operative part.
Yes, it is going to. In fact, that's why I said in the post-operative period, this man should undergo an MRI of the hip joint.
Yeah. That cannot, yes, of course.
Yeah.
I think this is the best way to tackle this type of fistula, with least morbidity actually. Otherwise, the procedure becomes more morbid.
That is what I tried, no? There is no other opening here. But we never knew, no, it will not match there. We always thought we'll be able to go there. Okay, give me the infant feeding tube. Let me satisfy myself for the last time. Flush करके दो, flush करके. नहीं मिथलिन ब्लू नहीं चाहिए, खाली ट्रैक चाहिए. Infant feeding tube चाहिए. Give an artery faucet. I have. So this opening, I am convinced it is not connected directly, it's in the subcut. I'll try and see if something goes other place, higher up somewhere. This also. Actually, there is no other opening which we can see to probe. Okay. All stopping short. Maybe it's a very narrow tract in between, which is Vicryl.
Show me. I can't see the light. Hold this. Nahi this. So I am taking the muscular bites also here because that will support the mucosa. Normally I take internal sphincter and the submucosa and the external sphincter separately. Sure. Keep it loose. Keep it loose. Yeah. So this will close the intersphincteric space also. Right now what I am suturing is, this is the external muscle, this is the internal muscle. So what we are trying to do is only closing the intersphincteric space. We haven't damaged the muscles anyway, right?
So you're only closing the muscles in the internal opening. The external opening, you're leaving it totally open for it to drain.
Yes, yes. If I had found a complete tract, I would narrow this down. Anyway, we always keep this open for drainage, but I am not going to narrow it also today.
So are you planning to keep a wick or a corrugated drain or anything
It's
of that?
quite a wide opening otherwise also, madam.
Okay.
সব ইন্টারস্ফিংটারিক স্পেস থেকে উপরে বা নিচে যাবে, ঠিক আছে? সুপ্রাস্ফিংটারিক যদি তুমি স্ফিংটার কেটে যাও, তুমি লিভার ড্রেনাজ কিছু করতে যাও, প্রবলেমে পড়ে যাবে। তুমি জাস্ট ড্রেন ইট, কোনিং করে নিচে ড্রেন করে। আচ্ছা, আমার মাস, হ্যাঁ হ্যাঁ, কমেন্ট এটা আমার তুলে দাও মাসটা। এটা আমাকে মাইকটা দিয়েছে তো, ছবিটা দেখাতে বলো। এই তো এসে গেছে। ডক্টর সমিতা, ডক্টর মানস.
Yes, sir, we are here with
please
you.
read the summary, what is written in the
Summary? Sir, give me a moment, sir. I'll get the summary.
Sir, this patient presented with a pus discharge from the perianal region from a small opening for last 3 years. He also had a history 5 years back of fistulectomy. And after that operation, it got relieved, but it gradually increased for past 3 years. On examination, there is a external opening at 5 o'clock position and 12 o'clock and 1 o'clock, which is at the base of the scrotum. Next, MRI reveals a fistula. Sir, ma'am, external opening is at the 5 o'clock position and also at 12 o'clock and 1 o'clock, which is at the base of the scrotum.
Okay, in addition to this opening which is at 4 or 5 o'clock position, there is one opening here, and another opening here, and one healed opening here. So you see there are multiple external openings. Some of them has already healed, or new opening has appeared, and there is pouting granulation tissue. So this opening, এই মাইকটা তো হচ্ছে না, যাচ্ছে না বোধহয়, মাইক যাচ্ছে, মাইক যাচ্ছে, এটা নেমে যাচ্ছে, মাইক যাচ্ছে না তো, যাচ্ছে তো,
হ্যাঁ স্যার শোনা যাচ্ছে,
শোনা যাচ্ছে এবার। and this is the scar mark of marks of operation. So in this case we can say that it is a complex fistula, and complex fistula that groups different types. You see this is a flatus coming out, and palpation is very important. Digital examination is very important, and next to digital examination MR fistulogram is very important, and both of them are very important, digital examination and MR fistulogram. But of these two, digital examination is more important than MR fistulogram. MR fistulogram may make mistake, but your digital examination, if it is proper and meticulous, that gives more idea about the fistula's anatomy and particularly the internal opening. And MR fistulogram along with the digital examination is excellent. MR fistulogram is complementary to the and supplementary also to the digital examination. Next.
Sir, I have one query.
Yes.
Do we have any detailed information about the history of the patient?
So
Meaning what I wanted to
already
know
they have said there 5 years back this swelling first appeared, there was discharge and operation was done here, and for the last 3 years he is having other openings here, and this discharge which was present that has reappeared.
What I would like to know is, does he have any history suggestive of inflammatory bowel disease? Because
no,
very
there's
often...
no history suggestive of inflammatory bowel disease. You see, the history started with localized symptom and sign. That means only in this region. It started with an abscess here, and then it progresses in appearance of multiple opening far away from the anus. And we know that external opening may be anywhere, that may be in the thigh, in the abdomen, that in the gluteal region, in the scrotum, that is possible. And most of the time you see, if it is of cryptoglandular origin, if it is not of ulcerative colitis or Crohn's disease, almost always the internal opening is at 6 o'clock position. And that is at the dentate line. And most of the time it is a horseshoe fistula. Horseshoe fistula may be of two different categories. Horseshoe fistula is external horseshoe and internal horseshoe. External horseshoe has no importance clinically and from operative point of view. But internal horseshoe, that is the tract, horseshoe tract, which really a horseshoe tract, that is in the intersphincteric space between the internal sphincter and external sphincter. That is more important. I hope in this patient there is a intersphincteric abscess in the form of horseshoe, and all these openings have connection to that horseshoe. And this horseshoe has a single small tract in the 6 o'clock position that passes through the internal sphincter and opens into the mucous membrane. So remember, this internal tract or proximal tract traverses through the internal sphincter. Intersphincteric abscess or horseshoe tract lies between the internal sphincter and external sphincter. External tract will form only when the intersphincteric abscess will burrow, will make opening in the external sphincter, and that will come out and traverse in different way and will appear on the skin surface. Okay, so the source of infection is the internal opening and the proximal tract, and the storehouse is the intersphincteric space. And intersphincteric space is there that cannot expand, so it will try opening in the external sphincter to come out. So the length, internal sphincter can be widened to certain extent. And I request my assistant to palpate the intersphincteric abscess, and we will find probably a horseshoe tract. You palpate, Krishna?
Sir, before you proceed, I would just like to add that we had a patient just a month back, very similar, clinically appearing very similar to what you're showing now. But that patient on workup, because there were multiple fistulae with complex tracts on MRI, we worked him up and found him to be positive for Crohn's. So we had held on to the surgical planning. He is on active pharmaceutical management for Crohn's, and already many of the tracts have healed. So we are planning to only operate on the 2 fistulae tract which have persisted in spite of medication.
Dr. Somita, just
Yes.
I am telling my finding here. On digital examination, I find a horseshoe intersphincteric tract that is very firm to hard. My assistant Krishnan is saying that there is something circular bony thing. It is so hard that he is telling that it is bony. But at the same time, just below that horseshoe tract, if it is a horseshoe tract, my finger is a horseshoe tract, just at the center, I can palpate a groove, a pit. An internal opening here is palpable, very definite. You palpate? Internal opening is palpable here in the form of a funnel-shaped opening. And I am sure in this patient, our operation will give good result because we can palpate the internal opening. And if I am fortunate, I will be able to demonstrate the internal opening by dye test. Okay?
Sir, regarding the tract that you're talking about, what is its relation with the dentate line? How far is it
Dentate line,
from?
that is at the dentate line.
At the dentate line. Okay.
And most of the time, these complex fistulas always have a opening at the dentate line, Alice forceps. I'll just show you. এবার দুটো দাও মানে ল্যাঙ্গেনবার্গ ডিটেক্টর
What is the information on the MR fistulogram? Have they commented on whether they are all communicating with each other or not?
Not so. They are not telling in details. Dr. Agarwal and me examined the patient, but we could palpate a indurated tract in this region. So they have not mentioned this communication, but clinically we got the indurated tract here. And I probably will be able to show by dye test that when I am pushing the dye, it is coming through this region. I hope it will be positive. Langenberg দাও আরেকটা Langenberg দাও.
Sir, we'll take the audio off your OT for a few minutes. We'll go over to Dr. Agarwal and we'll come back to you in a very short while.
Yeah, can you hear me?
Yes, Dr. Agarwal, you're audible.
So we retried putting in a tube here and it did go to some extent. Can you see this?
Yes, sir. Yes, sir.
But this is going into the bone. This cavity which we scooped, can you see here?
Yes, if the camera person could zoom in a little more.
Please show here.
Yeah.
See my artery forceps going inside there.
Right, sir.
Can you feel?
Yes,
and
sir.
This is the bony area which we were talking about.
Yes.
Can you feel the toughness? So we have scooped that area. I will re-scoop it and see if there is something coming out. Nothing came through my gauze. A chota scoop hai kya, sister? Yeah, there is some
Yes, there is
granulation
some
still
tissue,
there.
yes.
So basically there has to be either bony involvement in this patient or there has to be some bony pathology other than the fistula. छोटा स्कूप देना जरा.
So the scoop tissue should be sent for histopathology, right?
Give me the gauze. Irrigation there. Suction. Cautery. No problem. I think we have done with that quite efficient.
Just wait. We'll shift it.
Can you see this muscle fiber here, and this is the bone there. Take this granulation further. Artery.
Dr. Agarwal, can we switch the audio to the other OT for the timing? We'll come back to you.
Okay, now. Dr. Somita?
Yes, sir, you're audible.
Am I audible?
Yes, sir, you are.
Tulika. So you see now my target is to find the internal opening. What I have palpated, I will try to inspect it. Okay. So I have catch hold the lower margin of the anus. Actually, because of previous operation, this anus opening is already fibrosed. So it is not pliable. I cannot pull it much. So I am introducing a proctoscope as high as possible. Then you see I am withdrawing it. Ei sakat dao. Sakat dao. Sakat dao. Eta dao. Goli swab dao. Somita, I am just showing there.
So you'll have to talk us through it. We cannot see inside the proctoscope.
So can you see the inside?
Not
Can you see the
really.
inside?
Not really, sir. You have to talk us
এবার
through
দেখো
it.
এবার দেখতে পাচ্ছো ইনসাইড
Can the camera person zoom in a little more?
জুম করো দাও সাকাত দাও সাকাত দাও
And sharpen the image.
এই সাকাত দাও it is
You
now
need to
I can
focus the image.
identify the area. You see this the sakat tip here the now by with the anoscope we are seeing the posterior wall of the anorectum. And this mucous membrane is little bit congested, but the mucous membrane below this area is little whitish. And there is a opening which is hanged over by the fold of mucous membrane. This mucous membrane, this area is the site of internal opening, and we could palpate this area as a funnel-shaped opening. And the tract, the hard tract is here in this position. In this position, hard tract is there. This is the position of the hard tract. Now, give me the water.
So you were asking Dr. Agarwal in the previous case that whether you get two internal openings or not. But here you have multiple external openings.
Yes, but one single internal opening.
Single internal opening. Now the question is whether that one is communicating with all of these external openings or not.
all of them, with all of them. And one thing you see, when I am pushing that, you see, so I am trying to demonstrate the internal opening by dye test, by pushing water, simple water, saline through these external openings. See what is happening. What you are seeing, jet of water is coming through
through the other openings.
Other openings.
Right.
So there is a communication. Dr. Agarwal and me palpated this tract, and so it confirms, this test confirms. Okay?
So can you repeat it? Yes, that's very well visible.
So you see jet is coming. Okay?
Through
And
all of them? Through all of them?
All of them are communicating.
Okay.
No, not through this, because these are fibros, closed. And this is open, so this is coming. So these
Right,
tracts
sir.
are already closed.
Right,
Okay?
sir. Yes,
As
sir.
it is closed, a new opening is formed.
So
But
another thing I needed to know is when you're pushing the water,
Yes.
are you seeing water coming through the internal opening as
exactly.
well?
I am just showing now.
Yes, sir.
I am trying to demonstrate that, but as it is a very easy path, it is a wide path, that water is passing very easily. So I am requesting my assistant to close this tract. ভালো করে করো এইভাবে ভালো করে হাত দিয়ে ডবল
So basically compress that area.
compress that area so that it water সাক করে দাও ভেতরটা and if that এরপর একটা সিরিঞ্জে দাও হাইড্রোজেন পারক্সাইড দাও now I am pushing it ভালো এখন আসছে till it is coming ভালো করে চাপ দাও এইখানে চাপ দাও দরকার এইখানে বন্ধ করো শুদ্ধ এখানে একটা হাত দাও এখানে একটা হাত দাও you see it is still not coming because this is a very wide space. Okay?
So it is basically taking the route of least resistance.
Yes. So as I could palpate the internal orifice and this area of the internal orifice, here the mucous membrane having different texture that is fixed to the underlying internal sphincter, and I can also open the funnel-shaped opening. I hope that will lead to intersphincteric space. Now, what should be the treatment now? What shall I do?
So
what
sir,
is the
what is your
suggestion?
surgical planning now?
So please tell me, if anyone from you, what you will suggest me, then I will consider. I have a plan in my mind, then what you will do? Now,
Sir, first we have to manage the internal opening.
So internal opening I could not demonstrate because the tract is, but by palpation I could palpate the internal opening. So what is my plan? As I could find the internal opening, and that is as it is typically at 6 o'clock position, so that corroborates with the basic principle of all cryptoglandular infection. Close to 90% of cases, the opening remains at 6 o'clock position. Here we suspect and palpate it is in a 6 o'clock position. Though we fail to show the dye test, but yet I am sure that is the internal opening. And I will demonstrate that will lead to the intersphincteric abscess. I will make the intersphincteric abscess open up internally, and I will do nothing to this external tract. And I will just scrape either mechanically or with laser. So that this external tract granulation tissue went away and this tract heals up. As this tract has healed up, because it has developed a new tract. If there is no infection, no collection in the intersphincteric space, the pus will not migrate through this area. If intersphincteric abscess is not there, this external tract will not be there. Okay?
Is there any option of laying open the area between the 5 o'clock and the 12 o'clock tract?
So I'll do later. First, let me attack the internal opening site and enter into the intersphincteric abscess. আমাকে দুটো ল্যাঙ্গেন ব্যাগ দাও, লম্বা লম্বা ল্যাঙ্গেন ব্যাগ। As Dr. Agarwal has done the dissection of the internal opening and entering into the intersphincteric space, I will do the same thing here. You see, I have, এটা ধরো তুমি, আরেকটা অ্যালিস দাও, আমি নিয়ে নিচ্ছি। এটা এগিয়ে দাও আমার দিকে। এটা এই দিকে ধরবে, এই দিকে ধরো, ঠিক আছে? এই এটা অনেক ফাইব্রোসিস আছে বলে তো অনেক, এবার লাইটটা কেউ ফেলতে হবে গোটা, কেউ আমি তো দেখতে পাচ্ছি না, আর তো অডিয়েন্স তো দেখতেই পাবে না। এইবার দেখাও গো একটু ভালো করে, এই ধরো, এই ভেতরে লাইটটা ফেলো গো। এইবার দেখো, এবার দেখো ওপেনিংটা কত সুন্দর দেখা যাচ্ছে। এইটা লাইটটা কিন্তু না দিয়ে টর্চকেও ফেলতে পারো, টর্চকেও ফেলতে পারো, টর্চ ফেলো না কেউ, লাইটটা ফেলো ভেতরে, ওপেনিংটাই দেখা যাচ্ছে। এই যে ওপেনিংটা, না দেখালে গেলে তো হবে না। দেখেছি, বের করে দাও তো, বের করে দাও। It is so fibrous that this proctoscopy is not entering. Okay, now it is better. খুলে দাও এটা। In this patient, there is also some amount of hemorrhoids. এই যে এই দেখা যাচ্ছে, আমাকে তো দেখতে হবে। ঠিক আছে, তাহলে আমি এটা করি, আর কি করবো। এই দেখো ওপেনিং দেখা যাচ্ছে এখানে, ওই ওপেনিংটা, ইউ ক্যান সি দ্য ওপেনিং হেয়ার। এই তো ওপেনিং দেখা যাচ্ছে। এইটা ধরো, এইটা ধরো, এরম করে ধরো, এরম করে ধরো, এরম করে ধরো, ভালো করে এই যে ফিক্স করো, ধরে গেলে হবে না। এই যে লাইটটা পড়ছে, লাইট না পড়লে আমি তো পাবো না। এটা একটু আমাকে এগিয়ে দাও। এবার হচ্ছে ডায়াথার্মি। এর না, এর পাইলস আছে, এর হেমোরয়েডস আছে শুদ্ধ। দেখো ওই সামনে এই যে হেমোরয়েডসগুলো বাল্জ করেছে। আমাকে একটা সমিতা, কাঁচি দাও।
Yes, sir.
Actually, this patient, the problem is the fibrosis around the anus. There is a fibrosis at the level of the intersphincteric abscess. At the same time, probably because of the previous intervention, there is also fibrosis at the anal orifice, anal verge, Alice down. So I cannot dilate, I am unable to dilate properly.
So in that case, what is your plan, sir?
So anyhow, with difficulty, anyhow I have to enter into the intersphincteric, no way. Because
is there
that
any
is the
role of probing now? Since you can feel the internal opening, can
I
you not
can
put
see
pass
it.
a probe?
I can see it. The probe will not pass easily because I will try to pass a probe, otherwise its position may be lost. Okay? এবার আবার ধরো আমরা যেটা সমিতা has suggested, if I place a probe, then its position will not be lost. দাও এবার এটা আরেকটা দাও, এই নাও ধরো। দেখো usually if we pull the anal mucus, anal skin, most of the Alice দাও, Alice এখানে আছে, most of the time it comes down, posterior wall comes down. আরেকটা দাও, আরেকটা কিন্তু লাগবে। আরেকজন কেউ নাবো না, আরেকজন সিস্টার একজন নামতে হবে, আমাকে টেবিল থেকে জিনিসগুলো দিতে হবে ঠিকঠাক। এটা ধরো, এটা ধরো একটু। দিস ব্লিডিং মে ডিস্টার্ব আওয়ার dissection, so as less as, okay, fine. ব্যাস এবার একটা প্রোব দাও। হ্যাঁ আরেকজনকে নামতে হবে তো। So I have palpated the internal opening. Yes, this is easily entered. You see how it walks in. Just I place it, it walks in. Samita, will you appreciate the movement?
Sir, it will not be possible for us to see
Okay,
it from
fine,
here.
fine.
You talk us through what you are doing, sir.
Okay. So when I place the tip of the probe at the suspected internal opening, just little push, it has entered up to 2 centimeter inside. Also this. এইটা হ্যাঁ এবার দাও, দাঁত আর দাও। এটা দাও, এইটা দাঁত আমি না সবসময় এটা এদিকে যখন কাজ করব এই ডান হাতে যাতে ক্রস করবে না, এটা এইদিকে। So I am sorry that I am not able to show the area because of fibrosis, but when I will enter into the এটা দুজনকে দুদিকে টানতে হবে, এরকম এইটা টানতে হবে। ব্যাস এইবার হচ্ছে আমাকে একটা ছোট্ট আরেকটা অ্যালিস দাও, আরো দুটো অ্যালিস দাও। না ঠিক আছে, এটাও ঠিক আছে, এটাও লাগবে, আরেকটা ছোট করব। হ্যাঁ দেখাও। এটা একটু সেরতে পারবে কেউ? এটা আমাকে সাকার। এই মানস, আর ইউ দেয়ার? মানস
স্যার,
ক্যান ইউ কাম টু দ্য ওটি?
I coming, sir.
দেখি।
Sir, we've had a very long and fruitful OT today, and this wouldn't have been possible without the help of a lot of people.
এই দেখো, এই যে ওপেনিংটা পরিষ্কার দেখা যাচ্ছে মানস, এই যে দেখো সুন্দর ওপেনিং দেখা যাচ্ছে। ইউ সি সমীতা, how this probe is very easily entering this.
Sir, but it's easily gliding in, but which direction is the probe moving?
Direction is going backwards and upwards.
Backwards and upwards. So is it moving towards the 12 o'clock opening?
No. It is backwards, towards the posterior anal wall.
Oh, the posterior anal wall. Okay, I'm sorry.
Okay.
Yeah.
Actually, it needs proper retraction of the mucous membrane. Otherwise, I may injure the other wall. Okay, I like to stay definitely around the internal opening. Otherwise, as that retraction is not so good. Yes, now, এভাবে ধরো। ব্যাস এই ধরো। মানুষ আসুক। হ্যাঁ ভলকম্যান স্কুপ লাগবে, বড় ভলকম্যান স্কুপ।
So we've had a number of cases lined up today and it's been a very fruitful experience. But this would not have been possible without the support of the NRS Surgical OT family. Having worked here for a long time, I know what a wonderful cooperative nursing support staff as well as anesthesia family we have here. And on behalf of the Association of Surgeons of India West Bengal State Chapter and Department of Surgery, NRS Medical College, we would like to profusely thank Department of Anesthesia, all the nursing staff, particularly sister in charge of the OT, and the support staff here. So thank you all very much for making this experience so wonderful. We will go back to Dr. Shukumar Maiti for his demonstration now.
এই ছাপ অন্ধকার হচ্ছে, একটু টর্চ ফেললে কিন্তু ভালো হয়।
Sir, we'll request the camera person to reposition the camera. I think your head is coming in the way.
Also the light.
Yes, sir.
Light,
Yes.
এটা একটু সরে, এইদিকে সরেছে, আমি যন্ত্রটা আমার হাতের কাছে রাখতে হবে। ব্যাবকক্স দিন, এই ব্যাবকক্স না, অ্যালিস দিন, লম্বা অ্যালিস দিন, লম্বা, খুব লম্বা অ্যালিস দিন, কারণ ডেপথে তো লম্বা অ্যালিস না হলে হবে। চাক করো তো। না, ছা পড়লে হবে না, তোমার এই ছাকারে ছা পড়লে হবে না, ছাকারে ছা পড়লে হবে না। আমাকে এখন কাজ হচ্ছে, আমাকে ইন্টারস্ফিংটারিক অ্যাবসেসে পৌঁছতে হবে।
So, sir, you're opening up the tract over the probe, right?
ইয়েস ইয়েস। মানুষ এসছো, দেখো তুমি এখানে এই জাস্ট এই যে আমার প্রোবটা ট্র্যাক্টের মধ্যে আছে, এইবার তুমি একটা এইটা দেখো, এই যে পাইলসটা আছে, পাইলস মাছটাকেও টানতে হবে আর এই জায়গাটা শাক করতে হবে। এই না, এই না, লম্বা ডিভার্স দিন, সরু ডিভার্স।
Sir, how far can you introduce the probe, approximately?
No, it will be limited after a certain distance. When it will touch the posterior wall or the superior wall of the tract, it will not move further.
No, sir, what I wanted to know is, what length of probe has gone in?
That is 2 inches.
2 inches, right.
Not 2 inches, that will be less than 2 inches, 1.5 inch like that. So actually the diameter of the tract is about 1.5 centimeter here, and it has passed little laterally, either left or right, like that. হ্যাঁ, লং অ্যালিস লাগবে। সরু দিতে হবে, এটা যাবে না, যাবে না, সরু লাগবে। দুটো লাগবে, দুটো লাগবে। না বোধ হয়, দেখি 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 ছাড়ো, রিট্রাক্টর করে বের করে না, অন্য রিট্রাক্টর বের করে না। হ্যাঁ, বের করে না, এই ধরো, হ্যাঁ দিয়েছি, এই হ্যাঁ হ্যাঁ গেছে, ঠিক আছে।
We have another case which is ready in the second OT. I will request our postgrad trainee here to give a brief history of that case.
This is the last case. This patient presented to OPD with pain during defecation since last 1 week and bleeding during defecation since last 1 week. The patient presented to the OPD with complaint of pain in perianal region during defecation since the last 1 week. There is associated complaint of bleeding in the form of fresh blood since last 1 week. Patient has experienced similar episodes multiple times over past 10 years, resolving with medication. This patient has no history of hospitalization. On examination, a thrombosed external hemorrhoid at 3 o'clock position and internal hemorrhoids at 3, 7, and 12 o'clock positions was found. No active bleeding. The plan is hemorrhoidectomy and spinal anesthesia.
Thank you. Could we have Dr. Shukumar Maiti back, please? Yeah.
আমরা ব্যাক করছো কিন্তু I cannot show you.
So we are back with you.
Now little bit, Dr. Manos has come. He may try to demonstrate, show the area. So probably you can see to some extent that area. Yes. Thank you, Manos. Actually, Somita, the probe what I left, that has come out. And once
Yes, sir.
it has come out, and once I have made the incision and made the surface raw, that area is, that internal opening is not so good at the present now, because that has been with. So, but yet, the area we have demarcated, made a circular incision around the internal opening. I hope we can reach suction. You see, this fold is coming in the field.
Sir, I would just ask for a clarification. You said that you've introduced the probe and you're cutting it over the probe.
Over the
So,
probe.
right,
But
sir.
at the moment, the probe is not there. It has come out. But I failed to reintroduce the probe because.
Okay, so you're
probe
now
was-
moving in the reverse direction. You've taken care of the internal opening and you're dissecting around the internal opening.
Yes. I am just
Right, sir.
dissecting around the internal opening, and I will reach, by dissecting, will reach to the tract. And I will confirm, দেখি এবার এটা তো তোমার ওই
So your
জলদা-
aim will be to
জলদা-
communicate the two dissections.
Yes. You see, when I'm just, as I can try to demonstrate that I am in the right place, by now probably that I may enter. এটা আবার দাও, হাইড্রোজেন পারক্সাইড দাও আবার। ব্লিডিং আছে। একটু উপরে যাও, এইটা একটু উপরে। একটু উপরে। পছন্দ মতো না থাকলে জিনিস না। দেখি একটু বের করতে ট্র্যাকটা, এটা বের করো, লিভারটাকে বের করো। আমি হ্যাঁ, এবার আমার রিস্টার্ট করো এটা, ওই যে উপরটা রিস্টার্ট করে দেখা আমাকে। এই কেউ টাইট লাগছে না, এটা দেখো আমরা, and we can identify the pathological area. So I hope না মিউকাস মেমব্রেন চলে আসছে না, দেখছো না, ওইটাকে আমাকে সরাতে হবে, নাহলে তো এইভাবে ধরো, দাঁড়া, ছাড়ো, এই ধরো, হ্যাঁ, এইটাকে টেনে রাখো, এইটাকে রিস্টার্ট করে রাখো, ওইভাবে সাকার দিয়ে। হ্যাঁ, গুড।
Could we have the audio in the second OT, please? Dr. Agarwal, if you could talk us through what you're seeing.
Can you see the video
Yes,
first?
sir, we can.
This is again a similar case what I just demonstrated some time back. Again a grade 4 hemorrhoid here. You can see this large grade 3 hemorrhoid here and another large 3 hemorrhoid here at the 11 o'clock position. Can you see this?
Yes, sir.
Just.
So what are you planning, sir?
So I'll be doing again the same procedure. You can do a laser at the 11 o'clock position and excise the two. because I don't want to do a stapler in this patient because of the prolapsing hemorrhoid. Why, Krill?
Even if it was not prolapsing, would it be an indication for a staple hemorrhoidectomy?
Madam, a bit louder, please.
You said that because it is prolapsed, you would not like to do a staple hemorrhoidectomy. That given the fact that there are 2 hemorrhoids at 11 and 7 o'clock, would you do a staple hemorrhoidectomy in this case?
The issue is there is higher recurrences in the grade 4 with stapler. If all 3 were same grade like 3 or 2, I would do a stapler.
Right,
Doesn't
sir.
matter.
That's it. Yeah, that's exactly what I was looking for.
My inhibitions are because of this grade 4.
Yes, sir.
Hold. Laser ready रखना. Keep the laser ready, please. Gauze. Okay, leave it.
Sir, if you could talk us through what you're doing.
Sorry?
Could you please talk us through what you're doing?
Yeah.
Yeah.
So, again, this is the external element which I have picked up. As I said in the last case, we will mark out the hemorrhoid which we are supposed to excise first. This is the anodum again. I'll try and make like a dumbbell shape incision. Hold this. This one. This is the sensitive anodum there.
Yes, sir.
So excise as little as possible. This is the internal element which is huge. So we'll engulf the whole thing. There's the pedicle over there.
So you're deepening your incision up to the pedicle.
Yeah. You merge it till the pedicle. Okay.
Yes.
Once you have marked the incision, then you can do the dissection. You will not go drift from the point of your marking, you know. Blood किधर से आ रहा है? Sure. There was some trickling which was spoiling our field, so I'll just put in a gauze there. Hold. So this time we have not used the adrenaline. This is what happens with all the proctology cases. They get operated at the fag end of the day.
And you forget the steps.
When everybody is tired and wanting to go, you know. Hold.
So for the benefit of the postgraduates, when you inject the adrenaline, what is the measurement? What is the proportion of adrenaline? How much do you dilute it?
I usually use the prepared xylocaine with adrenaline solution.
Okay. How much?
You know, around 20 cc all around the ring, like a ring block which I just showed in the Fisher case, you know.
Right. And exactly where do you inject it?
And we mix around 20, sometimes we mix bupivacaine also in that, so that there is post-operative analgesia with the same thing. Can you see the internal sphincter here?
Yes, sir, we can see it. Yes, sir.
It just reflects the tissues above that and the muscle down, right?
Right, sir.
Hold like this. Hold this. Somebody mop. Hold. Gauze pieces. Yeah. So this is the internal sphincter which got reflected, right?
Yes, sir.
Hold. Where is the other end? I think the pedicle got.
I think because you tied the pedicle right at the beginning, the dissection plane is also very clean.
Comparatively, yeah. But it is never completely bloodless, you know, that is the
Right.
problem. Mop. Where is the other end? Ah. Take it up. No, no. Keep it like this. Just retract here.
So we'll go back to Dr. Maiti for
Yeah,
some
please.
time.
No problem.
Yes, thank you. We'll come back to you.
Yes.
Dr. Maiti, we are with you now.
Actually, the problem is that it is because of the too much fibrosis at the anal orifice, the proper retraction to reach that area was very difficult. But somehow we could open the intersphincteric space. But because of bleeding, I have given some pack and will wait. In the meantime, I am trying to. Roller goes down. So this pack is given to the intersphincteric space. From the wall, there is some amount of bleeding. So we have to achieve the hemostasis first. Huh? Bandage, it is bandage. মোটা ফুটার করছে মোটা চাই মোটা
Sir, your video is on. We'll switch the audio off and we'll be watching you.
Yes, yes.
But we'll talk to Dr. Agarwal in the meanwhile. OT2 audio, please.
ব্যাস এই থাকলো এটা এবার হচ্ছে আমাকে এই দাও ওই
Dr. Agarwal, we are back with you.
Yeah, yeah. So normally I take two sutures. One was the initial one which I turned, and the second is the one which I am just taking. Get it down. Mop. Yeah. Scissor. Sure. So this is the hemorrhoidal tissue. This is where Milligan-Morgan ends. Now this bleeding from the edges and all, they can just stop when you take the, close the wound, you know. So that is how the pedicle gets buried. Pakdo. Cut this. So don't waste too much of time trying to catch the bleeders, especially from the edge, because they will anyway get stopped when you suture the wound, right?
Right, sir. But the thing that we have to be sure of that there is proper hemostasis at the deeper level.
Sorry, ma'am, I can't hear. There's a lot of disturbance inside also.
No, what I said is, as you said, that these edge bleedings will stop when we close the skin.
Yeah.
But what we have to be very cautious and sure about is better absolute hemostasis at the deeper level where you are tying the pedicle and cutting off the hemorrhoidal
Yeah, that
mass.
when we tie the pedicle, we see, no, we have taken 2 sutures there.
Yes, sir.
One cannot take chance at the pedicle.
Right, sir.
You are right, yeah. Never. Cut. Jelly. So, gauze piece. Alice. So if you find any such kind of oozer, you'll have to take a suture over it again, right?
Right, sir. Right, sir.
It's already stopped to a large extent, but दबा के रखो इसको. You can see it stopped, right?
Sir, I think your head is coming in the way.
We'll watch again later on. So this I am going to do laser now for demonstration of laser.
Yes, sir.
Jelly. Jelly. So the first step is to feel the pedicle. Ice pack ready karo. Yeah. Feel. Here on this side. More towards 4 o'clock. Yeah? Can you feel the pulsation? Yeah, this is the terminal branch of the hemorrhoidal. There are 3 terminal branches, right? 4, 7 and 11 where the primary hemorrhoid erupts. So, if you find more pulsations, you tie them also, right? But these 3 places definitely, chodo. Hold it like this. Yeah. Forceps. Something wrong. So the pile mass has also got engulfed in this suture to some extent. Chodo. Cut. Wait. Yeah, it's quite. This will become something like an underrunning, you know. Can you hold this? This, okay, tighten it. See that? Take the gauze on this side, no? Anybody does anything differently here for hemorrhoids?
Sir, as far as the open hemorrhoidectomy, I think we all follow the same principles, but all of us, we don't have much exposure to laser.
Okay, that's why I'm decided to show laser at the other two hemorrhoid actually.
Right, sir. So it will be a good experience for us to see you do it.
Really. I could have easily done hemorrhoidectomy at the 4 o'clock also.
Yes.
But because we already did it in the other case, I thought I'll show laser. Hold it like this, huh? Again, feel the terminal branch. Yeah, I can feel it at 11 o'clock position. Now, as I was telling you in the last case, if you hold the needle holder in your thumb and the finger, it will become difficult to turn. So hold it in your hand like this, you know. Wait. I think today is not my day. There are always bad days in everybody's life, right?
Sir, while you achieve hemostasis, we'll go back to Professor Maiti for some time.
Yeah, please.
OT1, please.
Dr. Samita?
Yes, sir, you're
Am I
with
audible?
us. Yes,
so
sir, you are with
till
us.
now, what we have done, just we approached the intersphincteric horseshoe abscess through the internal opening. We placed a probe through the internal opening up to the intersphincteric tract, and around the probe, we dissected the mucous membrane and cored the proximal part of the internal tract up to the intersphincteric space. Okay?
Right,
and
sir.
Then there we could found some granulation tissue, and we could enter left side as well as to the right side. Okay? And in this side, we tried to push the dye through this tract so that it comes out through the internal opening, but as the space was very big, it was accumulated and that was leaking through this opening. So what we have done, as the lateral part was in the form of an abscess, we plan for a wide drainage of this abscess through this opening as well as through this opening. Initially, we thought we can make a further widening through this part, but we found, and we found that this part is going, but this part is going deep to the muscle fiber. You see the muscle fiber. That is the continent part of the urethra. So, and also the perineal body. So you see this tract, Manas, put your hand there, through this tract.
So are the two tracts communicating?
Yes, yes,
okay, they
communicating, but deep to the muscle.
Deep to the muscle.
So
Okay, yeah.
we plan to put, we scrape this area, and we have planned to put a draining set-on through these two openings. Okay?
Okay.
Draining set-on.
So what are you planning to use for the draining
Draining
set-on?
set-on, initially we planned for your wire, but now we have planned to place a Ryle's tube, baby Ryle's tube, number 5 Ryle's tube. This one.
What wire? You said you usually use a wire.
Wire. But sometimes I place your ligature like ethylone.
Right, sir.
Sometimes the wire.
Because we commonly use number 1 proline.
Proline
Yes.
it can be used.
Yeah.
We use the ethylone also.
Sir, considering the fact that you said there was an abscess there, is there any role of putting a Kharsutra there?
I have no experience about Kharsutra.
Okay, sir.
But Kharsutra is, that also helps in draining. But there is some chemical. They say that this chemical helps to cure, at least some mechanical, chemical effect. But I have no idea, experience about Kharsutra.
Sir, we'll go off you for a few minutes. Dr. Agarwal is going to apply the laser. So we would like to take a look at that and come back to you.
So this is the mucocutaneous junction here, right?
Yes,
This
sir.
whole thing. I'm going to puncture it from here. I am inside. I have gone up to the suture mark there, right?
So the suture that you applied prior to inserting it, that's the same
right.
suture.
Yeah,
yes.
with that suture DGR ligated which we did.
Yes.
And then just press the button, apply the laser.
Sir, is
turn-
there any setting that you would recommend?
Yeah, last case we just said 3 pulse and normally I use 6 in the laser training. They are using the 8 watt current, you know.
Okay.
So slowly you keep on withdrawing. You don't even expect it to shrink on table, right? Just apply the energy and come out, right?
Could you repeat that, sir? It wasn't clear.
So puncture 3 second 6 watt pulse is the current required and not more than around 180 joules in per pile mass.
Okay.
Right? And nobody should even dream that it will shrink on table immediately. It does take some time for the effect to occur, the fibrosis. The laser also act by, one is dearterialization, second is creation of fibrosis in the submucosal plane, right?
Right, sir.
Hold this. The same thing here.
So after you've withdrawn the laser needle, is it necessary to apply any compression at that area?
We apply ice pack, no ma'am?
You apply ice pack, yes. So the needle
man
tip,
and the
laser
machine
tip should
keeps
go
on
up.
morning. How much is gone?
Sorry.
Total, no? 140, yeah.
So the laser tip should go up to the level of the suture that you've applied.
Yes. Fine. Hold this. चश्मा निकाल लो. We'll keep this for some time and check the hemostasis at the end again before we put the ice pack. Ice packs are ready. Is the ice pack ready? So normally what we do, we cut the glove finger, put water into that and keep it into the deep freezer, so that this becomes a ice finger, what we call them.
Okay, okay. So how are you going to customize it here?
So they have given me this bottle. They opened the bottle. Can you see this?
No.
So you didn't?
Yeah, no, the camera person, can you please show what sir is demonstrating?
So the entire bottle was kept into the freezer, so it has become a shape of a bottle. We are going to break it and we are going to use the cold water which comes out of that and pack it.
Isn't it a bit too big?
No, I am not going to insert the whole thing. I said we will break it. Either you didn't hear it or you are trying to pull my leg.
No. Just try to lighten the situation end of the day.
I understand. Yeah. And I require it more than anybody else today. Just going to remove and have my final check. So no bleeding at the point where we did the hemorrhoidectomy, right?
Yes, sir.
Okay. No bleeding at the 4 o'clock position.
Is there a bulge there persisting?
Give me a gauze, please.
Yes.
Give me a gauze. Nothing, ma'am.
Is there another hemorrhoid at say 2 or 3 o'clock?
No, this we have already ablated actually.
That is the ablated one. Okay,
yeah.
Okay, right. Yeah.
The shrinkage will show later on, ma'am. And this is the 11 o'clock one.
Yes, that's okay.
No bleeding here either.
Right, sir.
Right?
Right.
So all that ends well is all well, should be considered well.
Yes.
So can I get the, are you going to give me the ice packs? Yeah, you have this, right? So you can go back to Dr. Maiti if you want, because we only have to just put in this pack, that's all. So I once again thank the West Bengal Surgical Association for calling me today, and again I extend an invitation for all of you to come and join us for Asicon Mumbai. Where is the ice?
Sir, we thank you for agreeing to come over here and enlighten us.
So
and yes, a
always,
lot of us will be in Mumbai next month.
Thank you so much. That's really very encouraging.
Just one last question for you, sir. The ice pack that you're applying, how long should it be kept?
So this will come, basically the ice melt within 20 minutes. When we put the glove, it slips out. Here, because we don't have the cut glove over here, so it can be pulled up after 20 minutes. There's no problem.
Okay, sir. 20 minutes.
Yeah.
Okay. Now, if you had your ice fingers like you normally do, how long do you keep it?
It comes out after 20 minutes.
It comes out. Okay.
If it doesn't, my staff pulls it out.
Okay.
So that's it. Nothing more to be done except the dressing over here.
Regarding the position of the patient post-operatively, the normal supine position that we use
Yeah,
in
yeah,
hemorrhagic-
absolutely. Nothing abnormal. In fact, many of our cases we do under local, so they even get up within few hours, you know. They can go to the bathroom also.
Okay.
Those who are under saddle block, we never do it under spinal. Those who are under saddle block, we try to keep them supine as much as possible, but if they don't pass urine, we don't hesitate to make them sit and stand after checking their blood pressures.
Right. So when we do a standard open hemorrhoidectomy, the main complication that we are apprehensive about is bleeding. Now, when you're using a laser, is there any other complication that one should look out for?
The most important complication in hemorrhoid surgery, I don't even call it complication, it's a consequence of any surgery, is the post-operative pain. right?
Right,
And
sir.
most patients are worried about getting surgery done in the sensitive part because of the pain. So when you use a laser or you use an MIPH, the incidence of pain is much less compared to an open surgery. There's no doubt about it. Only thing is, in the higher grade, the recurrence being more, you need to explain to the patient. The patient with a poor background or those who can't afford multiple surgeries, subjected to a complete hemorrhoidectomy in the first go itself. But those who can afford and those who are educated, those who can follow up and want to go back to work early with their proper consent, you can offer them a minimal invasive proctology procedure like laser or IPH. As I said that. The second most important for one thing is don't keep very heavy packs over there. You can inject local anesthesia at the end of the surgery. Some people also use methylene blue locally injected for some relief of pain. And in the immediate post-operative period, again during the surgery, don't use very heavy suture material or don't use suture. Those are all things which are going to cause a lot of pain. So one must suture without tension, use only 2 or 3 kind of a vicryl, do not pack, and inject local anesthetic agent. In the post-operative period, of course, you require analgesics for all these patients. And there are evidences to suggest that use of metronidazole ointment or use of sucralfate ointment helps in faster wound healing and therefore they reduces the pain in this kind of patients. Try and prevent constipation or fecal impaction in this patient because that is another cause for pain in the later part of the post-operative recovery period. The immediate another complication which is more worrisome other than bleeding is the urinary retention. Now most of these patients who get into urinary retention, either they will have a prior history of lower urinary tract obstruction which needs to be evaluated completely and treated accordingly. But all of us practically, other than a few percentage, do these kind of cases under spinal anesthesia. And that is one reason why they go into retention. And as soon as the spinal is given, there is a fear there will be hypotension. So the anesthetist also infuse a lot of fluid during the surgery itself, So try and do them under local if possible or saddle and minimize the fluid given during the surgery. You can always monitor the BP and accordingly give it. And the another cause for urinary retention is a large pack which most of us are used to put. So don't put any pack and don't give too much of fluid in the post because you can feed the patient in some after 2 hours or 3 hours immediately after surgery. So there is no need to push so much of fluid. Only monitor the BP, that is more than enough. And give them adequate analgesia so that the spasm which occurs, spasticity in the post-operative period is also prevented. The third most important complication is hemorrhoid, bleeding. It is not the first or the second one. So bleeding can be immediate intraop, it can be immediate in the post-operative period, or it can be delayed hemorrhage in the 10th or 14th, there we call it a secondary hemorrhage. Now the primary hemorrhage are usually because there are some technical problems during the surgery where you have not tackled the hemostasis properly or not cauterized the bleeders or tackle the bleeders adequately. So it needless to say that intraoperatively before you come out, you should always check that the hemostasis is complete and then come out. And do not keep a pack, but a small gauze can be kept to see if there is any bleeding. The wick can show the blood coming out which can be tackled. And the secondary hemorrhage usually are due to a passage of a hard stool or an infection where the granulation tissues get infected. So try and avoid constipation in the post-operative period. See to it that even there is a hard stool which causes rubbing of the granulation and that is what causes bleeding. So if there is a secondary hemorrhage, check if it is a smaller amount or a large amount. Small amount can be conserved very well, observe. And if it is a large bleeding, then you need to bring the patient back to the OT and see whatever is bleeding needs to be tackled accordingly, either some pressure or some local adrenaline injections or maybe cauterization or underrunning of the bleeding site. So these are the few important complications which occurs after hemorrhoid surgery and this is how they should be tackled.
So last question, your choice of analgesic in a patient undergoing laser hemorrhoidectomy.
So the initial 48 hours I do give them a diclofenac containing medications because that is the time when they get maximum pain. And after 48 hours, most of them do not require that strong analgesic. So I shift them to paracetamol 650 milligram 3 times a day for the next 3 days. After that, it is only an SOS. Those who require, they take it. Those who don't, they don't take it.
Thank you so much, sir. It was indeed a wonderful experience. Thank you once again. We'll go back to Professor Maiti in the other OT.
Thank you, ma'am.
Thank
I
you.
am obliged indeed.
Thank you.
Bye.
Dr. Maiti?
Yes, yes.
Sir, we are back to you.
Yes, yes. So almost we are at the end of the operation. So what we have done, we have made the internal.
Sir, we cannot see actually, your head is
I'll just
obstructing.
tell you. So what we have done up till now, we have traced the internal opening and the proximal tract up to the intersphincteric space, and we have made deroofing of the intersphincteric space abscess, and after deroofing we could trace the tract both laterally and to the left, and at the same time we found that this region there was a wide tract communicating the tract at the 4 o'clock position and the tract at the 12 and 1 o'clock position. So instead of scraping the tract, we thought we have to make proper drainage of that abscess cavity. There was actually abscess. You have probably noted that pus was trickling through the opening. So we made free drainage of the tract. And what we found that we could not communicate the two openings by incision, thorough incision, because forceps thou.
Sir, are you putting a set on?
Yes, yes. And we found that this.
Sir, are you putting a set on?
Yes, I will coming there. You see, this tract is passing deep to the sphincter muscle, and that includes the transverse perineal muscle. You see, if I cut this muscle, that will.
Cameraman, please focus.
If we cut this muscle, then that will cause disturbance to the sphincter of the urethra as well as that of the anal sphincter. So for that reason, we did not divide this tract. We kept this tract, and this tract was passing like this, you see. And here is the sphincter muscle. So there is a deep abscess, deep to the muscle, and we drained it. It's a wide space, so it will drain in the postoperative period. It may be kept for 10 to 14 days. And at the same time, you see, now I will show the intersphincteric space. So I will just show you the intersphincteric space. That is a deep cavity. মানুষ দেখা ওটা ওই জায়গাটা এখানে একটা রিট্রাক্টর লাগাও আর একটা রিট্রাক্টর দাও ল্যাঙ্গেন ব্যাগ আরেকটা ল্যাঙ্গেন ব্যাগ দাও এটা একটু উইথড্র করো ইয়াস একটু বের করে নাও ওটা মানুষ ওটা বের করে নাও ওইটা বড় ডিভাইসটা বের করে নাও ইয়েস এবার একটা ছোট আরেকটা ডিভাইস আছে কি আরেকটা ইয়ে আছে কি ল্যাঙ্গেন ব্যাগটা দাও বা তোমার পিনারটা দাও ওইটা দাও ইউ সি this is the space. Can you see the space?
Yeah, sir, your head is actually obstructing us.
Now it is okay. Is it? Can you see? মানুষ তুমি এটা ধরো এইটা
Now we can see. Yes, we can see now. Just a minute.
Can you see now?
Yes.
So this is the space, deep space in front. I am pushing the posterior wall of this. মানুষ থাক করো এটা ফোকাস করে একটু লাইট ফেলো. So this is the deep space. The wall is charmed with diathermy to achieve hemostasis. And you see there is another seton which is communicating. This seton is passing through this tract to here. Oh, একটা দাও আর্টারি ফোরসেপ দাও এটা একটু ধরো মানুষ লম্বা আর্টারি দাও and you see এটা ধরো একটু and this seton is yes see this can you see the artery forceps?
Yes, we can appreciate, sir.
So this was the intersphincteric abscess, and through it, to it the main communication was this space, that is a abscess outside the external sphincter, and that abscess has multiple opening here and here. So we have drained the external abscess through incision as well as by seton, And we have drained the intersphincteric abscess by deroofing its wall and as well as excising the internal opening and proximal tract. So basically all fistulas are the chronic abscess. Proper drainage of the abscess will actually help in healing. And in this abscess, only the epithelialized portion of the tract is the internal opening and the portion of the tract leading from the internal opening up to the intersphincteric space. Even the intersphincteric space is not epithelial lined. So we have excised the epithelial lined portion of the tract and we have drained the abscesses in the intersphincteric region as well as the abscess which is outside the external sphincter, and thus arrange the Satan's den. Thank you. Any questions or any comments or any query? Now we will pack this space with betadine and lignocaine soaked roller gauze, plain forceps now, plain forceps.
So I think we have a very good experience learning how to tackle such a complicated fistula.
And I ensure you,
draining off the intersphincteric space, whereby excluding the cryptoglandular infection, which is the source of infection, as well as we are draining all the intersphincteric, all the fistula's tract at the same time by putting a Satan. So sometimes we need to decide how to tackle such a complicated fistula.
So one thing, basic thing we should be aware of, that we should not be worried about the external tract. One thing, main worry is that whether we will be successful to find the internal opening or not.
Yes, sir. So main thing is the take-home message is actually the main part of the fistula that must be drained is the intersphincteric component of the fistula. Okay. Isn't it?
Yes, yes. And another thing, in this operation, what we have followed, we followed the internal drainage of the intersphincteric abscess.
Yes,
and sometimes some surgeon may prefer the closure of that opening after proper drainage, after scooping, or after curating, after using laser of the intersphincteric tract, they like to close that tract.
Yes, sir.
But we do not prefer to close the tract, because even we close with suture material, in this side the chance of infection is very high. That suture will not stay. Rather, the closing and accumulation of the serum within the tract beneath the suture will cause pain, and that may lead to an abscess. Then that may not be of cryptoglandular origin, but that may be a chronic abscess, and that may take long time. But if there is arrangement for internal drainage, I think that will be better. One demerit of this technique of not closing the opening or rend which is created is the hole. If the patient palpate the rectum, if he introduces his finger inside the rectum, he may palpate a groove, a pit inside on the posterior wall, and that he may be worried, what is that? But we should tell the patient at discharge there will be a pit during your cleaning of the anus, but don't be worried, and that will gradually fill up. I have to gauge them. Sandeep is there? Any query? Tomal is there?
No, sir. It's an excellent demonstration. We think we should end here today. I am requesting Professor Sudev Shah to conclude today's session.
Well, firstly, Shukumar da, your operation was great, and as a faculty, you helped us through all those difficult, actually most of the cases you did were very difficult ones, complicated fistulas. শুনতে পাচ্ছ শুকুর?
হ্যাঁ শুনতে পাচ্ছি। And actually this technique if you follow, I hope the postgraduate student will follow, and they should not be afraid of horseshoe fistula. Horseshoe fistula is one of the easiest operation of horseshoe fistula, because in horseshoe fistula the internal opening position is almost fixed, but in other it may not be. Okay, continue, Sudev.
No words are enough to thank whatever you have done for us today. Even after so many years after retirement, your skill is, I think, gradually improving. So that is all I have to say.
And I love to do fistula.
So many thanks for coming. And this thanks comes to you right from the West Bengal State Chapter as well as from this department at NRS Medical College. I think from now, since the operations are over, I would like to thank all the members who were witnessing this operation from far and wide. And thank you all for being with us.
Normal.
And now we
better
will gradually close. So this was the last operation. And now this audiovisual transmission will close. Thank you all.